Okay, chronic myeloid leukemia is a clear kind of thing, presentation. Big spleen is almost synonymous with chronic myeloid leukemia, at least from our training days, but you also know that other conditions like Al-Azhar and others present with massive splenomegaly next. Now, history goes back to 1845 in Edinburgh and also in Berlin when two eminent pathologists described this condition. Hughes Bennett and Rudolf Virchow, and in 1872, Ernest Newman actually did confirm that leukemia cells originated from bone marrow. And it was rather quiet until the year 1961, when in Philadelphia, Peter Noel and David Hungerford did notice that in all patients with chronic myeloid leukemia, one of the small chromosomes was always smaller than expected. And in 1973, Janet Rolle then did indicate that there was a translocation of that piece of that chromosome, that this was actually chromosome 22, which had lost a piece to chromosome 9. And then later it was discovered that was indeed an exchange of chromosome material. And in the 1980s, the BCR ABU translocation was described next. Next slide, please. Yeah. We have, in our center, we got 380 patients, and they got symptoms presenting complaints, and the commonest was abdominal complaints, non-specific symptoms, and I want you to look at the impaired hearing, impaired vision, and priapism, which are rare presentations, but which are also devastating presentations, and then tinnitus also occurs next. Now, a patient comes with these symptoms. A lot of them are vague. They are not clear, except for those who come with a big spleen. But then you have a suspicion, even that big spleen is not always chronic myeloid leukemia, so you have the laboratory workup, and you look at the peripheral blood, you look at the bone marrow, and then you look at increment in all the myeloid cell elements, and then you get marrow hyperplasia. Then you go to cytogenetics, you do karyotyping, and then you do FISH. Then you can go to the BCR ABU PCR. Now we don't always run through all this because we are cash constrained next. Now the accuracy, of course, increases with and the specificity with the increment in the more complex tests next. So, chronic myeloid leukemia has been treated over the years differently. When I started my medical school, the main drug was busulfan, and then later when I postgraduate, we were using hydroxycarbamide. Other centers which had better money were using interferon alpha, and autologous, allogeneic bone marrow transplant really was the only modality that gave you any chance of curing this disease. During those days, survival was 3 to 4 years, and then the disease transformed to accelerated and blastic phases. And then from this, it depended on whether you had myeloid transformation, which had survival of about 3 months, or whether you had lymphoid transformation, which went on to about 6 months next. Now the exchange of that chromosome material is depicted there, the 9 and 22. The Ebuson oncogene site that broke on the chromosome 9 and the BCR gene on chromosome 22, and then they got stuck onto the chromosome 22, formed the Philadelphia chromosome, and that is what was initially noticed. Next. And the BCR-ABL oncogene then coded for that protein product, and in the signaling pathways, and you have the various signaling pathways leading to migration, proliferation, and cell survival. one of the signaling pathways is not depicted there. That's the hedgehog pathway is not depicted there. But these are basically the main signaling pathways of BCR-ABL that make it leukemogenic. Next. Next, yes, sorry. Now the mechanisms of action, no, sorry, I think we have skipped a slide. I think we have skipped a slide. Go up. So now the treatments then improved, and in the 1980s and beyond, Brian Drucker, then at the Dana-Farber Cancer Center, started looking at tyrosine kinases. Of course, this is after attending lectures and reading papers, and the main paper was by Alexander Levitsky that did depict that EGFR inhibition could be used to inhibit cancers, and then Brian Drucker got interest in tyrosine kinases, and then he did actually go into the laboratory, and when he moved to the University of Oregon, they worked with a team that then they developed imatinib and did clinical trials, and by 1999, 2000, they did actually indeed confirm that this was a new treatment that changed the outlook of leukemia. Now, in 1996, there was Pat Garcia Gonzalez, whose son Maximilias had died from chronic myeloid leukemia, and she formed a foundation, and that was helping people access treatment. She said nobody should die of leukemia because of lack of money. So when imatinib was developed, the Glyvec International Patient Assistance Program then was put in place to help access drugs to patients in low and high and mid-income countries, various countries, including India, Pakistan, Kenya, and the rest were involved in this particular program. Go to the next slide, please. Sorry, getting stuck. Okay. Now, of course, this just shows you the BCR-ABL, the ATB binding pockets where imatinib binds and knocks out its tyrosine kinase activity. Next slide. So, before tyrosine kinase inhibitors, of course, the treatment of chronic myeloid leukemia was based on the drugs that I have mentioned, and the risk scoring was done mainly by the SOCAL score. And this was based on patient's age, spleen size, and the percentage of blasts in the bone marrow. And as you can see, the higher the percentage of blasts in the bone marrow, the bigger the spleen size, the poorer the outcome. And the survivals were not really very great. Next. Now, after the development of imatinib, you can see now how survival has improved. Patients who are on busulfan down here, patients who are on imatinib, and in between hydroxyurea, cytosine, arabinoside, bone marrow transplant, the survivals were not as great. So imatinib then revolutionized the treatment and outcome of chronic myeloid leukemia. Next. And this again just shows you the pre-imatinib survivals and the survivals during the time of imatinib, and of course the other second and third generation tyrosine kinase inhibitors. Next. Sorry. Now, so in 2001, the Glyvec International Patient Assistance Program was founded to assist patients, as I mentioned. Now, clinics were set up, and in our country, the first clinic was set up at the Nairobi Hospital, and then later on one at the Aga Khan University Hospital. And we have been running this clinic. I joined in 2005, And since then, in 2021, the government came in and since has been decentralized regional areas. Next. Registry then we established last year to describe the CML disease burden in Kenya and to inform policy and planning. Next. Next slide. Sorry. This is just a picture of the Nairobi hospital, part of the Nairobi hospital where the clinic is running. Next. Now during COVID, because we ran this as a team, and during COVID, patients then were not coming. So what we did was we took the files, they sent us blood results. We looked through prescribed as a group, and then sent it prescription to pharmacy. Pharmacy then organized and couriered the drugs to them in the various places. And so people did not actually miss their treatment during the entire COVID period. Next. And this just shows files, the team looking at files, looking at results, prescribing, sending to pharmacy, then pharmacy couriers it. Next slide. Now, the treatment of chronic myeloid leukemia, we have several drugs now, and you want to decide which one. Clinical trials looked at the superiority of one after the other, but these were mainly compared with imatinib, nilotinib, the ANES trial, Dasisio trial, dasatinib, and bosutinib. Now, the first one that proved that you could get, actually, if you started, particularly in the high-risk patients, you started with the second generation tyrosine kinase inhibitors, you got a deeper and a faster molecular remission, was the ANES trial, which tried nilotinib. These other two, Dasisio and before trial, actually did not confirm that, but this is now assumed from the ANES trial. So we then, centers have then decided to risk score, and the ones that look to be at higher risk, then you start on with the second generation tyrosine kinase inhibitors. Now, choice of therapy also considers achieving and maintaining remission, delaying progression to accelerated and blastic phase, which are very dangerous, maintaining quality of life, because these drugs also have their own side effects. And then there's something now we are looking at, that is treatment-free remission. Next. So now, selection of first-line therapy in chronic phase has been dependent on the score. SOCAL score, there are other scores like Hasford, UTOS, and the rest. But the arithmetic involved in SOCAL score, I don't believe many centers, unless in clinical trials, are using this score routinely. Comorbidities, cost of therapy, adherence, and goal of TFR. Now, cost of therapy for us is zero because these drugs are supplied free except for nilotinib. Next. Now, tyrosine kinase inhibitors, dosing and toxicities here. Again, what you consider a patient who is going to be on imatinib, you look at all things, including fluid retention. Diarrhea is said to be there in the books. In the publications, we don't see patients with diarrhea, maybe an occasional one on imatinib. Dasatinib, the effusions, again, we have patients, I haven't seen much trouble with effusions. Nilotinib, which is sold, again, the cardiac comorbidities need to be taken care of. Bosutinib, that causes serious diarrhea. So we actually start with a low dose and go up. If you start with a standard dose, the patients will not tolerate it for more than 2 days. Next. Now, CML treatment in Kenya, as we are saying, no risk scoring. All our patients, unless there is a very good reason, are going to start on imatinib. And then we have when imatinib fails or cannot be tolerated, then we go over to dasatinib. We can use nilotinib, bosutinib. Now we have, if they go straight into an accelerated phase, then our second line is ponatinib, which is also available to us for free. I think we are lucky on this. And then we don't have omacetaxin, radotinib. We don't do allo transplants, but now there is the auto transplant has started. Asciminib has just been approved and is being used in the United States. I'm told it's so expensive you can't afford it outside the United States. I don't know whether centers in Europe and Asia are using it next. So you want to monitor them, and these are the levels: complete cytogenetic remission, major molecular remission, and then if you go to MR4, MR5, and MR4.5, those who are reached the 0.0032 BCR able percentage have done very well. Even those who are in MR4 have done very well. And if you are looking at treatment-free remission, we have a project now looking at TFR, and we are looking at those in MR 4.5 who have sustained for at least 2 years. We are putting on TFR. Next. So this just shows you the resistance to tyrosine kinase inhibitors. You have various BCR-ABL gene amplifications, increased activity and expression, alternative pathways, and then you have the non-ATP pocket binding site that is now being used for asciminib, that is an allosteric kind of site. So this is a different mechanism, and combined with the ATP binding pocket inhibitors, now that has revolutionized again resistance approach. Next. Now this is just again the sites of resistance, and the T351I pocket is there that is resistant to almost all tyrosine kinase inhibitors except for ponatinib, and now asciminib is defeating that because of the site, different site of binding. Next. Now, so in the registry, we looked at 1347 patients, and the mean patient age was 44.1 years. This is much younger than what you see from outside, where some say 50, 60, some even go up to 70. I don't know the experience of the rest of the panel. The majority, of course, were adults, males. So there's always a slight male preponderance. But again, this preponderance, if you look at almost all hematological malignancies, the ratios remain just that: lymphoma, myeloma. For some reason, you go and look at your data, you will be surprised that it's almost fixed within a margin of error. Next. Now, that just depicts for you the males and the females. Next. Now, the first line, as I said, is imatinib, and this is just the occasional patient. Did they need to be switched to second line? Yes, 206 were switched to second line for various reasons. Those who couldn't tolerate pain, the cytopenias, which give us a lot of problems, and others, and of course those who are transforming. Next. Now, the dasatinib was second line for the majority. It's easier actually to administer dasatinib. I haven't seen those effusions among these patients. Ponatinib for the occasional patient that moved straight away almost from chronic phase to accelerated or blastic phase, we used ponatinib on. And what are the outcomes? The transformations that are written there, yes, at 26, I think we missed some. I think the number is larger, but those, again, deaths at 11, again, there were some which were missed, but the registry, the number is larger. But you can see those who are alive at 1151 after several years of treatment. Next. And if you look at 5 years retention, it's almost a straight curve. Next. And if you look at a longer term, you have, at 13 years, you have almost 70% retained, something that was not there in the pre-imatinib era. Next. Now, how about, we are looking at possible cure, and indeed there is a possibility that CML may be cured by these pills. And so we are now looking at those who have received TKI for at least 3 years, with DMR at least 2 years. We do close monitoring. The close monitoring done in Europe and North America, we can't afford. I mean, this idea of every 3 months or initially every month, there's nobody in our country who can afford that. And we find that even without that tight monitoring, we still have fairly good outcomes. Let's go to the next slide. Of course, those who have been put on TFR, anxiety, they keep going to see the doctors. The TKI withdrawal syndrome, some of them get very severe pain and stiffness. In fact, they start may be getting very severe pain and stiffness. On imatinib, you can do all the scans in this world and see nothing. But then again, when you stop imatinib, they're back again with those pains. So it can be very confusing. Next. Sorry, next slide. So now we looked at the results of one gentleman we started treating in 2010, and his BCR able, because we do quantitative PCR from the beginning, because we can't afford to go to banding and all those things. I mean, it's too expensive for us. So then we started, this is how we went, and he started developing edema and he pleaded not to be treated. So we stopped treatment, and then he started progressing, and we restarted treatment again, and then he did well, and he said, now let us stop. We stopped again, and then in the year November 2021, he started progressing. Then he agreed this time that treatment be stopped because he knew that he can actually get some cell sleep and he goes into blastic phase. And that will be serious trouble for him. And again, now these are the latest. So those who are destined to do well will do well. Next. Sorry. Okay. Thank God I was not holding it, because if it is stuck in your hands, it's very, you get very anxious about the whole thing. Eh? So current trials to cure CML, survival by patients, it's not that they are like survival like anybody in the general population. They're still less. So there are attempts to cure CML. And as I said, asciminib has come in place. And ruxolitinib, which is Jakafi, which was used at the JAK2 inhibitor, is also being tried in combination with BCR-ABL targeted tyrosine kinase inhibitors. But others are now being tried, like chimeric antigen receptors and the bispecifics. How far they will go in the area of CML is not very clear in that area. Next. And then, so in conclusion, CML used to be a uniformly lethal disease within 36-48 months. Development of imatinib and the other tyrosine kinase inhibitors has changed, clearly changed the outcome of this disease. Now if you are told you have a patient with CML, you smile because they are going to be with you for a long time and they will be very happy with you. There are still patients who suffer from adverse events and stop or change therapy, or those who outrightly fail treatment, those who fail treatment, give us some trouble. GPAP, this is the program, the Glyvac International Patient Assistance Program. Now the Merck Access Solution has greatly enhanced survival among patients in resource-poor countries who otherwise could not afford these state-of-art treatments. And TFR is an effort to see those who may achieve cure and may go off therapy, and which may save costs also, all those who cannot tolerate the medications and need to be taken off therapy together. Now this tight monitoring, as I said, what it looks like is those who are going to do well will do well, whether you monitor them every day or not. Those who are going to do badly will do badly. And this is in hematological neoplasms or under the cancers, breast cancer, lymphomas and the rest. All of you, I think, have seen this. Next. So I want to acknowledge this and stop my presentation from there. I hope I did not rob you of minutes, and thank you very much for listening.
Good morning, everyone. So we'll shift gears to the therapy of solid tumors, the lung cancer. So just to tell you that most of the data, there's a lot of data as we know in targeted therapies in lung cancer, but I'm going to restrict to the work that we have done, because that will be, you can correlate it in most of the low and middle income countries. And my colleague and Dr. Kumar Prabhash, who is head of the medical oncology department, I acknowledge that he has provided me with most of the slides that I'm going to use. So as we know, actually in oncology we have done really well in some cancers. For example, in breast cancer, there's no pointer on this, no? So as you know, in some cancers, like the breast cancer, we have really done well, and the outcome now is more than 90% in most of the breast cancer patients that we see. Even in colon cancer, we have done well. But until recently, you know, cancers like the lung cancer, pancreatic cancer, we really had not done much at all. But I think slowly, especially for lung cancers, that is changing, and that's what I'm going to show you in the next few slides. So we started with chemotherapy as for all cancers, as we know, and initially we used the doublets, mostly cisplatinum based therapy, but all the doublets that we used, whatever we used, the median overall survival was around 8 months. Not only that, we changed cisplatinum to other drugs also, various other combinations we used, but still the outcome was the same. And even when we added the third drug or the triplet, the outcome did not change. So with the chemotherapy, we were stuck at around 8 months of median survival. Not only that, at Tata Memorial Hospital, we also did something unique actually, especially since we always think about cost cutting, was low dose gemcitabine along with cisplatinum. And again, even with that, actually it was not inferior, it was same, and the median survival again was around 8 months. So whatever we did with chemotherapy, the outcome was dismal in advanced non-small cell lung cancer. And then came the era of molecular biology, and we started profiling our drugs. And the first, you just heard Professor talking about the EGFR mutations. And the first thing that came out was that in many of the lung cancers, we have the EGFR mutation. And that was the era where we started profiling the... Can I go to the next one, please? Yeah. So the EGFR was the first mutation that became known in lung cancer, and even outside reports were coming. Even at the Tata Memorial Hospital, we analyzed around more than 9,000 samples, and we saw that around 23% of our patients had EGFR mutation. Now this was different than what was reported from the West, where we know that around 10 to 15% of the Caucasians have EGFR mutations, and if you analyze the data further, you can see that in adenocarcinoma, the rate of mutation was around 28% as compared to the overall numbers, and in squamous cell it was 3.8%. And again, when we analyze it further, you can see that if you have females and non-smokers, the EGFR mutation rate was much higher at around 32%. And if you see, again, males also, if they were non-smokers, it was higher. So definitely EGFR mutation was an important mutation in lung cancer. And very importantly, again, this test was done in-house. We had developed the RT-PCR was developed in-house, and the cost of doing this test was less than $10 compared to, at that time it was available commercially, but it would be around $70 to $100 at that same time. So this was a very cost-effective thing which we developed in-house in the Tata Memorial Hospital, and this is Dr. Abhishek, a postdoc who did this study. And again, at that time the drugs were available. The first drug, as we know, gemcitabine, gefitinib, was available for treating patients with EGFR mutation. And though the data was coming out from the West, even at the Tata Memorial Hospital, we did a randomized study where we did this thing of gefitinib versus chemotherapy, the standard chemotherapy versus gefitinib trial for patients of newly diagnosed patients of adenocarcinoma. This was 1:1 randomization. And if you see this trial, the progression-free survival was much better compared to chemotherapy alone. So definitely the gefitinib worked in these patients, newly diagnosed patients with non-small cell lung cancer with EGFR mutation. And if you see however, the overall survival was no different, and that's because more than 90% of the patients who were on chemotherapy changed or received the oral gefitinib later. So overall, it was not much different. On the contrary, the chemotherapy arm was a little better. But very importantly, you have to look at this. We started with chemotherapy. The median overall survival was 8 months. Now, when we added gefitinib, the first generation TKIs, the median overall survival increased to 20 months. So definitely a good difference in the outcome. And this is our data from Tata Hospital around 20 months. which is nearly the same as what has been was reported from the West, except for those from Japan. As we know, always the Japanese people have really slightly better data in most of the time. And here you can see their median survival was around 31 months. Others were nearly same. So definitely the addition of TKIs improved the median overall survival. And that was the first drug, first mutation. As we know, EGFR was first. But again, slowly there were many, many more mutations which started coming out. And what we did was we wanted to do the full profiling of our patients with lung cancer, non-small cell, not only non-small, the whole lung cancer patient group. And very importantly, again, we developed in-house. It was available commercially, but the cost was very high if you had to do the whole lung panel. But this Dr. Pratik Chandrani, a postdoc from our lab, developed the in-house where we had nearly 21 gene panel which we developed. And this is what we found. This is the data which was available from the West, where most of the commonest was the KRAS mutation. EGFR was around 17%, and these are the other ones. But if you see our data, the EGFR was the highest. Nearly 30% of our patients with adenocarcinoma had EGFR mutation, which was much different from the West. And KRAS was also low from the West. And we found a very interesting, a new mutation, the FGFR3 mutation, which was there in nearly 5% of our patients, which was not reported, at least at that time, from the West. So definitely we could do this at a very low cost compared to, it was less than or around $100 compared to what was being offered commercially from the West. In India, and many of the samples even used to go to the West to get the test done. So this helped us to develop this, not only helped us to know what was happening with our patients, but also helped us to give them the targeted therapies. That was the non-small cell lung cancer adenocarcinomas, and again we thought that was a lot of data, a lot of arguments in the scientific community whether we should be treating a squamous cell patient with TKIs, and it was told that no, all of the mutations are there only in the adenocarcinomas, so we should not be treating the squamous carcinoma patient. But again, when we did a big study of all our squamous carcinoma patients, nearly 2.8 or nearly 3% of our patients with squamous cell carcinoma had the EGFR mutation. This is very important because 3% is not a small number, and even one patient, if they have the mutation, if you give them, they will benefit with it. So this is data from our center, and does it really make a difference clinically? And you can see that those patients of squamous cell who got the EGFR TKIs basically benefited with it, and the outcomes improved. So definitely, even in squamous cell, we have to look for the mutations, because not only EGFR, there were other mutations also. There are many other mutations, which including the ALK, which may be present in them. So it's better to profile every patient with lung cancer if you can do it. And this shows clinically it made a difference. And we talked about KRAS being one of the common mutations, and we saw that patients who had KRAS mutations and the EGFR mutation, again they benefit with the addition of TKI inhibitor. So definitely most of them had partial response, but definitely they also benefit. So even if you have double mutation, if there's a mutation which is sensitive to a therapy, you should be trying that therapy in this group of patients. And this is a very interesting paper. I just put it because why is it important to profile every patient? And this is actually the family of 3 patients in the same family having non-small cell lung cancer. And when we did this, basically it's Dr. Pahuja who did this in the lab, and when they did the whole sequencing of all these 3 patients together, they found that in all these patients, there were in these 3 patients, there were some of the genes, and especially the HER2, which was common in all the 3 patients. So that was okay to do it in the lab, on the sample. But he went back to the lab and studied this patient even in the culture. Actually, he tried to change the cell lines and put these mutations there. And what he found interesting was in this group of patients, in this cell culture where the cells were exposed to trastuzumab, basically there was a significant decrease in our suppression of the growth of these cells, and that's what we did in the clinic now. The first patient unfortunately died, just after the diagnosis. We could not treat, but the next two patients we treated with trastuzumab, and you can see the response to this trastuzumab in this group of in these two patients. We had excellent response, though they later progressed and died. But it's very important. What I wanted to show was that every patient is different, every patient is important, and if there is something you can target clinically, I think we should be looking at it in the labs also. So this patient gave us that confidence that it's very important to profile every patient with lung cancer. And we talk about EGFR mutation, but EGFR mutation is not one single mutation. You can see there are multiple mutations, combination of mutations, common mutations, uncommon mutations. So it's not a single thing, and you have to look at it in an individual patient. Basically, you can see here that there are some common mutations, uncommon combination of mutations. And does it affect clinically? Yes. You can see here that basically there are some mutations which hardly respond to the TKIs, like the median overall survival in this group was 1.8 months, whereas some respond very well. The median survival is 28 months. So there is a range of the response to the treatment, and it's all individual. So you'll have to see what happens to this and develop the other point of the story is that you have to develop newer therapies for these different uncommon mutations. So it all helps clinically to understand the biology, not only the biology, but how we can change the treatment in this group of patients. So that was the first generation TKIs. You saw in CML, we had the first generation, second generation, third generation. Same thing is there even in the lung cancer scenario, and especially after the availability of the third generation TKI, the osimertinib, basically whether it is better, and this is what the data we got. So this is a FLORA double-blind study design where the patient with exon 19 mutation who received either osimertinib or the patients or the doctor's choice of either gefitinib or erlotinib, the first generation TKI, and basically they were followed till progression, and even there was a crossover of this patient. And you can see here definitely the median overall survival had much decreased. I showed you the first few slides where with chemotherapy the median survival was 8 months. With the first generation TKI it increased to 20 months, and now with the second generation TKI it has increased to 40 months. So definitely from 8 we have gone up to 40 using different types of TKIs, but very importantly it has made a difference in the outcome in patients with non-small cell lung cancer with the mutations. But it's not all simple, because osimertinib, the data was there, it was a good drug, but same like imatinib when it started, we knew the drug was so good, but not even 1% of our patients could afford to buy the drug, and the same was with osimertinib. So basically we knew that this is good, but we couldn't afford this. So we thought whether we can improve the outcome of our patients without using the third generation TKIs, and this is the study we did, which again at the Tata Memorial Hospital, where we did a randomized trial of gefitinib versus gefitinib plus pemetrexed and carboplatinum. That means the combination chemotherapy plus the first generation TKI as compared to the TKI alone, and this is what the study was. So basically this is the newly diagnosed patients with advanced lung cancer either received gefitinib plus chemotherapy or gefitinib alone, and this is what the data showed, that basically definitely the progression-free survival and the overall survival much improved with this combination. And at the same time there was even a paper from the West, especially Japan. This is again a Japanese paper where the data is always nearly 8-10 months better than other data which has been reported. But again, if you see this gefitinib plus carboplatin and pemetrexed, the median overall survival has increased to 52 months. So definitely it has improved. So from 8 months to 20 months to 40 months we have gone, and this is again without using the third generation TKIs. With chemotherapy and the first generation we could improve the outcome, And why this is important, especially for India and for Africa also, is that gefitinib, now we have all this, many of these first generation and all drugs in the generic form. So this drug, for example, gefitinib, the monthly cost at Tata comes to around $8, around $8 to $10 a year. And imagine this, osimertinib, even today the cost is, if you have to buy the original molecule, there are spurious drugs available, drugs which come from other countries also, but if you see the original, it's around $2,000 for a month's treatment compared to $8 and $11. But if you add the first generation TKI plus chemotherapy, the cost is only $40. So this is the importance of that, and if you saw the outcomes were nearly the same, so you have increased the outcome to around 40 months using the first generation TKI with chemotherapy. So this is what I was telling even yesterday, that we have to develop our trials so that we, in such a way that that can be translational, that can be used in the clinic the next day, and it will make a difference. So this is what this trial helped us to do. And now we have moved forward also, because as you know, it's sometimes difficult to get a biopsy in patient with lung cancer, and especially at time of recurrence and all, it's more difficult to get biopsy. So like all the West has done, even at Tata Memorial Hospital, we have gone away from these biopsies to solid biopsies to what we call the liquid biopsies. And we have shown this was a study undertaken at Tata using various cancers. But if you see, especially the lung cancer here, the concurrence is nearly more than 90%. So we have changed. This is a previous paper. It has much improved even now. So we are now using more and more liquid biopsies in patients with lung cancer, especially at the time of recurrence. So that was one, EGFR was one mutation which everyone talks. The other common mutation, as we know, which is targetable, is the ALK mutation. And this is again a data from Tata Memorial Hospital, where we did, crizotinib was the first generation TKI available. So we started treating that all good effort. Many of these patients got this thing on patient assistance program. But what we saw was patients of lung cancer with ALK mutation, those who got crizotinib did much better. The median overall survival was more than 36 months at that stage. And if you see here, patients with basically metastasis, also did not have metastasis, they had nearly a flat line using this. And the patient basically who got first line did better. So basically crizotinib made a difference in the outcome of patients with ALK positive basically mutation in non-small cell lung cancer. And this is again data from the West, the first line data of using crizotinib in patients with newly diagnosed patients with ALK positive mutation in non-small cell lung cancer. And again, I wanted to show this slide because of this median survival now of 50 months. So from 8 months, we went to 20 months to 40 months and now to 50 months. So this is how we are slowly but steadily making progress in this group of patients. And we have gone a little further using the second line, the ALK inhibitors. And this is alectinib. You can see here, now the median survival has gone to 60 months. So from 8 to 20 to 40 to 60 months now, we're using different drugs. And this is not only basically with this mutation. The other mutation, though not common but recurrent mutation in lung cancer, is the ROS1 mutation. And you can see a patient with ROS1 who got crizotinib are doing really good, though this is not a mature data, so I'm not shown you in detail, but at least the initial data again from Tata Hospital shows that those with ROS mutations who got crizotinib are doing much better than the other patients. So definitely worth a try. And this is data from the West which has been published, which shows that the patients of ROS mutation who are on crizotinib, the median overall survival now has increased to 50 months. So definitely we are making progress slowly and steadily in different types, but what is important is that we have to individually profile each and every patient of lung cancer. You cannot use a common treatment like chemotherapy for all, and you have to have a precision medicine based treatment for this group of patients. The other mutations that can be targeted are the BRAF mutations. Again, there are various trials which have shown that you can target that. You have dabrafenib plus trametinib, basically second line, first line treatment. Again, the median progression-free survival has improved. And this, I am sorry about this, can't see the slide properly, but this is the again the combination drug where you can see that there is a flat line here, so that this group of patients also benefit with therapy, but it has to be targeted to that particular mutation that is there. Another one targetable mutation is the basically the TRK inhibitors which are available, and in lung cancer nearly 7% of that. So larotrectinib is basically another drug which is being used now, and again it has shown good responses in if the patient has that mutation, and their outcomes are also good. So it's another targetable mutation where the median survival has now increased in this group of patients to around 41 months. So definitely slowly and steadily we are improving. Combinations are being used. And another one is the HER2 mutation. I showed you that one patient, but again there's more data showing that if you have a HER2 mutation, basically they again benefit with the HER2 directed therapy, and especially now the TDX available, which is available, has shown good responses in this group of patients. You can see the excellent responses in this group of patients that they have. And you cannot stop talking about any therapy now in any tumor without talking about the immunotherapy. And this is the basically even the lot of data coming for use of immunotherapy in patients with lung cancer. Either you have the PD-L1 based therapy, that means the checkpoint inhibitors, or the CTLA4 blockers. So basically different types of therapies are being used. But definitely one thing is the PD-L1 expression. If it is there, basically you can see if you have more than 50% expression, there's a great response to the checkpoint inhibitors, and you can see that the median, the overall response, overall survival is around 36 months, but this nearly, if you can see a flat line, so nearly 60 months you can say. So definitely if the patient has basically the PD-L1 expression which is more than 50%, they will benefit with these drugs. And even at Tata Memorial Hospital, we treated nearly 155 patients with various cancers, because the initial experience was not that much because of cost constraints of using immunotherapies. But what we saw that patients who were responding had a great flat line. So definitely in some patients, if you have a good response, they do really well, and it is worth trying if the patient can afford. We can try this the immunotherapies in this group of patients. And very, very importantly, there, as you know, in lung cancer, when we talk about chemotherapy, actually, if you have a poor performance status, we are not supposed to give therapy because it doesn't work. But this is a data of patients who were in poor performance status and could not be given any standard therapy. When we gave them the immunotherapies, you can see the median OS is only 2.9 months. But very importantly, you can see there's a flat line at the end of this thing. So there is nearly 30% of patients who responded have done well with basically using this immunotherapies. And that's again where we cannot afford to use the standard immunotherapy in India and maybe in Africa also. So like I told yesterday, we are now trying the low dose. That means the standard nivolumab is used in 200 milligram. What we are using is 20 milligram, or 1/10 of the dose. And we have shown that are they really effective? This is what an editorial we had written a little time back. But then we have shown now, this was an ESCO presentation this year from our hospital, which has been now even published actually in JCO, which has shown that if you combine oral metronomic therapy with low dose immunotherapy, we definitely get a great response. And now this is in head and neck cancer, but there's a trial going on for the other cancers also, including lung cancer, and we are eagerly waiting for the outcome of this trial also. So in conclusion, there has been significant development in management of lung cancer. Targeted therapy and immunotherapy has significantly improved the outcome. You can see the median overall survival from 8 months has gone up to nearly 80 months using the third generation ALK inhibitors, for example. So it's a great 10 times we have actually slowly improved from 8 months to 80 months. But very importantly, like I told, it is important to develop diagnostic tests and treatment protocols that are locally relevant. We cannot depend entirely on the West, and this makes the treatment accessible to patients. And there are many other developments which I could not cover because of 30 minutes that I've been given. But very importantly, all this is irrelevant if you don't do this, and that is very important that even today, tobacco remains the most important and preventable cause of the lung cancer death. So I think we have to stress not only on the treatment, but as much as possible on how to prevent the lung cancer, head and neck cancers from developing. And if you do that, it will save much, much more than trying to treat this patient. So thank you very much for all that. So this is my Dr. Kumar Prabhash, who is the head of our department, my colleagues from Medical Oncology department, and these are colleagues who are from our lab. So a lot of work has gone on in this presentation, but over the years we have made a steady progress in the outcome of a patient. Thank you very much.
Thank you so much, Professor. We now open the floor for questions. If there are any questions in the building or online.
Thanks, Prof, for that very good exposure. Now, the oral metronomic therapy, which agents were used on the and which doses were these?
So because of lack of time, I did not dwell, but it's a published paper now, so if you put the name, it will get it. It was a triple oral metronomic therapy, again, which we have published again previously in JCO only. It's basically celecoxib, methotrexate, and erlotinib. So these are the three drugs that we use. And this is, when we added this with this is head and neck though, it's not lung cancer. The paper is in head and neck. The one which we are working, I'm not talking about it because that's an ongoing the study that is going on. But this one was in head and neck cancer where we use triple oral metronomic therapy along with 20 milligram of nivolumab.
Hello and good morning. As already introduced, I am a breast surgeon. I'm not an oncologist, and I'm just filling in her shoes. Well, we work at a hospital which is far away from Mumbai or any of the metropolis, and therefore I thought my presentation has to be, useful for people who work in remote areas. How to approach a patient with breast cancer with whatever tools, resources we have with us. So it's a very baseline presentation. It does not have any of the results or data that you have presented. Of course, we use data from Tata Memorial or all the other data that is available from the West. So I would start by just introducing how we look at breast cancer. This is particularly for people who are working in far off areas, and how to approach a patient with breast cancer. So this is the topic given to me, hormones and immunotherapy. It has nothing to do with surgery. I wish it was, the surgical part. I would have been doing that much better. So the changing scene in breast cancer. So previously we would look at breast cancer as a local disease, and it would spread by known anatomical pathways to reach distant organs, either through the bloodstream or lymphatics. Then we had a change in view, breast cancer as a systemic disease mediated through humoral, hormonal and biologic factors. And now we understand that it is a genetic disease and it is heterogenetic also. And it is the change in the genetic alterations that are really responsible for the disease. Now, these are some of the alterations that basically you have to know. It is the single nucleotide substitutions, which are known as point mutations, deletions, insertions, chromosomal amplifications, structural alterations, germline mutations. Accumulation of any of these would lead to cancer. Now, we also understand the heterogeneity. It is not only a genetic disease, but it is a heterogenetic disease. So there are differences among different patients, including different subtypes also. There is intertumor heterogeneity. So differences between the same tumor, and of course differences between the primary tumor and relapses. This is what we had before, just the morphology, how breast cancer would look under the microscope. Then we had the IHC coming in, the immunohistochemistry gave us the ER/PR statuses. Then we had the HER2 new oncogene, which we recognize. Now, of course, we have the gene expressions and, of course, single expressions, and now next generation sequencing. And the prognosis and predictors, which include hormone receptors and overexpression of HER2 new oncogene. Actually, these are the two basic reasons we do the classification into these 4 distinct groups, just depending on the hormone receptor status and overexpression of HER2 new oncogene. So luminal A, high expression of ER, HR HER2 negative, low Ki67. Low expression of ER, HER2 positive, high expression of Ki67. The HER2 enriched group, which has ER, PR negative and HER2 positive, and of course the basal-like, which is the triple negative, which we see in the most of our cases are triple negative. And this is from our department of pathology, all the 4 types. Now, hormones in breast cancer. Of course, we know estrogen has been one of the primary reasons for, the breast cancer, and we have been targeting the estrogen receptor pathway by using anti-estrogen. This is the first among the drugs that came in. And even before that, of course, we knew about it, and ovarian suppression was being done, oophorectomy was being done. Even today, it has its role in prevention, or you could do ovarian ablation. And then, of course, the selective estrogen receptor modulators, tamoxifen, raloxifene, the aromatase inhibitors, and the progestins. Even progestins sometimes find use in particularly advanced metastatic cancers. Now, tamoxifen, only agent approved for chemoprevention, treatment of DCIS, surgically excised premenopausal breast cancer. I'm not taking in the combined therapy. It's just first line I'm talking about, not the combined therapy. You know the permutation and combinations we have. Raloxifene, earlier used to treat osteoporosis. It has anti-estrogenic properties, and everybody would, one of the first things they would ask me is, how does, raloxifene, if it is used to treat osteoporosis, and we know that estrogen deprivation is going to, give rise to, demineralization of the bone, and how is it really effective here? And we have to tell everyone that it has an agonist and antagonist effect also. So the agonist effect is on the bones, the antagonist effect is on the breast cells. And we have torimifene. We don't have torimifene in India. We are not using that, but it is used everywhere in the West. Fulvestrant, of course, we are using also. It competitively binds to estrogen receptors. So it is not actually an SERM. It is not a, it is a degrader rather. It is an SERD, if you can call it. And we have the aromatase inhibitors, letrozole, anastrozole. These are non-steroidal. And exemstane, when used, it will permanently, there is no reversal, it will permanently inactivate the aromatase enzyme. And some of the hormonal agents used and how they are to be used. This is particularly for a guideline for people working in more remote areas. And what they have to really know is, now estrogen is being, tamoxifen is being used for 5 years. But there is enough evidence now saying that it can be used way beyond 5 years also. Maybe they are talking about using it for 10 years. So this is very likely to change in time to come. And some of the side effects, hot flashes, depression, we have to be careful with the thromboembolic episodes, uterine cancer. These are the worst things that you could encounter with tamoxifen. And of course, rarer are the retinal toxicities, the cataracts. Aromatase inhibitors, with this you really have to worry about accelerated osteoporosis, and sometimes we think of using biophosphonates along with the AIs, with the aromatase inhibitors. And non-steroidal, of course, we have fulvestrant. And arthralgias, myalgias, hypertension, hypercholesteremia. So just tailoring treatment. Basically, luminal A, hormone therapies, plus chemotherapy. Luminal B first would come chemotherapy, and then you could think of hormones. HER2 enriched, of course, trastuzumab. And basal-like, we have chemotherapy and immunotherapy. I'll come to that, because that is supposed to be my topic really. And the BRCA1 and 2, of course, we have the PARP inhibitors now. So in case of now these are the challenges in case of endocrine resistance. CD4/6 inhibitors now have been approved. So abemaciclib and ribociclib, any of those are in use now. And in case of trastuzumab resistance, we have adotrastuzumab emtansine, which has a cytotoxic arm also, along with the antibody conjugate, and lapatinib also, which can be used in case of trastuzumab resistance. And of course, newer strategies would involve, you see, the CTLA blocks, the PD-L1 inhibitions, HER2 vaccine therapies. I've just put in what is likely to happen in future. As far as triple-negative breast cancer is concerned, because of lack of targeted therapies, now we have something now. We have the immune checkpoint inhibitor, pembrolizumab, and of course adaptive cell therapy not approved yet. We have pembrolizumab and azitolizumab also. So if you look at the triple-negative breast cancer, there was a time we did not have a medical oncologist, and all the treatment I would do the surgery and I would do the chemo also. And I remember starting way back 20-25 years with CMF, the Cooper's regime. And then I remember the taxanes came in, the anthracyclines came in, then gemcitabine, capecitabine, and of course then today we have the Herceptin came in, and then of course the PARP inhibitors. Now it is long known immune cells. This is just to go back into history. It was William Coley who first realized that you see there's tumor regression after acute infection. And he actually made a cocktail. We had the Coley's cocktail, which is known the Coley's toxins, which use Streptococcus pyogenes and Bacillus proteguus. It is observed that histologically similar tumors have different clinical outcomes with identical therapy. Immunotherapy has shown promising results in melanomas, non-small cell cancer, and in renal cell carcinoma. TNBC is also considered most aggressive, lack of therapeutic targets. There is a need to move towards specific, targeted, tailor-made, personalized treatment. And I bring this picture always because I want the doctors there to understand what are we dealing with really, and what is a cancer cell really, and how you see the abilities that it has of, you see, resisting tumor death, you see continuously proliferating, acquiring its own blood supply, basically trying to get out of the cell program which is encoded in our DNA. So once it deregulates itself from that cell program so that it is free to charter its own course and to, in fact, to become a master of its own destiny. That's what a cancer cell wants to do, and that's what we want people to understand. So all future therapies will have to be targeted towards the hallmarks of cancer. Now, immunotherapy has shown promising results, but not all tumors respond to treatment. Overall, considering cancer, breast cancer is considered only moderately immunogenic. As we move towards a personalized treatment, we need to know which patient will benefit, and so these are some of the surrogate biomarkers we have: the tumor mutational burden, the tumor infiltrating lymphocytes, the PD-L1 expression. I think in breast cancer it is the PD-L1 expression which will tell us whether the patient is going to benefit from targeted therapy or not. And of course, microsatellite instability. Now, it is known the ability of immune cells to combat cancer, and it is halted by, you see, cancer cells at the checkpoints. Now, one of the checkpoint is the PD-1. So, therapies that target PD-L1 and PD-1, I'll show you in the next figure. The PD-L1 receptor is on the T cells, and the PD-L1 is coming from the cancer cell. And so blocking this pathway, the cancer cell is able to evade the immune system. So immune evasion occurs at this axis. So we have also seen that PD-L1 expression is reported in triple negative breast cancers relatively as compared to HER2 positive and ER positive. PD-L1 expression is more in the triple negative breast cancer. So PD-1 checkpoint receptor expressed by T cells, I've just told you about this, the mechanism of tumor evasion. And here it's the figure, the PD-L1 binding to PD-1 and inactivating the tumor cell. And we have the anti-PD-L1 or anti-PD-1 anti-tumor antibodies, and it will block these the PD-L1 axis and reactivate the T cell. I'll just put in one trial just to know that the immune checkpoint inhibitor pembrolizumab. This is a keynote trial, and the results are very interesting. Now, if you see if the score of PD-L1 is more, only then actually the patient is responding. With lesser scores, maybe pembrolizumab may not be so useful. For immune-related adverse events, toxicities include colitis, hypophysitis, thyroid dysfunction, pneumonitis. Particularly with pembrolizumab, it is arthralgia, nausea, fatigue, myalgia you find almost everywhere, diarrhea, colitis. Rarely you could get hepatitis, and DIC is also very, very rarely reported. Now, looking forward, the immune checkpoint inhibitors, now combination therapies, anti-cancer vaccines, cellular adaptive therapies, all under investigation. Oncolytic virus immunotherapy, bacteria as cancer drugs. This is how you could look at the future, the way you see research is going. And I've put this again, future targets have to be the hallmarks of cancer. So these are some of the PARP inhibitors. We have just put in what is going on. Many of them are under trials, some of them to be initiated also. So where do we stand at present? Immunotherapy has been established as a promising modality. Now, in breast cancer, it is only the metastatic triple negative breast cancer. That's where we use immunotherapy or pre-treated triple negative breast cancer, I think with a 1-year delay, and then you could use pembrolizumab. 3 and 4 are not actually connected with immunotherapy. In fact, trastuzumab is connected because it has an immunotherapy component. But these are targeted therapies which you could use in ER positive tumors, and PARP, of course, BRCA1 and 2, most of them, BRCA1 and 2 are also, we find they are triple negative cancers. Now, more evidence is needed regarding the timing of treatment, the combination therapies to use, and predictive markers. Now, before I go to the summary, what we have really now, I think as far as targeted therapy in breast cancer is concerned, we have done quite well, because we have targeted therapy for ER positive tumors, we have targeted therapy for HER2, we have targeted therapy for triple negative breast cancer, and we have targeted therapy for BRCA1 and 2 also. So we have come a long way in targeted therapies, and this is just a summary. This is for you see particularly in metastatic breast cancer, what you could be doing is just a guideline. The references. Thank you very much.
Good morning, everyone. I'd like to thank Merck Foundation, Dr. Rasha, Benu, Vishaka, Dr. Rajkumar, everything for taking all the initiative and calling us over here, and also for bringing all of you from Africa for this meeting today. So as you can see, my topic, it's a pretty long topic. So I'll try to touch upon things, and let's see how we go ahead. So next slide. Okay, I'll do it. Okay. So now, if you can see just in short, all over the world, as per the Globocon 2020 data, we had around 417,000 cervical endometrial cancer patients. Out of that, we lost around 97,000 women due to this particular disease. So, and if you see in Africa, we had around 14,000 patients, and as per the Globocon 2020, and we lost around 4,000 women in Africa because of endometrial cancer. And these are the areas in deep green, the countries where they have a high prevalence of endometrial cancer. So now, when do you suspect endometrial cancer? So basically, any abnormal bleeding. Suppose a woman coming with abnormal bleeding as a postmenopausal bleeding, you should suspect endometrial cancer. Then all the postmenopausal women with pyometra, you should suspect endometrial cancer. Then asymptomatic postmenopausal woman with atypical endometrial cells in the pap smear. Sometimes you do a pap smear in the postmenopausal woman, and if you get atypical cells in the pap smear, these are the women you should suspect that they may be having endometrial cancer. You should rule out those things. And perimenopausal woman with intermenstrual bleeding, and premenopausal woman with abnormal uterine bleeding and history of anovulation. So in the history component, these are the things you should evaluate and try to find out whether these are present or not, and how do you diagnose them. So as I've already told, history is one of the most important things, apart from finding all those history clinical features which I've told. Another important thing which you should take care is the family history. As you all know, endometrial cancer may run in the family, so family history is very important. When you take the family history of those women, basically family history of breast cancer, endometrial cancer, colonic cancer, the ovarian cancer, these in the gynecological component, these are the things you should always look for. And you should try to evaluate the history for 3 generations of the, let's say, the parent, the grandparent, and the great-grandparent, and downwards also the children, then the grandchildren and great-grandchildren, and laterally the siblings. This is very important. You should take a very good family history, especially for countries like us and Africa, where we cannot do these markers for all the patients which NCCN has recommended. So family history is very important. That is the first step when you are dealing with these patients. So as I've already told, once you have done this, then you should go for a office endometrial biopsy. That is a very, it can be done in all the countries, just by the help of the people, small biopsy, it is done as an office here. But in all the 100 patients, you may not be successful. It's said that around 15% of the patient, you may fail. This endometrial biopsy may not give you the specimen, the specimen that you want, and then in those patients, you should go in with a hysteroscope and do a directed biopsy. And if you do not have a hysteroscope, you may have to do a dilatation and curettage in this set of patients. Okay. Now, another thing, as I've told, is pap smear. As I've told, almost 50 to 60% of the endometrial cancer patients will have abnormal cells in the pap smear. So there you can detect some of them. Then color Doppler, role of color Doppler, it is said that once you are doing a color Doppler for these patients, the pattern of the vessel is important. They say that the three pattern A, pattern B, pattern C. Pattern A means you have multiple major vessels, then it is highly suspicious of endometrial cancer. Pattern B, you have a single major vessel. This generally comes in the form of polyp. And pattern C is the scattered vessels. This generally comes in the form of endometrial hyperplasia. So just by looking at the color Doppler also, sometimes you can suspect when, whether you are dealing with a patient of endometrial cancer. And sonohistogram mainly with the polyp and delta, I have already told dilatation. PAP-seq test, another test, next slide I'll tell. Tau brush is a brush which goes inside the endometrial cavity, and you can take a brushing sample and take a liquid biopsy, make a liquid biopsy out of that. And CT and MRI mainly once you have diagnosed the woman with endometrial cancer, it helps in the management, basically the staging and all the management. Yeah, sorry. So, yeah. So now this PAP-seq test, just the three things. The thing is that once, as I've already told, here 3 samples are collected. One you collect from the endocervix, another you collect from the endometrium by the Tau brush, and other is the blood sample. So what else, I was already told in the endometrial cancer, just by taking a pap smear, from the pap smear, almost 50 to 60% of the endometrial cancer can be detected. If you put the brush inside, the Tau brush inside, and take the brushing and come out with, put it in the liquid media, and from there you can detect almost, they say 93% of the sample can detect endometrial cancer with the Tau brush, and almost 45% of the ovarian cancer can be detected with the help of this Tau brush. So this is the coming up thing which needs further evaluation. So now, what are the risk factors? As I've already, most of the risk factors, relative risk runs around 2 to 3 to 4%, like that. But few concerning factors are, one is this, basically estrogen. Only estrogen as a HRT. That is important with the woman having uterus in situ. Then another important thing is obesity. They say as the BMI increases, the risk of endometrial cancer increases. So that is one of the important preventive measures that we need to take in obese women. And then family history of Lynch syndrome. It can go as high as 22 to 50%. So now, what are the preventive things? For an average risk woman, we should look for the body mass index. Ideally, it should be within 25 to 30. That is our target. And regular physical exercise, then breastfeeding, and also the oral contraceptive pills. So all these behavior have health benefits beyond protection of endometrial cancer. Now, what about the high-risk factors? High-risk patients. Let's say, as we all know, Lynch syndrome is one of the important high-risk patients for us. Now, how do we prevent? So they say chemo prevention is one of the aspects. How we can do it? We can use the POPs and LNGs, where we say that after using for 3 years, the 50 to 60% risk reduction after using for 3 years, and there is a 80% lower risk after 10 years of use. And once you have used this protection remains for 20 years after cessation. The other thing is the colonoscopy. As you know, Lynch syndrome, these patients, they are prone to develop endometrial colonic cancer. So they say that colonoscopy should be started. Those patients where their Lynch syndrome is, their carrier of the Lynch syndrome, colonoscopy should be started from 20 to 25 years, at least 1 to 2 yearly. That is how you should. And then there is a role of aspirin. They say at around 42 years, 600 milligram once daily for 2 years. There is a study that they have shown that you should ask them to take this. And then some risk-reducing surgeries, like risk-reducing total hysterectomy by age 40 years. Those were Lynch syndrome carrier. So now, another important thing, how do you detect? So these are high-risk women. Now, this is premenopausal women. So this, premenopausal women, they will have this the regular period. So endometrial thickness won't help us much. Rather than the postmenopausal woman, where we say when it is more than 4 mm, we will suspect. But in premenopausal woman, it is very difficult sometimes. So still they say that around 14 mm endometrial thickness warrants sampling. Then office endometrial biopsy may be considered at 35 years. and then reliable and accurate for the detection of endometrial cancer. And these are the methods of choice for evaluation. But in a postmenopausal woman, if it is an asymptomatic woman, we do yearly or yearly transvaginal sonography to look for endometrial sampling, and the cutoff is around 4 to 5 mm. And if it is with pyometra, somebody will take 3 mm. And then biannual endometrial sampling we do. And in symptomatic women, initial evaluation by either transvaginal ultrasound or endometrial sampling. And as I've already told, more than 4 mm endometrial thickness warrants sampling. And in tamoxifen users, asymptomatic, no routine screening method. Previously, we used to do endometrial sampling, but now they say patients who are on tamoxifen, we do not do routine endometrial sampling, and symptomatic women evaluation with transvaginal sonography and endometrial biopsy. So, but whatever we do as of now, they say there is no validated screening test as of now. These are things which you can do. So now, when do you refer? So referral for early diagnosis. Postmenopausal bleeding, heavy menstrual bleeding, post 45 years of age, or intermenstrual bleeding, which is a better predictor, you should refer. Patient on HRT, persistent bleeding for 6 months, post 6 months of starting HRT. You have started HRT and patient is having bleeding, you should refer. Bleeding persisting 6 weeks after stopping HRT. So these are, there is a concept of this one-stop postmenopausal clinic. All these women should be referred to the postmenopausal clinic, and the postmenopausal clinic will do either a TVS and then endometrial sampling based on the risks involved. So this is how you can go ahead. So now management. So management of endometrial cancer is based on risk stratification. We all know, generally the endometrial cancer, once they are detected, we stratify them as per the risk. Historically, it was seen that all this risk stratification was done based on histopathological age and all those factors. But now, this molecular classification is slowly coming in. So now, this is how we'll try to see what has changed. So now, approach of risk stratification has evolved from a purely histological diagnosis to ISC studies. And molecular classification not only helped in improving prognostications, but also helped in proper management. And use of targeted and immunotherapy in the management of endometrial cancer is slowly increasing with better understanding of the molecular pathway. So now historically, as I've told, in the 1983, Bookman, he classified endometrial cancer into type 1 and type 2 endometrial cancer. Type 1, basically, these 80% of the patients, endometrial cancer will be type 1, and 20% type 2. We all know type 1 endometrial cancer are basically, these are the tumors which do very well, and type 2, these are the high-risk varieties, like the serous cell, the clear cell, mucinous, squamous transitional cell, and undifferentiated. They have a poor prognosis, these we know. Now, so treatment, we all know endometrial cancer, surgery is the mainstay of treatment. So what do? We do total abdominal hysterectomy, bilateral salpingo-oophorectomy, plus minus pelvic and periaortic lymph node dissection based on the risks involved. So now that is there. So now, and in advanced stage, we do cytoreductive surgery. In advanced stage of endometrial cancer, we go, we open, we do whatever is all the visible disease, we try to remove, and then put her for chemotherapy and radiotherapy based on the risk stratification. And sentinel lymph node dissection is a standard of care in endometrial cancer, which has come now. And what is the route of surgery? It may be minimally invasive surgery, robotic, laparoscopic, or it may be open surgery and vaginal surgery some people are doing. So now this is how it goes. So this is just to show you the endometrial cancer, small endometrial cancer here, less than 50% endometrial invasion, grade 1, grade 2. Here no need to do lymph node dissection. Only hysterectomy is will suffice. But again, in this case, grade 3, all whole involved up to the serosa. These are the high risk endometrial cancer. Here you need to do lymph node dissection, and they say that if you are doing lymph node dissection, it should be both pelvic and paraortic lymph node dissection. Okay, so this is how it will. So this is the whole specimen will go, and they say that this ascitic fluid cytology, although now it's from the staging they have taken it out, but then it helps in the prognosis. So whenever you are doing your endometrial cancer surgery, ideally we should take the ascitic fluid, or if there is no ascites, the peritoneal wash for cytology. So now this is basically the how we that lymph node, whether when you will do lymph node, when you don't do lymph node. This is the answer to that. The grade 1, grade 2, stage 1A. That means less than 50% myometrial invasion. The lymph node metastasis is in less than equal to 5%. Though they say whenever it is any year there is less than or equal to 5%, you may avoid lymph node dissection, because 95% of the time you will do an unnecessary lymph node dissection in this person, leading to the increased morbidity. So they say grade 1, grade 2 endometrial cancer, well differentiated, stage 1A, don't do lymph node dissection, just THBS will suffice. And in other rest of the thing you need to do. So the role of adjuvant therapy based on the old stratification which we know as of now, they say that if it is a grade 1, grade 2, as I was told, less than it falls in the low risk. So don't do anything, just observe them. If it is more than 50%, but grade 1, grade 2, it is low intermediate, we need to treat them by giving only vaginal brachytherapy. And if it is grade 1, grade 2, but LVSI positive, or grade 3, it falls in the high intermediate. There you need to do vaginal brachytherapy if the node dissection was done and node is negative. And if the node dissection was not done, then you need to do EBRT, means the external radiotherapy plus brachytherapy plus when the nodal status is not known. So now last is the high risk factor, where you need to do systemic therapy plus radiation therapy. So the thing is that this remains same. Based on the histopathological, this, you do this, this, you do this, this, you do. Now, with the advent of this newer molecular classification, what happens is that there will be some rearrangement here, but the treatment remains same. Which patient will do in lower risk, which patient will fall in the high risk, which patient will fall in the high intermediate risk, that there will be a change of things, but the treatment remains same. Okay. So now emerging role of molecular markers. So molecular features are increasingly being integrated into routine histopathological reporting. The 4 molecular subtypes of endometrial cancer we have defined as of now. I'll tell you with respect to the histogenesis, precancer lesion, risk factors, hereditary susceptibility syndrome, molecular abnormalities, response to treatment, and outcome. So in effect, molecular classification identifies the disease in a different perspective, and clinical practice is moving towards treating them as such. Hello? Not going? It was running nicely, suddenly we got stuck. Yeah. No, just go back. Go back. Right? Yeah, next. Yeah. So what's different now? So now they say that previously what we used to do, we do endometrial sampling and send it for histopathology. Now they say along with histopathology, ideally universal screening on all endometrial cancer specimen, you need to analysis of the tumor for presence of 4 genes that are known to malfunction or mutate in Lynch syndrome. They say that all endometrial cancer specimens should go for this testing. I put a question mark here, because there was a question last, on my previous speaker's session, that in all countries, some country we need to modify, we cannot imitate the West. So therefore I put, so all patients we cannot do. We cannot ask all endometrial cancer patients to do all these MLH1, MSH2, MSH6 and PMS2, which are the 4 genetic for Lynch syndrome. So that's the importance of family history. We'll do it on the basis of, generally in our country what we do it on the basis of family history. When you get a very high suspicious of family history, very strong family history, in those patients we pick them up and we send them for this testing in the endometrial tissue. So now, these are the 4 genes that are tested, and if all the genes are expressed, this is normal. The unlikely that a Lynch-related pathogenic MMR deficiency is present, and if one or more of the genes are not expressed, then consider germline testing. Unless defects in the MLH, I'll come to this in the next slide, little bit of explanation is needed here. So now, what is microsatellite instability? They say that this happens in the MMR deficient tumors. What happens is that once the replication happens, there is some mismatch. This mismatch repair gene comes in and repairs those mismatch. But whenever there is a defect in the mismatch repair gene, this the repair does not happen, and this leads to the microsatellite instability. They say once the microsatellite instability we get is high in those MMR deficient tumor. So now this is how it happens. Endometrial cancer patient, less than 70 years. So this is in reference to Turashvili. So they said all the MMR you do ISC screen. Either you get MMR proficient and MMR deficient. Suppose if it is a MMR proficient, what is the family history have taken? Negative family history, she is no further action. But you have a very strong family history, but you are getting MMR proficient. Then you need to send her for the genetic counseling and genetic testing if needed. Suppose MMR deficient, so PMS2, MSH2 if you get, and MSH6 if you get, directly they will go for genetic counseling and genetic testing. If it is MLH1 and PMS2 deficient, then you need to do one further step. You need to look for the MLH1 promoter methylation testing, it should be done. And if there is no methylation, they will go for genetic counseling and testing. And if it is methylated, negative family history, no further action. If it is methylated but family history is positive, then they will go for genetic. This is the flow chart, how you manage these patients. Okay, next. Should give me extra time for this because my presentation is very long. So now, risk stratification based on molecular markers. You see, as I was told, diagnostic. As MMRD, MSI is considered as a marker of endometrial type endometrial cancer. Pre-screening to identify patients at higher risk of having Lynch syndrome. Prognostic as identified the cancer genome atlas. I'll come to that. And predictive for potential utility of immune checkpoint inhibitor therapy. So now this is what the cancer genomic atlas. Here they have divided this endometrial cancer as a polymutated. These are good tumors, they say, very good prognosis. Then you have the MSI hypermutated or MMR deficient tumor. Then you have the copy number low, where the P53 weighted or NSMP tumors, and the copy number high, that is P53 aberrant. So now the thing is that it was a bit complicated. So then people came up with this simplified ways, where this is the TCGA, where they needed the fresh tissue, fresh frozen tissue to perform this test. But this is the promise and the Leiden-Portek, Transportek. What they did, the promise, these are basically, they tried to find out the surrogate markers. These are based on the paraffin block tissue. Well, you can get the paraffin block and get it done, ISC-based test. What they did, MMR testing first is done. Suppose MMR deficient we know, good enough. Then they may stop there only. Then if it is MMR proficient, or some will come as unclassifiable, next they were doing polymutated. Polymutated, it is polymutated we know, then good. But if it is wild type, then they will do P53, either it is wild or aberrant. So based on this, they used to classify. This is a simplified way of doing, and these are the mainly done in our country or in the low resource setting. This can be imitated. So now, as I've already told, Bookman classification, type 1, type 2, we used to know good tumor, these are bad tumor. But what happened, you know, even in this good tumor, they saw that 20% had a recurrence. And this type 2 tumor, 50% sometimes did not recur. So why? They tried to find out why it happened. So this, once they analyzed this tumor and correlated with this tumor, genetic marker, they saw that some of the type 1 tumor, this thick line will be more than 50%. Okay, endometrial cancer more than 50% will be either MMRD or NSMP, good prognosis. But there will be few who will be P53 aberrant. So this type 1 tumor having this won't do good. So now we know that all type 1 tumor won't do good because some of them will have this. So once we know this, this we can reclassify this, and based on this reclassification, we can treat. So a tumor may have a polymutated tumor, even if it is high grade, even if it is a type 2, but if it is a polymutated, this will do good. This will do good. Okay, so that is the importance. If we can really do it, then this helps in the prognostication of the disease. So now advantages of molecular classification compared to historical classification are the ability to sort tumors that is standardized, and these are highly reproducible. You can again go back and again check with those blocks what has happened, and shows concordance between the initial biopsy and final hysterectomy specimen. So as I already told, polymutated, what are these? Basically, approximately in the TCGA, they have shown that almost 7% of the patient had polymutated. These are basically low-risk tumor, favorable prognosis with 95.6% survival at 5 years. These are early-stage high-grade tumor, but then they are favorable. Observation only may be reasonable, even if high-risk features and clinical trials are needed to establish safety and efficacy. De-escalation of therapy here. Even if it is a high-grade tumor, but it is polymutated, you can do de-escalation of treatment in the form of adjuvant treatment de-escalation or surgery de-escalation may be there, and there is a role of fertility-sparing surgeries. Sometimes nowadays a lot of endometrial cancer comes in the young age group when they have not completed the family, and then suppose these are polymutated tumor, you can tell them that okay, we can go ahead with the fertility-sparing surgery in these patients. Next. Next, it's not moving. So, yeah, okay. So, MSI hypermutated, MMRD, these are approximately 28% of the TCGA classification, the tumors. These are the decimal tumors which are associated with the Lynch syndrome or Lynch-like, means they are positive in the tumor, but not present in the genetic level. Means there are two things. One is somatic and germline. Germline means it is detected in the blood, okay, and somatic means in the tumor. Okay, and sporadic means they are not here, but then homozygous methylation of the MLH1 gene is there. And these are constituted under the high intermediate risk tumors, and treatment will be as per my earlier I have shown you. So radiation works better here, and checkpoint inhibitors in advanced and recurrent tumors. So little bit about the checkpoint inhibitors. They say that pembrolizumab, all the MMR deficient tumor, pembrolizumab works very good. They have shown very good results. And if it is, even if it is a MMR proficient tumor, they say along with pembrolizumab, if you use lenvatinib as per the keynote 777, they have shown good results. Other checkpoint inhibitors, dostarlimab, as per the Garnet trial, they have shown that overall response rate of around 45% with 11% complete response and 34% partial response. And durvalumab antibody to PD-L1, this is as per the Fedra trial, and evolumab, where we have the ORR finding of 27% for the MMRD group. These are the various checkpoint inhibitors. I'm not, again another confession, I am not a medical oncologist, so I go into details of these things. Anyway, so now copy number low, approximately 39% of the TCGA. These are basically the low intermediate tumors. These are P53 weighted tumor, no NSMP, around 40 to 50%, and these are in the intermediate prognosis. And these are basically the ERPR positivity will be there, and this hormone therapy works better here. Hormone therapy works better here. And there may be some role of mTOR inhibitors. Another interesting thing which they found in the PORTEC-3 cohort, they saw that few of these did not do good. And when they went back and saw that these groups, those patients, cohort of patients who did not do good in this copy number low, they had this CTNNB1 mutation and L1CAM mutation. Okay, so now next I'll come to that. So as because of this finding, the PORTEC-4A trial was planned, and where they have divided it like that. Basically, they have taken all the early cancer, high intermediate risk group cancers. You see, stage 1 endometrial cancer, surgery done, the pathology diagnosis or everything done, it comes under the high intermediate risk. They have assigned 2:1, standard arm, vaginal brachytherapy, we know, high intermediate group. Experimental arm, what they did, determination of the molecular integrated risk profile. Now molecular, here they have done, and they tried to find out whether it is in the favorable, if it is a favorable group, observation. If it is an unfavorable group, they will do EBRT. If it is intermediate group, they will do vaginal brachytherapy. Now how to find that? You see, stage 1, high intermediate risk endometrial cancer, determination of the molecular. If it is poly, positive, favorable, we know. If it is P53, extensive LBSI, and L1CAM, more than 10% L1CAM expression, it is unfavorable. If it is a MMR deficient tumor, yes, intermediate group. If it is MMR deficient, no, Then they will do the ctNNB1. If it is a wild type, favorable. If it is mutated, unfavorable. See, this is the how they treat it. So now, copy number high, almost 26% as per the TCGA classification. These are basically the high-grade tumors, p53 abnormal, chemotherapy works better, and there is some role of HER2-neu targeted or HRD targeted therapy, and 5 years, however, is around 50%. 50%. Next. Okay, so to summarize means not the whole thing, just this part summarization. The presence of pole mutation reclassify all stage 1, stage 2 tumor into low risk category. I've already told. For advanced stage polymutated tumor, there is no recommendation regarding classification given the limited evidence. P53 abnormal status upgraded the category of most stage 1, stage 4A tumor to the high risk group. Exception, if there is a polyp, you get P53 positive in a polyp, but no superficial, only superficial layer, no deep myometrial invasion, then you can leave them, no adjuvant treatment. MMR deficient and NSMP tumor were classified according to concomitant clinical pathological features such as presence of myometrial invasion, LBSI, high-grade histology or stage, and clear cell carcinoma has not been classified. So this is the risk classification as per the ASMO, ASGO, ASTRO. It is there in the internet. You can just make a photo after doing the test. This is the old classification. This is the new. After doing this poly, MMR, all this testing, you can see where your patient lies after doing this. Okay, so you can reclassify them and treat them accordingly. Okay, so it's there in the ASMO, ASGO, ASTRO Consensus Conference Environmental Cancer Diagnosis and Treatment Guideline. So after doing these things, what they went back, and this was a study which was done by Sarah Imboden, and then what they have shown that they have done a retrospective study of 594 patients performing molecular classification and applying this guideline. They have shown there was a change in the there is a change in the risk group in up to 7% of the patient. Out of that, 44% were assigned to the lower risk category. From the original one, and 56% of the patient were assigned to a higher risk category once they have reclassified as per this IC. So now management algorithm changes, as I was told, in respect of surgical extent, where you need to do lymph node dissection, whether you can do fertility sparing surgery, all these things you can take care. In respect of adjuvant treatment, what to give in which patient, and better prognostications. So now adjuvant treatment, I've already told, low risk. What do you do? Stage 1A endometrioid plus low grade LBSI negative, low risk, no adjuvant treatment is needed. Intermediate risk, they say adjuvant brachytherapy provides excellent vaginal control and high survival rate. No adjuvant treatment is an option for patients aged 60 years who have a low risk of relapse. And there are few specific available data on the best treatment for stage 1A non-endometrioid carcinoma. Stage 1A but non-endometrioid carcinoma, you will decide on the case-to-case basis. And I've already told the poly, P53, even if it's P53, sometimes adjuvant treatment may not be necessary. And if it is suppose the high intermediate group, and after you have done a complete lymph node staging, no node positive, EBRT can be considered for substantial LBSI and for stage 2. But adjuvant brachytherapy can be recommended to decrease vaginal recurrence. Adjuvant chemotherapy can be considered especially for high grade or substantial LBSI, and omission of any adjuvant treatment may be also an option. And in the high intermediate risk, where suppose lymph node staging not performed, you do not know about the lymph node status, then adjuvant EBRT is recommended, especially for substantial LBSI and or stage 2. Additional adjuvant chemotherapy can be considered especially for high grade and or substantial LBSI. High risk, you have to give both radiation and chemotherapy, either as a sandwich or sequential. The benefits of added chemotherapy is unclear for patients with stage 1 and 2 clear cell carcinoma, and additional brachytherapy boost can be considered especially when there is substantial LBSI, endocervical stromal invasion. In those patients, additional brachytherapy. So coming to the last, role of targeted or immunotherapy, we have two important trials, Keynote 28 and Keynote 158, where they have shown that 13% ORR and 13% SD. And in the Keynote 158, 49 patients with MMR deficient endometrial cancer had overall response of 57% and median PFS of 25 months. But the thing is that this immunotherapy in endometrial cancer is not in the first line. It is only for the metastatic setting. They said that pembrolizumab demonstrated robust and durable anti-tumor activity and encouraging survival outcome with manageable toxicity in patients with previously treated advanced MSI-H or MMR deficient endometrial cancer. And it was published widely, and ultimately, and this keynote 777, which I have already told, in MMR proficient tumors along with lenvatinib, they have shown good results. And this led FDA to approve pembrolizumab as a single agent for patients with advanced endometrial cancer with MSI-H or MMR deficient who have disease progression following primary systemic therapy in any setting and who are not candidates for curative surgery or radiation. So this is how it goes. So road ahead is a modification of surgical extent, as I've already told, based on this. Sometimes omentectomy. They say that see endometrium, when you do omentectomy, our teaching is that in serous endometrial cancer, we do omentectomy along with THBSO, pelvic lymph node dissection. But now they say that even if the woman has P53 positive, then in some patients we need to add omentectomy also. Selection of adjuvant treatment, better prognostication of patients, role of targeted therapy, and the main question, the applicability in low middle income countries. How do we apply this knowledge in our setting? So this is how it goes. These are my references, and thank you. And I leave you with this slide. As Go Astro did, all your things, whatever you get, the management is here. You can make a photo of this, and it's already there in the net. So thank you so much.
Thank you so much, Professor. We'll take one question, and then we have another question online.
Good morning. Very nice presentation. I'm Dr. Fauzi from Mauritius. I'm a pathologist, and I'm very much concerned about whatever you told us, because actually we are having quite a number of non-endometrioid tumors. So being responsible for the IHC section, we are planning to implement a MSI panel by the end of this year for our 5 regional hospitals. So it was actually meant for colorectal, but after seeing your wonderful presentation, we know that in some of the private sectors, we do report MSI on endometrial cancers. So Mauritius being a small island, I just wanted your opinion, like, should we in all cases of stage 1 non-endometrioid subject it to P53?
Yeah, that is what, Actually, one of our residents, we have given a thesis on this subject.
Okay.
Yeah. We thought, let us at least, we need to modify things based on our resources.
Yeah.
So we thought that all this, as she has told, we are trying to do P53 on those patients based on only one marker. P53 will do. If it is negative, then it's okay. If it is positive, then we know this is not a patient who may be bad. So this is a very good idea. In fact, this idea came to us also, and we also give it, give it to one of our residents.
So it's going to be a research point for us also.
Yeah,
Thank you so much, sir. Thank you.
Thank you.
Thank you. So I've been given 4 tumors to cover. Like Dr. Burman told, lot of things to cover, but let's see how much you can do. If you can give me this thing 5 minutes earlier, then I'll wind up. So again, the same thing there. Much of the data is in relation to applicability in low and middle income countries, and some of the therapies are not standard, but we have been doing that in our center. So as you know, I mean, moving from cancers which are controllable, now we are moving to cancers which are curable. And as you can see here, basically, overall, everywhere we have done improvement, but if you say overall, more than 80% of pediatric cancers can be cured. This is true especially for the West. I cannot say that with confidence for Africa or for Asia, but definitely these are potentially highly curable cancers. Why is it important? You can see here basically that, the incidence of cancer, pediatric cancer, is much lower in Asia, Africa as compared to the West. Here it is 165 per million population compared to 85 year and 75 year per million. But the other way around, if you can see here, more than 50% of the patients children diagnosed with cancer in Asia and Africa die because of the disease compared to hardly 10-15% in the developed countries. So definitely we have a lot to improve. And this is what is again important, is that though the incidence is less, You can see here that out of the 215,000 new cases of pediatric cancer diagnosed across the globe, you can see nearly 80% of those or 70% of those are in Africa and Asia, not because, as we showed, the incidence is less, but because there are so many children living in Asia and Africa, the number of cases in Asia and Africa is much, 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 much more than what is there in Europe or in America. So definitely it's very important, if we have to improve the outcome of pediatric cancers across the globe, we have to concentrate on cancers, childhood cancers in India and Africa also. And this is the numbers. Actually, if you see here, during the period 2011 to 13, across the whole of England or UK, 1,691 pediatric children with cancer were diagnosed. Why I'm showing you this number is that this is 1,691. For these many children, there are 23 specialist centers taking care of these children across the UK, and many, many more smaller centers. But you see at just one center, that is the Tata Memorial Hospital in Mumbai, some of you have rotated through there, you can see the same period we had 4,297 children diagnosed with cancer at one center. So 2.5 times in one center compared to the across the whole of UK. So this is why there's a difference. I told you yesterday also that our numbers are our enemies also and our positive point also. So especially if you all want to come and rotate through Tata, you can see a lot of children during a small period that you are there. Just to mention, as we all know, the commonest cancers in children are the leukemias, followed by brain tumors, and these are the percentages of other cancers. I'm not going to waste time in that. But very importantly, if we have to cure this, though these are highly curable cancers, if we have to cure cancers in children, you have to make an early diagnosis. Like again, I told you, not only early diagnosis, you have to make a proper diagnosis. And third important thing is that treatment has to be given properly. If you treat AML like ALL or ALL like AML or lymphoblastic lymphoma like Burkitt's lymphoma, it's not going to work. So basically you have to treat them properly. Very importantly, for solid tumors, as we know, that the wide spectrum of presentation, symptoms can be because of the tumor mass, can be because of the metastatic spread of the disease, and very importantly, in many of the tumors, they can also present with paraneoplastic syndrome, so we have to keep that in mind also. So how do you evaluate these children with solid tumors with cancer? Is definitely we need the basic blood investigation, sometimes the tumor markers, we have to do a proper imaging for staging, and we have to do a proper biopsy for diagnosis confirmation. So these are the basic requirements if you have to treat any child with cancer. Again, initially we used to talk about only 3 modalities of treatment, the surgery, radiation and chemotherapy, but it's becoming more and more increasingly important to include the immunotherapy also in our armamentarium of therapies, not only in adults but also in children with cancer. Why I'm showing you this is that you can see here across everything, most of the tumors except for maybe here hepatoblastoma here and osteosarcoma, you require all the 3 modalities of treatment if you have to cure the children with cancer. That is that is especially the solid tumors I'm talking about here, the chemotherapy, surgical therapy and radiation therapy. So it's very important to have. I have been told, many of the fellows that rotate through our center, there are many centers in Africa which do not have even a single radiation therapy unit, or some are there but are not functional. And now yesterday in the panel discussion we heard, like in Kenya and all, there are many more radiation therapy units now. So things are improving, but very importantly, if you have to cure the children with cancer, especially the solid tumors, you have to have a radiation therapy facility again for treating many of the cancers. And this is very important slide which I am showing you, because till some years back when chemotherapy was not available, most of the children with cancer were being treated with surgery. But you can see here that, and we always tell that the cancer in children is a systemic disease. Even if you have a very small localized disease, many of these have already systemic spread. So you can see in the pre-chemotherapy era, even tumors like Wilms tumor, 40% cure rate, with chemo it has improved to 90, Ewing sarcoma from 5 to 60, lymphomas from 10 to now maybe 95%, rhabdomyosarcoma, osteosarcoma, astrocytoma. So very importantly, many of the tumors in children, just with, even if they are localized, just surgery does not help, and you have to give them good chemotherapy or good systemic therapy if you have to cure these children with cancer. And this is, again, I would always tell that it takes a village to treat one child with cancer, and you can see the number of people required to treat one child with cancer, and that is why there are very few pediatric cancer units, especially in the developing countries. These are the core people that you need: a pediatric oncologist, pediatric radiation oncologist, pediatric surgeon, pediatrician, nurses, pharmacists, a dietitian, etc. These are core people, but you require a lot of supportive care in the form of radiology, pulmonology, hematology, blood transfusion, genetics, and so on and so forth. And very importantly, even the peripheral people like data managers, palliative care, social workers. So lot of people are required if you have to treat even a single child with cancer, and that is why it's better to develop a few good pediatric cancer units rather than having more number of units with less facilities. So very, very important for many of the countries in low and middle income countries to develop a few centers but have everything at that place so that these children can be treated with a curable intent. So now coming to the tumors, so we have been given 4 tumors. Let us see how much we can cover in this time. So the first is the Wilms tumor that I have been told. So as we know, Wilms tumor is the most common primary malignant renal tumor of childhood. Now most of the tumors in children are most common or second most common, how you can label them, but this is the most common renal tumor in childhood. Can be unilateral or bilateral, as always, like in retinoblastoma. If it's a unilateral tumor, they present at a little older age as compared to if it's a bilateral tumor. And again, they are known to metastasize to lung and liver, and 10% of these are associated congenital malformation syndrome. So very few actually in children have congenital, the hereditary and malformation syndrome, but Wilms tumor is one of those where in 10% you can have all these other different types of congenital malformation syndromes. This is just the type of presentations. It can be a painless abdominal mass, abdominal pain, abdominal distension with respiratory difficulty, rupture if they have an acute bleed, fever, hematuria, hypertension. So there are various ways in which these children can present, but the commonest one is when the mother is bathing the child, she palpates a tumor in the abdomen and then she takes that child to a doctor. So these are various ways that they can present. But most importantly is this question, whether to do upfront surgery or give them chemotherapy. And there's a big fight between those practicing in United States and those practicing in Europe. And as we know, most of us work in conjunction with SIOP or the European group. So in India, especially India and maybe in Africa also, we start with chemotherapy. Mind you have to keep that in mind that basically whatever you do, the outcomes are nearly the same, especially if you have all the ways of treating this child. But very importantly, in the advantages of upfront surgery are you get a accurate histological diagnosis, the staging is accurate, the tumor burden is reduced before starting treatment. But very importantly, this is especially true for countries like Africa and India, where patients present with large tumors, so less rupture or spillage if you start with chemotherapy. Access to assessment of response to chemotherapy is possible, and especially India, Africa, where malnutrition is a big problem. Large tumors present with a malnourished child, so it is better to improve the nourishment of the child before doing the surgery. So upfront chemotherapy is better, but the multidisciplinary team has to decide on case-by-case basis. But mostly in India, except if the tumor is small, we start with upfront chemotherapy. So what are the important issues to keep in mind in Wilms tumor? Surgery needs to be adequate. Very, very importantly, just surgery is not enough, and many times this surgery is done by non-oncological surgeons, and they don't do all the proper oncological staging of the patient. So very important that lymph node sampling has to be done if you have to stage these patients properly. So lymph node sampling has to be done. Rupture has to be prevented, and many times what happens, surgeons don't tell. I don't know what in Africa, but in India, many times patients come from outside. Surgeons hide the fact that the tumor was ruptured during the surgery, and this is very bad because you have to give abdominal radiation if there's a rupture. But if you don't know the history, then we'll not be doing that. So very importantly, the surgeon has to be, true to his profession and tell us what exactly happened during the surgery. And another thing is pathological evaluation needs to be accurate, whether if it's a favorable or unfavorable histology, the local staging is to be done properly. So all these are important issues in management of patient with Wilms tumor. And this is again, important in adults, renal tumors. Many times we do nephron sparing surgeries, but in children this has to be done only in select situations. For example, if you have bilateral and all, it's not a standard of care. Though surgeons will tell that I can do nephron sparing, but ideally this is not standard of care, and this is only to be done in select situations. Second thing is, many times in adult oncology now we are doing a lot of laparoscopic surgeries, but in Wilms tumor, even today, this is only done by selected surgeons. So this is not a standard of care, and laparoscopic approach is not a routine for management of Wilms tumor. This is just to show you this thing. So if you have a low stage disease, 2 drugs are used, but if you have a high stage disease, we use 3 drugs, and the commonest drugs, as we know, are vincristine, actino, and doxorubicin. And if you have metastatic disease to begin with, we add ifosfamide, carbo, etoposide, so that the drugs depend on the stage commonly. So low stage, less drugs, higher the stage, more the drugs. But what is important is that, and even radiation is used for higher stages. So it's not only the surgery, chemotherapy, and radiation therapy is required in most of the cases, except if there is a low stage tumor where you can get away without giving the radiation. So all these things is important, and very importantly to know, as we know, is that Wilms tumor is a highly curable disease with more than 90% of the children getting cured of their tumor. So it's very important to treat them properly to get the improved outcomes. The next one is the neuroblastoma that has been told. Again, it's basically neuroblastoma is again one of the commonest soft tissue, the non-CNS tumor tissue, tumor in children. So it's an embryonal tumor of sympathetic nervous system, forms nearly 10% of all pediatric cancers, most of them less than 6 years. Tumors predominantly arise in the adrenal medulla, the parasympathetic ganglia. So this is the commonest site of origin, most of them in the abdomen, in the adrenal region, abdominal region, some in the thoracic, especially the posterior mediastinal region, and cervical ganglion. So basically these are the commonest sites of origin. And the clinical presentation can be as per where they are, like loco-regional symptoms. If it's an abdominal mass, they can present with hydronephrosis, bowel obstruction. Cervical Horner syndrome is known, as we will show, there's a photograph I had. But Horner syndrome, if it's a thoracic mass, it can present with superior vena cava syndrome. They can present with symptoms because of the metastatic disease, especially if there's bone pain, bone marrow involvement, then low counts, raccoon eyes, liver, etc. So these are some of the metastatic presentations. And like I told you in the beginning, paraneoplastic phenomenon is common or a known part of neuroblastomas, especially the opsoclonus, myoclonus, ataxia syndromes. They can have chronic diarrhea because of VIPoma. So basically, these are some of the paraneoplastic presentations in neuroblastoma. So this is the Horner syndrome, where because of the cervical involvement, you can get raccoon's eye, where there's bleeding under the eye, abdominal mass. So these are some of the presentations. And risk stratification. Now there are various means. There are tables and nomograms where you can have multiple ways to diagnose or prognosticate these children. But at the Tata Memorial Hospital, we have used the simplest way to do. We risk them according to the low, intermediate, and high grade. And low, as we know, is if it's a less than 547, so that's infantile neuroblastoma. And low stage, non-amplified, if it's more than 547 days, again low stage and non-amplified. So these are the low grade ones. Intermediate is basically the infantile neuroblastoma, which is higher grade 3 and 4, but MIC is non-amplified. And the higher grade, the older children, but with only stage 3 disease and MIC non-amplified, they go into the intermediate grade. and the rest are high grade, basically, especially those who are older children with stage 4 disease, and especially all of these are, many of these are MYC amplified. So MYC is a very, very important prognostic factor. So if you are not doing any other biological markers, at least see that whether you can do a MYC amplification test done. If not, in your center, maybe for a whole country, there can be one center which can do the MYC part of it. But I think it's a very important prognostic marker in neuroblastoma. And as you can see here, most of the patients are in the high grade group, and some of them low. But this is data from the West, especially in India and Africa. We may be having much more higher number of patients in the higher and intermediate grade than in the lower grade for neuroblastoma. So what is the treatment part of it? Again, treatment depends on the prognostication, whether the child falls in the low risk patients especially can be observed, or only surgery can be done. Intermediate risk, you have to increase the therapy, so surgery plus moderate intensive chemotherapy. And for high grade, you need all the things, that is surgery, more intensive chemotherapy, more radiation also comes in, and even the stem cell transplantation and immunotherapy. So as very importantly, like I told in the first slide, you have to have an early diagnosis, proper diagnosis and proper treatment. This is why you have to have an early diagnosis, because as the stage increases, treatment also becomes more intensive, outcome also decreases. So if you have to have good outcome, you have to diagnose these children in the right time so that they can get the treatment immediately. So this is the treatment for high risk patients. So we give induction. Mostly we use the rapid Kojak treatment at our hospital. And then after the initial new adjuvant chemotherapy is given, followed by surgical excision of the primary, followed by myeloablative therapy, that is the high dose chemotherapy and autologous stem cell transplant, followed by radiotherapy to the primary tumor site, and then we continue them on oral cis-retinoic acid, 13-cis-retinoic acid maintenance therapy. And this is, for example, this is a tumor which they present with one of the child, and most of them present like that. But after neoadjuvant therapy, there is decrease in the shrinkage of tumor, and this tumor becomes more accessible to surgical therapy. So we do that in most of our advanced patients. And this is just the outcome. If you see here, again, this is for low risk, intermediate and high risk patients. And you can see for the low risk and the intermediate risk, the outcome is more than or equal to 90%. So most of the children will get cured. But in the high risk, the outcome falls to less than 10% to 50. So for the high risk patients, the outcome is not that good, which we need to do something much, much more for this group of patients. Again, this is just a graphical thing of stage 1, 2, and 4S, all ages, stage 3, and stage 4 lower age. And this is for stage 4 patients. So you can see how much drop is there for the outcome from stage 1 to stage 4. And this again is the most, like I told you, most important one is the MYC amplification. And you can see those who are not amplified do much better than those who are amplified. So very important to do at least this test, if not any other test for your patient. And this is just to show the original paper which showed, Kathy Methe's paper, which showed that if the children get high dose autologous stem cell transplant along with cis-retinoic acid maintenance, they do the best as compared to those who do not get the autologous transplant or the cis-retinoic acid maintenance for patients with advanced neuroblastoma. So there's a big difference there. So this has become a standard of care for many of the patients. And again, this is not, that was with transplant, but then came the era of immunotherapy. So the anti-GD2 antibody, when it came, it showed that definitely if you give these children the antibody therapy, the outcomes are better. But very importantly, in countries like India, Africa, the cost is there. I'm not even talking about the cost, because cost is tremendous beyond reach of most of our patients. But along with that, there is significant acute toxicity, inflammatory reaction, not commercially available in most of our countries, and cost is a factor. So we hardly give that. But there's another paper that came out which showed that basically for those patients who cannot go for transplant or for antibody therapy, simple thing like metronomic maintenance makes a difference. So this showed that if you give, and these are simple agents that can be given as metronomic maintenance, and you can see here that with the oral metronomic maintenance, the outcomes, the 3 year overall survival came from 60 to 71%. For 3 years it was 30 or 40%. So basically it improves the outcome. So nearly what you get with the antibody therapy, you can get away with doing low dose metronomic therapy. So this may be a way of treating our children, but there is now data which is even better than this, and this is the data of oral, difluoromethyl ornithine or DFMO therapy, which my colleague from US is popularizing, where she has told this is an agent which basically targets the MYC gene, and it actually arrests the cell cycle in the G1 phase. So very, very simple drug. It's an oral drug with hardly any side effects. And if you start producing it in India now within a short time, the cost will really, really low, because even today the cost is $1 for children in US, but it will be maybe $5 or $3 for the entire month if India starts producing this drug. So this is beyond the patent era. So it can be developed in India. We are trying to get it done. But DFMO has shown that if you give this drug, you can see the maintenance has really improved the outcome of children, and this is shown in multiple studies done by her, where DFMO maintenance therapy has improved the outcomes. Now mind you, all this is done after standard therapy in US. That means in USA the standard therapy is not only the chemotherapy, but then followed by autologous transplant, followed by anti-GD2 antibody. So even after all that, the outcome improves. In India, where we don't do anything, or in Africa, where we do not do transplant in many patients, or do not give the anti-GD2 antibody, it will be interesting to see whether the DFMO maintenance improves the outcome. So waiting for this study to be done soon in India at least, and maybe we'll see if we can get others to participate in this study. Next one is the osteosarcoma. And like I told you to begin with, that in the pre-chemotherapy era, the outcome was just 15%. So we have improved a lot from 15 to 65. Unfortunately, this 65 has remained nearly constant. We have not been able to improve much after that, but there is improvement because of chemotherapy. And very importantly, this we hardly see nowadays. That means once upon a time, amputation was the treatment for this patient, but we don't do that now. And you can see here, even with such an extensive osteosarcoma patient, we have done the limb salvage surgery, and this is a very functional limb which can be done. So we are hardly doing any amputation nowadays, and a lot of limb salvage surgery is being done for these children. So again, prognostic factors for osteosarcoma, as we know, the site of disease, whether the disease is axial, appendicular or craniofacial, as we know, these are the children which do poorly because we cannot operate them in this area. The size of the tumor, larger the tumor, worse is the outcome. Metastatic disease, again, is if it's there to begin with, worse is the outcome. And post-chemotherapy, so these are pre-treatment prognostic factors. After receiving the neoadjuvant chemotherapy, the post-chemotherapy prognostic factors are whether you can surgically resect these tumors. So if you can resect the primary as well as the metastatic disease, they do better. And the degree of tumor necrosis, as we know, is very important. And this is one of the most important prognostic factors in this patient. I'll show you the graphs for this. Again, there are some the important things to keep in mind of OGS is that 3 drugs are better than 2, but there's no benefit of adding the 4th drug. So 3 drug has become the standard of care, and the most commonly used drugs are cisplatinum, doxorubicin, and high-dose methotrexate. But in country like India, Africa, where getting admissions or doing the levels of methotrexate, etc., or the cost of that is not affordable, we are using the 3rd drug as ifosfamide, and I'll show you the graph of that. So cisplatinum, doxo, ifosfamide is mostly used in the developing countries, whereas cisplatinum, doxo, and high-dose methotrexate is used in the West. And metastatic disease was prognostic. Number of metastases and surgical clearance of gross disease is important. So if there are oligometastatic disease, they still do well. But if there are many mets, then these are the children who will not do well. And this is to show that if there's more than 90% necrosis, they do well as compared to those who have less than 90% necrosis in the tumor. But very importantly, now we have gone even further. So if there is more than 98% tumor necrosis, these are the ones who do well. So you have to have at least 98% tumor necrosis in the post neoadjuvant chemotherapy sample if they have to do well as compared to those who have less than 98% tumor necrosis. So it's very important to do a proper pathological staging after the tumor is removed for surgery. So this is just to show one of the things. So again, like I told you, 3 drugs are better than 2 drugs, but 4th drug doesn't help. And this is just to show this Euromos trial where, basically patients received post-treatment, post-surgery, either 3 drugs or 4 drugs. And you can see here that adding the 4th drug did not make a difference in the outcome. And as expected, those with metastatic disease did poorly as compared to those with non-metastatic disease in this thing. And this is our own study which showed that overall the progression-free survival was around 60%, but more than nearly 74%. Even overall survival for patients with non-metastatic osteogenic sarcoma, where we had used the 3rd drug was ifosfamide. So that means adriamycin cisplatinum ifosfamide as compared to high-dose methotrexate. So they also do equally well as compared to those who have been given high-dose MTX, but which is not possible in many of the developing countries. And lastly, the brain tumors, though I know I don't have much time to cover everything. Just a few slides on brain tumors is that, though unlike in adults where many of them have high-grade tumors, most of the children commonly have low-grade gliomas, and like low-grade gliomas, you have astrocytomas, brainstem gliomas. So these are basically low-grade tumors, and high-grade gliomas only 10% in this, medulloblastomas another 15%. So this what I'm showing is if you are suspecting, if the child presents with headache, vomiting, and you're suspecting brain tumor, please never do a CT scan. CT scan many times, like I told you, since most of the brain tumors in children are low grade, you may not see it well laid up in a CT scan. So the investigation of choice is getting an MRI done. And MRI is not only helpful in the early diagnosis, but even in patients who have been treated, whether to find out whether there's a tumor there or radio necrosis because of the radiation. Again, the MRI helps because you can do a MRI spectroscopy and see whether it's a dead tissue or a tumor there. So MRI is a better test to be done for brain tumors in children. And the treatment strategy again is basically you have to manage if there's increased intracranial pressure, treat it with dexamethasone, CSF diversion procedures, and the definitive therapy, the best therapy is surgery. Whatever said and done, the best way to treat is surgery. But I'll show you in the next slide, not all we can do surgery, but surgery, radiation, and chemotherapy are the definitive therapies, and supportive care is also very important for that. And these are the indications where many patients require surgery, and surgery is treatment of choice. But for some tumors like optic gliomas, special sites, pineal gland, germ cell tumors, CNS lymphomas, where we don't need to do the surgery or it's not indicated doing a surgery. And for surgery, after that, the commonest treatment is the radiotherapy. And there are various. When we started, there was only cobalt, but now we have external beam cobalt therapy, we have intensity modulated therapy, the stereotactic radiosurgery, hyperfractionation, proton beam therapy. So there are much more in armamentarium for treating children with cancer, and not only treating them, but decreasing the long-term side effects because of our therapy. And many tumors where we know that there is a high risk of spread to the CSF, we also have to give not only to the brain, but the craniospinal irradiation is important for these tumors, and for low-grade tumors, you need to give only local therapy. And this is just to show, for example, this is a stereotactic conformal radiotherapy, where you can see how beautifully you can cover only the tumor and decrease as much as possible radiation to the other sites. And very importantly now, this proton therapy, which has become standard of care, especially in the West for brain tumors, and even Tata Memorial Hospital now has acquired, and in the next month or so we'll be starting a proton therapy unit, where you can see that the tumor, when you give proton therapy, it only radiates the tumor. The exit dose is not there, so that especially in areas like the spinal cord, the brain, where we don't want this other external, the exit therapy dose to be given, you can beautifully cover the tumor only with your proton therapy and prevent basically the radiation from going to the other sites where we don't need it. So the advantages of proton therapy is reduced acute and late toxicity, reduced integral dose, and reduced second cancer risk. So we are trying to see how many children we can treat with proton therapy once it starts at a center. And then the chemotherapy, basically chemotherapy, some of the patients, the young children cannot be given radiation therapy, some require systemic therapy also. So especially tumors with PNETs, medulloblastoma, germ cell tumors, lymphomas, etc. We require to give them chemotherapy also. These are the various drugs that are used, but most common is vincristine, vinblastine, temozolomide, and cisplatinum. So these are the common drugs that we use. And just the key points is that basically CNS tumors, like I told, is the second most common form of pediatric cancer. Majority are infratentorial in location, and these are basically the surgical treatment is the best treatment for most of these tumors, and especially for embryonal tumors, these are more responsive to chemotherapy than in adults, and outcomes are now better with systemic therapy, and radiation is used with caution, especially in very young children, for decreasing the long-term side effect. So that's it. So that was brain tumors in brief. But this is what I wanted to show. We know in India, Africa, very important. We have luxury cars like this Audi here, but at the same time we have bullock carts also on the road. So we have to, we have nothing to feel ashamed of that, but we have to take care of both these people when they come to us in the hospital. And that is why we are working a lot on what we call metronomic therapies. And we are using really low-cost drug repurposing type of therapies rather than the drug discovery and the newer molecules. So we have published, this is there, if some of you can read or may have already read that, there's a lot of good data for pediatric cancers, what we use the metronomic therapies. And I'm just showing you this thing, for example, for these soft tissue sarcomas that we have using, simple thing like this is a repurposed drug, tamoxifen here, it's not a hormonal therapy, but it's an anti-angiogenic therapy. This is a high-dose tamoxifen, oral etoposide, cyclophosphamide. As you can see here, a patient who had progressed on after standard therapy, given just this oral therapy, and you can see nearly total regression of the disease, and this is a long-term which has been published. We have seen excellent result in patients with recurrent, resistant, relapsed patient of soft tissue sarcoma. So these are very important therapies which can be used in the clinic. And not only us, actually now there's data from US also which shows they are using the maintenance, oral metronomic maintenance in patients with rhabdomyosarcomas, where they have shown improved overall survival even after the standard therapy. So this is becoming more and more standard of care, and this is what I had showed in my previous talk, where we now use not only metronomic therapy, but metronomic therapy takes care of your negative immunity. There is a suppressor immunity and a stimulatory immunity. So the suppressor immunity, your T regulatory cells, the myeloid-derived stem cells, the macrophages, all these are negative immunity. That is not taken care of by your immune therapy, the checkpoint inhibitors and the CTL4. So they take care of the stimulatory immunity. So if you combine stimulatory immunity to stimulate the immunity and suppressive and drugs that can suppress or take care of the negative immunity or the suppressive immunity, it will work better. And that is why the combination of metronomic chemotherapy plus the immunotherapy may work wonders. And this is exactly what I showed we did in our head and neck cancer patients, where we used very low dose 20 milligram of nivolumab along with triple oral metronomic therapy, and we showed the improvement in outcome. This is in relapse, recurrent or advanced disease, so it will work much better in patients with newer disease. So we are working on that, and maybe in the next meeting we may have something more to present for that. So overall what you can see is that for most of the tumors now, we have improved the outcome. Even in our setting, the outcomes have improved a lot, but there's still, for some tumors, we have a lot to improve. We are working on it at present. But very importantly, these children have to be treated in a dedicated pediatric cancer unit, because you see here, the loss to follow-ups, the toxicity, relapses, everything is much less in a dedicated cancer unit compared to if you randomly treat a child with cancer. And this is what we are doing now at the Tata Hospital. We are giving them holistic support that's not only financial, We arrange accommodation for them. There's infection prevention, nutritional support, transfusion support, psychosocial education. So all this support is given, and everything. So no child has to pay a single rupee, like the St. Jude's in USA. If they come to Tata without any financial or any other support, we arrange everything for them. And because of that, you can see our loss to follow-ups or treatment relapse refusal rate has decreased from 25% to less than 5%, and this has remained constant for the last at least 5 years now. So definitely all this support has improved the outcome. So what is needed is, like I told you, it takes a village to treat a child with cancer. The treatment is multifaceted: pediatric oncologist, pediatric oncosurgeon, radiotherapist, interventional radiologist, pathologist, nutritional psychologist, social worker. So many people are needed to treat a child with cancer. Very, very important is good nurses who can handle children. So these nurses are also very, very important part of the team. As we know, the treatment of childhood cancer is aggressive and expensive, and at the same time treatment is very intensive and prolonged. So a dedicated pediatric cancer unit is very, very important if you have to treat children with cancer with a curative intent. And this is very important. We always say that childhood cancers are curable, but importantly they are curable if they are diagnosed early, if they are diagnosed properly, and very importantly if they are treated appropriately. So we always say that every child with cancer deserves the best chance of cure. And for those who are interested, you all are interested, in April 2023, we have our next pediatric solid tumor workshop. Every year we have, which is very well attended. So any of you are interested, check with the Merck people and get registered and come and spend some time there. Thank you very much.
I congratulate Merck Foundations for hosting this Luminary 22 in the great city of Dubai. In fact, Dubai is a dream city. I'm speaking from Ibadan, which is the southwest of Nigeria. The topic is development and implementation of virtual pre-chemotherapy consultation. What is virtual health? Virtual health is the use of information and communications technology for health care delivery. It was in 2005 when the World Health Organization identified virtual health as a global health priority. What is the justification for use of virtual health? The high increase in rural and remote population is one of the justifications. Of course, during the pandemic of COVID-19, the oncology community was prompted Hello, is it okay now? The echo.
Professor, you can change your slides. We have given you rights. We have given you access to change your slides.
Okay, yeah, that's good. That's all right. No, justification for use of virtual health is due to the high increase in the rural populations. The advent of COVID-19 in 2019 led to commencement of widespread use of virtual health in the field of oncology. Of course, there was need for this virtual health because we had to limit interaction with patients. What are the attributes of virtual health care? 1, consultations of patients is possible. Interventions are possible in diagnosis, in treatment, in follow-up of patients. We can also carry out remote monitoring of patients. We can supervise our clinical staff on ground with the patients. We can have documentation, electronic documentation. The virtual health is also associated with decreased costs. And improve access to care. What do I mean by that? When we carry out pre-consultation pre-chemotherapy virtual consultation, the patients can be at his or her base. We can be here. They don't have to travel. They don't have to travel for counseling. They don't have to travel for pre-chemotherapy sensitization. It involves practically no costs, you know. And then the virtual health has demonstrated high patient and provider satisfaction. Where it has been practiced, they've shown that the patients and the provider, they were satisfied. The virtual health is also very useful in chemotherapy services. What are the virtual options in chemotherapy? That is the usage of virtual health in chemotherapy services. One, counseling. Counseling is very important before we carry out our chemotherapy. You know, we can sensitize them, tell them about the side effects, tell them what's the meaning of chemotherapy drugs. How do the chemotherapy drugs function? What are the prognosis using chemotherapy drugs? We can also carry out pre-chemotherapy evaluation of our patients, psychological, etc., etc. As I mentioned, patients' education on cancer chemotherapy can be carried out. During virtual option in chemotherapy, you can discuss about oral drugs compliance. Because when patient goes home after chemotherapy, some of them are after chemotherapy in the hospital, some of them are oral chemotherapy drugs. And we need to really discuss with them how they comply with usage of chemotherapy drugs, like some of our hormonal drugs, etc., etc. And then we evaluate them. Other aspects of virtual options in chemotherapies, we can discuss about, apart from their medication, also about laboratory tests. We will advise them why it is important to have all these tests. So this is also one of the good aspects of virtual options in chemotherapy. But before we commence virtual pre-chemotherapy consultations, we need to do the following. We have to assess the patient's technological capacity. Now, assessment of patient's technological capacity. Can you change the slide for me, please? On the assessment of patient technological capacity. Yes, thank you very much. Yeah. Now, the first question is there availability of internet services with the patient, and of what quality? Does the patient even have the money for data availability? They may not have money, you know. What type of device does the patient has? Now, we've got to have minimum documentation of virtual visits. It's very important. We should document and state participants who are attending the visit. It's very important. We should document location of the patient another healthcare givers present at home or in other location with the patient. We should document what type of visit do we have. Is it audio visit or video visit? In our documentation, we should state if the telehealth visit was completed or not. Next slide, please. Next slide, please. How do you conduct virtual visits? How do you conduct it? A support person should be available to the oncologist or any other healthcare professionals. And initial in-person visits to the patient should be carried out. This is important for formal physical examination and investigations. Next slide, please. The virtual pre-chemotherapy assessment will help in a lot of ways. It will provide low stress setting, helping patients to absorb information on their treatment. That means before the patient gets chemotherapy, we relax them. We give them enough information about what is called chemotherapy treatment. This chemotherapy treatment should be given on a day separate from the day we shall administer the chemotherapy. This is important, so as we're able to prepare the mind of the patient, relax them, and give them psychological calm before the day of the chemotherapy. Virtual pre-chemotherapy assessment will enable these patients to reflect carefully on the information they receive, these side effects of chemotherapy, and they will ask us, they have opportunity to ask us any question on the chemotherapy that will be given. This virtual health will also ensure that the patients are better informed and prepared for chemotherapy. It will help to reduce anxiety. Next slide, please. When we are carrying out the virtual health, the virtual assessment tools should ensure patients are assessed at the same frequency visits as in-person assessments. This is for research, this is for comparison, this is for auditing. It's very important. The virtual health should be carried out the same week as chemotherapy. The virtual health should ensure and check whether the blood tests are done and results are reviewed before chemotherapy is carried out. And then the virtual health, of course, as mentioned earlier, will ensure that we educate the patient properly about the process of chemotherapy and how it works in the body, how it kills cancer cells, and at the same time, what kind of side effects it will give the surrounding normal cells, and how we can ameliorate, reduce, minimize the side effects from this chemotherapy. Because many of our patients, they believe that chemotherapy will kill in the African setting. It will kill. They will rather go to the alternate medical practitioners. But when they know that we have resources to minimize the side effects of chemotherapy, they'll be better reassured. Next slide, please. Virtual health will help us to manage and report side effects of chemotherapy, such as diarrhea, nausea, vomiting, fever, etc. It will help us to find out, is there any other medications patient is taking? Is there a comorbidity? Is the patient having cancer and diabetes or having hypertension? Other diseases, we'll be able to advise them, and we take note of that. We also, during the virtual health, we find out if the patient will continue with the chemotherapy and at the same time a normal occupation. We shall evaluate that. During the virtual health, we will advise the patient on general health. General health is important. During during chemotherapy, she should avoid contact with people with infection, cold, cough, catarrh. And then during this process, we advise them on to avoid traveling long distances. Next slide, please. From experience, it is evident that patients with cancer receiving chemotherapy, whether intravenous or oral, can be followed virtually. We should also take note that when we are carrying this virtual health, we should make sure that locally accessible healthcare providers are arranged for in-person physical examinations, interventions, and to advise the patients. This can be done by the managing physician. As we continue with chemotherapy, during the virtual health, we should make sure that decisions are known whether the patient will want to continue or discontinue chemotherapy. Next slide, please. What's the importance of virtual chemotherapy consultation? The workload of the conventional chemo clinic can be divided, is even reduced. When we do the virtual pre-chemotherapy consultation, we're already carrying out consultation, chemotherapy education. This is a time that we've been using in our conventional chemo clinic for years. It can be reduced because during the pre-chemotherapy consultation, we are doing it already. We are giving them counseling. We are giving them chemotherapy education. So we are minimizing the workload at the chemo clinic. We are also, with this virtual pre-chemotherapy consultation, we are reducing the waiting time of the patient. Patient comes for, in the old days or before, patients come for chemotherapy. Of course, we have to start with counseling, education. This is time. It's taking the time of the patient. It's taking the time of the healthcare giver, the oncologist. What I've done, virtual pre-chemotherapy consultation, we've gone through this, and the stress of waiting time is reduced. Patients who have traveled long distance for chemotherapy, we don't have many chemotherapy centers or radiotherapy oncology centers generally. Many of them travel from long distances. Now, when they come, and we've done all the virtual pre-chemotherapy consultation, they'll be able to travel back as soon as possible from their long domain. In fact, those who have come very far distance, they are bored, they are tired of spending a very long time at the clinic. So our virtual pre-chemotherapy consultation has helped to reduce the period of stay, in the clinic, probably too far from their board of the place where they live. I haven't given time for virtual pre-chemotherapy consultation. We now have time for other informations and questions they may have. They may have other questions for us, apart from our counseling and chemotherapy education. There'll be enough time for all those other questions and informations. The virtual pre-chemotherapy consultation is very important and attractive for patients on oral chemotherapy. Many of our patients, not all of them are literate. Maybe 70% are not literate. They need this consultation for us to educate them, especially oral chemotherapy. We can deal with chemotherapy in the clinic, but when they go back to the villages, they need to be well educated, to be well informed, especially about the oral chemotherapy. So many oral chemotherapies, many of these patients are on hormonal, etc., etc. So it will be very helpful for them. Next slide, please. Next slide, please. But virtual pre-chemotherapy consultation is not without its own problems. One of the problems is that being virtual, we don't have proper assessment of the patients, 100%, we don't. Hence, we need to incorporate physical meeting as a backup. Another point we should note is that there is lack of infrastructure for both patients and healthcare givers to provide optimal virtual care for cancer patients. We can still not avoid the fact that virtual pre-chemotherapy consultation is still lacking in the fact that we are not physically with the patients, and we cannot be as exact as when we are given physical care, physical consultation. It's not as we cannot compare, though pre-chemotherapy virtual consultation has the advantages I mentioned earlier, but we cannot say that it's as effective 100% as the physical visits. Virtual pre-chemotherapy consultation has benefits. Like we mentioned earlier, it can reduce quality of interactions, with clinicians. And hence, another issue is that it's less attractive for some cancer patients. Some cancer patients want to see their doctor physically. They don't want to be speaking to some spirits or ghosts. So you see, while it has so many advantages, there are still some issues that they are not perfect in. Can I have the next slide, please? Next slide, please. The paradigm surrounding virtual cancer care has shifted from us just using them as a tool to assess care. They're not just to assess care, they have become an essential part in cancer care, especially in chemotherapy services. The elderly patients love it because they don't want any stress. They prefer to have this, to be informed, to be educated with less stress, not traveling far for consultation or for education, but the virtual pre-chemotherapy consultation has dealt with that. I will implore that we as oncologists review this new modality, which came into effect only 3 years ago in the oncology practice worldwide effectively, and to make sure we maximize all the benefits from this process and for the improvement of quality of care in our cancer patients. Next slide, please. I thank you for your attention. I'll be waiting for your questions, and we may have more discussions. Thank you.
Good morning, everyone. I hope you are not so hungry after that break. So I'd like to present myself. I'm Dr. Fauzi Jasmine. I'm from the Republic of Mauritius. So I'm going to bring you now to my country after you have visited India and the whole of Africa. So we are such a pretty island in the middle of the Indian Ocean, midway between Africa and India. And why Republic of Mauritius? It's because it comprises of the island of Mauritius and the sister island of Rodrigues. So all our statistics, all our treatments, and all our opportunities are from both islands. So that's why it's now Republic of Mauritius. It's situated around 550 miles away from the east coast of Madagascar. We are a multiracial country, so we've got people from Asian origin, African origin, Caucasians, Chinese. Like we are, like Mark Twain said, we have been copied from, paradise has been copied from us. So not to be bold, but just refreshing your minds, all of you must have heard. We have actually 5 regional hospitals, a central health laboratory for the whole of the island. We've got a population of 1.2 million inhabitants. We have got a GDP per capita of $5,514 US. So we are doing quite well on international level. And also we have got a capacity of around 3 per 1,000 beds. So just to tell you briefly about my country, the topic which I was given is in fact more of an international one, but I'll try to make it according to the Mauritian context. So clinical research is currently not being done in the Republic of Mauritius. However, we do have cancer researches based on epidemiological factors, clinical, radiological and pathological correlations, as well as benchtop or benchmark researches. So why do I want to start with breast cancer? Because actually, despite Mauritius being so loving and so nice on the world map, we still have the highest rate of breast cancer throughout Africa. I'm going to show it to you in the next slides. So in females, because it's female empowerment, right? Merck Foundation. So breast cancer is the #1 in Mauritius. For the past 10 years, it's been on a rise. So how do we know about that? It's because we have got a Mauritius National Cancer Registry for cancer cases, which gives us a yearly report. So this report dates from 2020, and just before leaving Mauritius, the Mauritius National Cancer Registry being situated in the Central Health Lab, we have got data collectors based with us, we have got our statisticians and a newly recruited epidemiologist. So for a small Indo-African country, we do have a big repository. It is according to this that we do our regulations, policy makings. So as you can see, breast cancer cases in females is around 500 new cancer cases for the past 5 years. And we have also accounted for males, 5 new cases. All birth and all death are duly recorded by the civil service status. So our cancer registry is one of the most reliable ones, because we don't have any deaths or any birth which occurs in the Republic of Mauritius which is not being registered. The government has given several opportunities for parents to make sure that they come to register any birth and any death. So all parents are given a certain sum of money, so they have to come for registration, and the deceased have got a special death certificate with an algorithm and with a QR code which needs to be recognized. Otherwise, the deceased person relatives cannot process with any legal matters. So as we can see, the mortality is high in cases of breast cancer, 184 cases compared to the ASR world, which is 17.7 per 10 to the power of 5. The total number of cases, dear colleagues, is quite surprising, because we register a yearly record of around 2,500 to 2,800 new cancer cases for the past decades. And the death due to cancer, like I have already told you, so no death goes unnotified. It is 1,431. So like I have presented you, over a population of 1.2 million, we are having so many new cancer cases, so many cases due to cancer. So the government of Mauritius has decided that needs to be done upon capacity building and upon training, and also in implementation of new criteria. So the female breast cancer case, being #1 in the Republic of Mauritius, is a public health problem. In most of the African countries, even Asian countries, or throughout the world, we all agree that these are the triggering ones, and these are the first cases that create public health problems, because nowadays all communicable NCD cases, they come in the second line. According to the cancer registry, like I have told you, there is a female predominance compared to males, and we do have cancer screening programs throughout the island, in mobile caravans, in area health centers, as well as in our 5 regional hospitals. So in cases of breast cancer, we have got the breast self-examination, which is being taught from school education. So from a certain age, all girls, as from the age of 16, they are being taught breast self-examination by our formed nurses. Then we also have got pap screening. Now, since 2022, we are no longer doing the conventional pap smear. We do liquid-based pap smear, which is faster to be done by the gynecologist, which is also more faster for the pathologist to read, and the reports are given quite fast because, like Dr. Really said, that a simple pap smear can give you so much information, and we can just rush to know what are the guidelines that need to be followed according to different stratifications. And like I have told you, we are the highest in Africa in cases of breast cancer. Here you can see these are the trends which have been done and published by the AFCON. The Republic of Mauritius is also a member of the AFCON because we have got a national cancer registry which is helped by them as well as with the IAEA. So we publish yearly reports in collaboration with them, together with the World Health Organization and of course the Ministry of Health. So dear friends, from this chart you can see that there was quite a subtle rise from the 90s to year 2000. However, you can see the drastic range from 2000 to 2016. I have not included other years because our statistics till 2022 and 2021 is not ready. But from this only, we can have an idea that it has come from around 700 cases to 2,000 in these more than 2 decades. So there is a rush and there is a need for early prevention, early diagnosis, early treatment, and early surgery. Chemotherapy, surgery, pathology, everything goes as a multidisciplinary team work. Same like Dr. Banavali rightly said, I got this beautiful word to bring to my country now, it's a village. So we should agree that we should walk hand in hand to make it agreeable, suitable, and most convenient to the people of Mauritius, not only, dear friends, also to your country. So we've learned so much from Africa, from India, from the US, because sometimes we learn so many things, but we can take pieces from all countries and try to adapt to our system, because all of us have got constraints, we have got contingencies, we have got financial issues, we've got business proposals that we need to fit in our budget. So all of us, we should just bring some pieces from everywhere and make it like the Mauritian one. So that's what I did in the next 4 years. So just to tell you, we had made a comparison which we published in ASCO, so the international conference which I joined in the year 2018. So you can see that compared to the highest countries, Nigeria, Egypt, South Africa, highest population, Mauritius, since it is based on the age standardized ratio, so we can see that breast cancer was the highest, because comparison on the number of cases is no longer a modality now. It is upon our region, upon our age, and upon the number of people. So a survival study was also carried out. Like I told you, we are part of the AFCON, so we have got the cancer registry, which does some of our graphs. So here you can see that with time, we have seen that the survival has considerably improved because of better surgical facilities, better histopathological diagnosis, better surgical acumen, better chemotherapeutic drugs, but all have been there in order to increase the overall prognosis and survival of our cancer patients. Because all of us here in this room, we are here why? To learn from each other. We are here to be like team building. So we just want to rope in everyone and just get ideas from everyone and then just bring it to our country, motherland, and just to implement it. Though it may be quite challenging. So, concerning my topic, why I wanted to adopt it according to my country is, like I told you previously, we don't do any clinical research. Though when I was doing my postgraduate, I was bound to do clinical and benchtop researches. So, what is the definition of clinical research? It's quite simple. It's a comprehensive study for safe and effective promising advances in patient care. So it got all the beautiful words there. So this is what is clinical research. Unless and until clinical researches are not done, because we should be very thankful to all the volunteers throughout the world, be it Africa, be it India, be it anywhere in the world, those people who come forward and clench into these clinical trials, despite them suffering from cancer, which they know maybe they're stage 4, remission could be very bad and outcome could be very poor, but however, they do help us, clinicians, scientists, everyone, in order to be able to improve further cancer research outcomes. So we should be thankful to these people and grateful forever. So what does it have? Like I've told you, it makes a big impact. Already said, in cancer research, in treatment, in chemotherapy, the list is very long. It tests for safety, like I've told you. Any drug or any tool or any surgical new technique, we should have got the volunteers to be able to carry it out. So when doing these clinical trials, dear friends, only then we would be able to know whether it is safe, whether it can be released to more of the cancer community, or the failure rates have been too much. So we need to, just like we say in French, reculer pour mieux sauter, means we just go back so that we can jump further. So it's very important, safety, because all types of surgeries, all types of chemotherapy, they are dangerous. They do have side effects. We can't say that we do things without taking a risk. We all do things with a risk, but we want to minimize the risk. So what we do is, safety is very important. It gathers information, like I have told you. We have got repositories, we have got data sheets, we have got the cancer registries, we have got data banks. So all these are important for improving the clinical research for cancer outcomes. It removes bias, means no one is partial. So we can know the probability, plus minus, whether it is less than 0.05, more. So it's very important in cases of several research. Can you please? Next slide. So, like I have told you, all of us here, we know that clinical research is important in decision making. So decision making is to, I think there is one slide. Yeah. Yeah. So, like I have told you before, clinical research is so important because it improves medical procedures, anything from surgery to laparoscopy to now what is on the trend, minimally invasive for cancer patients. Policy making, all decision makers, stakeholders, directors, ministries, everyone is on board. Improvement of all laboratory tests for tumor markers, immunohistochemistry markers, sequencing nowadays, liquid-based biopsies, molecular testing, like I have already pointed out, diagnostic tests in the radiology department, ultrasound guided. Now we've got MRI, CT scan, PET scan, which is just acquired by a private clinic in the Republic of Mauritius, which is definitely helping us a lot in minimal residual diseases and also in cases of staging. Targeted oncotherapy drugs and vaccines. Then, like I have told you before, in decision making, policy making, prevention, diagnosis, and treat. Like we usually say now, everything comes with personalized medicine, precision medicine. Each one of us in this room, we may be from
different countries. You may be from Africa, but not all of you are the same. Not all of us from India are the same. Each person has its own gene. Each person has to have its own personalized treatment. That's why nowadays, like in several developed countries, they are taking one person at a time. Why do we do MDTs for all cases? Because each person has a uniqueness in himself or herself. So that's why we say therapeutic. So we are doing prevention, we are doing therapeutic, and we are doing diagnostics. Then we have got several workforces which are important to establish cancer plans. For example, in Mauritius, we have got the NCCP, which is the National Cancer Plan, which is being done by several consultants, including juniors. Why have we embarked juniors nowadays on several action plans? Because they are new blood, they are fresh blood. They are the ones who've just come and they are full of ideas. We should listen to them because maybe we are just so much involved with our clinical acumen, with our patients, with our OPDs, surgeries, OTs. But the young ones, the fresh bloods, the ones you can identify, they can be full of knowledge, they can be full of intentions and full of good opportunities for the country. So we do embark them in NCCP programs now. National Cancer Action Plans in the Republic of Mauritius is done every 10 years. And in cases of treatment, de-escalation, which is very important because a cancer patient needs to be supported by the village, like Dr. Banavali said. So you need to have emotional, physical, spiritual, yoga, everything is just embarked so that the outcome is one of the best. So what to say about the importance of clinical research is it's a key part of our healthcare community. Like I have told you, it fuels, it just boosts up everything so that we can save lives, those who are coming with early diagnosis of cancer. And we are thankful, like I have told you, to all these volunteers who participate in clinical trials. Now, I just want to boast a little bit about my department. So I'm responsible of the immunohistochemistry department in the Republic of Mauritius. This I should be very thankful to Tata, to Dr. Banavali, to Merck Foundation for having given me the opportunity to stay at Tata Memorial Hospital to get the acumen, the training, to be able to set up an immunohistochemistry, because nowadays, rightly said previously by our seniors, that histopathology, dear friends, is not enough. I know in Africa, it might be very, very challenging. Even in some places in India, in some remote areas, can be very challenging. Even for the Ministry of Health of Mauritius, it was very challenging because once we're bringing the business proposal, the first question before you just sit down is, dear doctor, how much will it cost? How much? But we should be like, please sit down, let's discuss about it. Let's talk what can be done. Maybe we can't do everything at one go. Maybe I can't be like Tata, I can't be like TMC, I can't be like USA where I did my training. I can't be like that. But I can save lives in my country. I can. And I should do it. Why? Because I'm passionate about that. I have to do something. Because why? I can't see the number of breast cancer cases just rising and surgeons just doing mastectomy with level 1s and no treatment, just everyone being given tamoxifen. No, dear friends, we can't continue with that. So when I returned in 2017, after training from Tata, and I should be very thankful to all my professors because the fact I was very passionate, they say, come on, we'll give you a hand. So how to approach your ministry? Because sometimes you look very young. They can say that she's too young, maybe she's coming with some advanced technologies, but we just want to stay back and be happy because, you know, at times in Mauritius, it's a stigma. Cancer is still. Some people may be having breast lumps and they're for like 5 years and they don't come out. But we have been able to start with the lab. So, like I'm telling you, in 2017, when I came from Tata, I was trained on the Ventana machines, which is state-of-the-art machine from the US, and in Tata also we had the same machines. So I was a little bit cunning. I didn't go alone. The director told me, you have been offered a scholarship. I said, yeah, I'm very happy, but which machine will I use? Would it be done manual? Because I'm not very keen for it to do manual. Then he said, okay, we are going to look with WHO so that you can get a machine. I said, but the machine is not enough. Who is going to do the test? Then my director told me, oh, you are quite wise for your young age. I said, of course, I can't be the reporting pathologist. I do the test and I run the machine myself, so I should bring in someone with me. Goes together and hand in hand. Effectively, I got one technician with me, Mrs. Amrita, and with the WHO machine, when we went for evaluation, I was a bit mean with the ministry. I said, please send another person. So 2 persons went at a time. One went to South Africa and the other came with me so that we could speak the same language, because sometimes building capacity doesn't mean sending only your doctors. It means to send your technicians, send your lab managers, send your quality assurance manager. Everyone in any places should be involved. Your nurse oncologists are one of the most important people, dear friends. I have seen them working. Your OT nurses, they are just like the gold you're wearing with the diamonds. You can't go without them. They have to be side by side and hand in hand. So I brought her together with me so that she's able to know how to run the machines and how we can perform, because the fact that we are having so many cancer cases, I told myself that 1 run in a day wouldn't be enough. We should be at least 2 runs. And this is an automated machine, so it could be run overnight. So in 2017, we acquired that. WHO, like I told you, gave us the Ventana. In 2019, I was a bit meaner for the budget. I asked for a backup because I got an issue with the drum. So IHC was down and manual ongoing for like a month, which was very tiresome for the technicians. So I asked for a GX. The ministry was saying, oh, Dr. Fauzi keeps asking, but the results are good. Patients are getting the reports quite on time. You just have to satisfy the receiving end and then you get your job done. Unfortunately, you have to be at times mean and sweet at the same time. So just now we have received the state of the art. I'm very grateful to World Health Organization and to the Ministry of Health to bring their confidence in me to be able to have this machine, because this one does the work of 2 machines. So hand in hand, I have got like 3 machines running in one day. The backup, we tend not to tire it too much. It runs at least once a week for soft tissues, and we have also dedicated them so that there is no cross-contaminations. So we try to do quality assurance with Tata Memorial, like Dr. Banavali rightly said, my dear friends. National Grid is very good, so we had an MOU for an EQUAS with them. So we check our results every now and then. And I'm trying to clone myself because that's what Merck and Tata told me. So it can't be one-man show because right now I'm here. So it's quite difficult for my colleagues. So I have one colleague. I'm currently training her so that I can go abroad more often and go on holidays. So just to show you the process flow, so this is Mrs. Amrita. She came with me. So Amrita has cloned herself into Miss Chitra. So she's the one who's, both of them, they're responsible. Mr. Shamim, unfortunately, he was not there, the one who went to South Africa for training. He was on holidays. So we have got, fortunately, our own department now, our own microtomy, our own bath. We have got our own machines. We have got everything on ourselves. The immunohistochemistry section in the Republic of Mauritius is just autonomous on its own. And like we have got many issues among pathologists and among clinical oncologists, I had to develop 2 kinds of immunohistochemistry forms. So we had to develop one which is in-house. We are currently running with around 48 immunohistochemistry markers. The government has granted me a fund to increase it to 55 immunohistochemistry markers by next year, 2023. And we also have got a form abroad. So we usually send difficult cases and immunohistochemistry markers which we don't have abroad. So we do partly in-house. We cut the cost. Then we just pay for abroad to India or South Africa and even to the UK. We send for second opinions and for further immunohistochemistry markers. And I was, after so many years, means 2017 with the COVID and everything, one day one consultant oncologist called me and told me, Dr. Fauzi, you know, we are not getting your reports. I said, that can't be. Why you can't be getting my reports? Doesn't make sense to me. Then she told me, no, I'm telling you really, I'm not getting your reports. Then I say, are you not getting my reports or are you not finding them in the files? Then she was quite quizzical. She told me, I don't understand your question. I said, could you find them in the folders? Oh, it's difficult because all cancer cases in Mauritius, we haven't gone paperless, so we are still using big files. The files are very big. To look for any report, any blood result, any radiological report, they found it quite tedious and quite tiresome. Sometimes they would just tell the patients. I have once witnessed myself. Unfortunately, the oncologist didn't know at that time I was a doctor. So just then Ramesh said, oh, you know, the IRH report is not here. The histopathology is not here. Because they have so much in the OPD. They can't have the time to rummage through. So we decided to go for color coding. So now I've stopped receiving complaints that your reports are not, because we have a very good turnaround time for immunohistochemistry. So all breast markers, ER, PR, Ki67, and HER2 are already given within 1 to 2 days. Yeah, so we do it as fast as we can, because for neoadjuvant chemotherapy and also all endometrial cancers now are subjected to hormonal receptor testing. So we decided to put pink because breast, because this is the one which goes more in view of the high number of cases. Then the other color, any other for lymphoma panels, neuroendocrine, soft tissues and all, we use the blue one. And since we do HER2 testing for all patients systematically without the oncologist sending us a request, so we have done in situ hybridization just to cut down the cost on fluorescence in situ hybridization. And since you know I'm very mean, I said once you get white reports means you've got the report but you're asking for a duplicate. So any white report which you still can't find in your files means the original has gone and the second one is just a duplicate. So dear friends, like I was telling you, all HER2 equivocal cases, we haven't gone for fluorescent in situ hybridization just to cut down the cost. So my machines do dual in situ hybridization. And like all centers of you who might be knowing, the more we do, the more the cost goes down. And the better, the faster the treatment for the patients. So actually, I have adopted this from TMC. It's a TMC copycat. They just told me that you adopt it according to you, but they helped me to design it and how to make it easier so that they understand amplification and non-amplification. So I use my routine microscope, chromosome 17 to 13. I've got a special reporting sheet on which we visualize 20 fields and the next 20, so in all 40 fields are being counted. It's black against red dots. It's quite easy, but I need to have someone who marks it for me, because sometimes while changing the fields, we can have issues in the number of cells which we are counting. Following that, we have also been able to do a small research. So on 106 cancer cases, we have found out that in the Republic of Mauritius, there's a prevalence of luminal B compared to most of your countries where you have got a high rate in triple negative. So for us, it's mostly ER/PR positive, a high versus a low Ki67, the proliferative index, and a HER2 negative. Sometimes we also have got HER2 positive, which is included in the luminal B. So what has been the achievement from 2017 till date? So we have got a poster presentation, which we made, and we have got the best poster by the Ministry of Health and the University of Technology in 2018. And we have just published the trends in cancer incidence, because like I have told you, the cancer registry, the laboratory, immunohistochemistry section, we are all together. We are just in one team. So it has been published in the Science Direct Journal. And just recently, 2022, we did the first case control female breast cancer epidemiological study in the Republic of Mauritius. It was not easy, very tedious, but we had got the help of the University of Mauritius together with several stakeholders, because we definitely want to know what's in the basket for us. What is there that's causing so many cancer cases? One of the professors, Professor Adebamo, when he came as a consulate, he told me, you know, Jasmine, Mauritians should stop getting married to Mauritians. Break down the gene amplification. You should get married to other people, because it's true sometimes when you think we're just an island, so some way or the other, we are related to one another. So we are just increasing the genes. So I've just given you an idea, those who want to get married to Mauritians. So what's our vision for 2023? We have acquired next generation sequencing. We are planning to start with BRCA1 and BRCA2 for epidemiological purposes, prevention, very important. And we are also planning to use it in lymphomas, in colorectal carcinomas, as well as in lung cancers. So this was my Merck Foundation Cancer Access Program, for which I'm forever grateful, and for which today I'm standing here and sharing everything with you. And these are the references. And this is regards from my beautiful island, from Mauritius. So the director of the lab, my clone, like I told you, the doctor, and then Mrs. Amrita and her clone, Miss Chitra. Thank you so much.
Thank you. I hope you will hear at this later when your cells are dehydrated. But let's try. In the beginning, as I had presented this slide in the morning, and since you are the same team, I don't want to repeat it, though it's not exactly the same. But after the description of what looked like CML in 1845, first of all by Bennett, then Virchow, then there was that confusion. Bennett attributed this to some infection. Virchow thought it was a neoplasm, a hematological neoplasm. And then again, as happens when two people from different parts of the world describe an entity, and then meetings are held, nobody knows who was the first one to describe it. So lots of people attributed this initially to Virchow, and others attributed to Bennett, and after a lot of arguments, Virchow then gave up and said Bennett actually was the first one to describe the case that was later known as CML. And this progress cannot be repeated. You all know about the discovery of Philadelphia chromosome. The BCR-ABL gene we talk about it all the time, because whatever we say on CML is basically BCR-ABL, nothing else. And the spleen, those two. So then there's that 922 translocation. We talked about the chromosome, the ABL oncogene on chromosome 9 and the ABL oncogene on chromosome 22. The split and then the reuniting and the reuniting of the BCR and ABL gene that now codes for this famous tyrosine kinase. And as you know, in the cellular transduction inhibition, we have got the tyrosine kinases, we have got the post-phosphorinositide 3 kinases, and we have got the serine and threonine kinases, the bigger group being the tyrosine kinases. Now, again, the pathways that lead to leukemogenesis are those ones depicted, the RAS-RAF MAP kinase, JAK-STAT, PIK3, and the hedgehog pathway. Now, the clinical presentation, as we knew when we were students, is a big spleen. But then there are more details. It's not just the big spleen. But a lot of them come in with abdominal pain, abdominal discomfort, abdominal swelling. And in countries where patients, the healthcare facilities are robust, you get incidental findings. Patients can be discovered incidentally without necessarily having a presenting mass. Now, not all patients will come with splenomegaly. And when spleen occurs, what causes it? It is known to be obvious that, well, spleen is large because of pooling of blood, period. And then in your practice, you see patients with huge spleens, but then you see total white counts and the others are not that high. So which blood is pooling when the white cells are not that high? So we wondered and decided, well, why don't we do a study just to be sure that this is what we are seeing? It is like rediscovering the wheel, but so what? The wheel can always be rediscovered. We looked at the cases that was presented to us from the University of Utah initially, where most of their patients had presented with fatigue, not necessarily the spleen. But then on physical examination, 95% of those patients had splenomegaly. But then weight loss, abdominal fullness, and the rest came in. So we said, well, maybe we are seeing similar kind of findings, but not necessarily the same. We are stuck again, but we'll proceed. Dang. So we wanted to verify the correlation between various baseline myeloid elements in circulation or bone marrow with clinical manifestations in chronic myeloid leukemia in our patients that we are seeing. And we wanted to see if there was correlation between baseline BCR-ABL over ABL percentages at diagnosis with clinical manifestations of chronic myeloid leukemia. We took these parameters, the absolute range, median, mid, white blood cell counts. We did the same for absolute neutrophils, platelets, HB bone marrow blasts, and also the BCR-ABL levels. We tested this against each of the clinical presentations. Notice that quantitative BCR-ABL levels are not routinely tested at diagnosis, but at follow-up. It's monitoring. But in our setup, because we really don't have the luxury, the financial luxury of going through the banding and going through FISH and the rest, we do qPCR right away after the bone marrow, and the other tests have shown us the chronic myeloid leukemia in the face. So we looked at that time, 583 patients were included, and that male preponderance is constant. And as I've told you, it's a constant in hematological neoplasm, the same percentages. If you look carefully at all your figures, you will see that it stays there. The symptoms, the presenting symptoms, the most common one was abdominal swelling, as opposed to the University of Utah, where it was weakness and the rest. But then that weakness of Utah came in as number 2 in our presentations. And we had some very vague and clear presentations. A patient comes, they don't even know what they are suffering from. They just know they are not too well. And you examine them, and then you do tests, and you find, well, these people have a problem. They have chronic myeloid leukemia. Now we had these very rare presentations that I talked about, priapism, and the smallest group of the youngish males had priapism. Impaired vision was there, impaired hearing. These people come in blind. People come in deaf. I'm sure you have seen such patients. And priapism mainly for the young males. And of course, it's very devastating if they come in. Sometimes what happens, these people go to the chemist. The chemist, pharmacists sell their medicines. And they go looking unwell, and the pharmacists give them some medicine, and the priapism doesn't go away. By the time they go to hospital, the damage is done. It is irreversible. And so we looked at hematological values against symptoms, and we found there was no significant correlation between abdominal swelling and the symptoms. And we looked at that dizziness, and again, there was no significant correlation between that and the symptoms. We looked at swelling of the legs, and then we noticed that those who had high platelet levels in circulation are the ones who are most likely to come with swellings in various regions. The ones who had unclear presentations were those who had lowish, not low total white counts, because we know CML is a disease of high total white counts, but if you put them a range from 100,000 to 600,000, those in the 180, 90 were the more likely to come in with these unclear presentations. We looked at other symptoms. The other symptoms meaning that they are the occasional one you get in one patient, two patients. We lump them together and we call them other symptoms. And there were no clear correlation between them and hematological parameters. Now, baseline hematological values, again, gender, whereas in terms of clinical presentation, splenomegaly was more common in the males. Splenomegaly, there was no gender difference in terms of hematological values. Now, looking at age, the younger patients not only had the higher total white blood cell in circulation, they also had higher BCR-ABU over ABU concentrations at the time of diagnosis. Now, we looked at splenomegaly, and to be sincere, there was no statistically significant correlation between the circulating white cell counts and splenomegaly. But we did not look at the size of the spleen. So if we had looked at the size of the spleen from 1 centimeter to maybe 30, 40 centimeters, maybe we would have found some kind of correlation. But when you just talk about correlation of splenomegaly in general with any of those parameters, there was none. Patients who were pale did not again have any, had significantly lower BCR-ABU level percentages. This is like a fishing spree, but really you have to try to tie them together for them to make any meaning or no meaning at all, but at least you have looked around. Wasting had no correlation. Leg swelling, this one should be dropped. Unclear presentation, again, were higher among those with baseline white counts were higher among those with insignificant kind of presentations. Vague, very vague. You can't place them anywhere. And other symptoms, no correlation. Now these are signs, no correlations again. This is when they tell you they had leg swelling, then you examine them. And then you confirm. So the difference between the symptom of leg swelling and then the actual physical finding. These types of leg swellings were not necessarily just the edema, pitting edema. Some are nodules under the skin. Some are just big swellings, but not necessarily big time edema. Now, heart failure. Interestingly, we had heart failure. Again, patients who had higher BCR-ABU over BCR percentages had slightly more heart failure, and this was statistically significant than the others. Now, lymphadenopathy correlated with lower absolute neutrophils. Lower absolute neutrophils at the time of diagnosis. And again, the reason for that is not clear, and we'll try to find out why that should be. And then nothing to do with miscellaneous. So, having looked at that, what were the thoughts? When we look at splenomegaly, it was more common among males than females, and that is known. The spleen is bigger in males than females. And in fact, males tend to have more splenomegaly. So that probably was that correlation, nothing very different. It has been attributed, though, to high white blood cells in circulation. And if you look at literature, they will tell you, yes, it is the big white cells. But ours was at the 0.17. Okay, we did not take the spleen size, so we cannot stand very firmly and say this is what it was not. Now, like other studies, among young cohort of patients referred for bone marrow transplant that were looked after by Thompson and by Savage and colleagues, the spleen size was correlated with high white cell counts and was inversely correlated with hemoglobin levels. In our study, there was nothing. Prevism, which is rare, but one of the most devastating, since it affects young males more, and irreversible in up to 50% in high-income countries. I believe in a low-income country like ours, it would be irreversible in even more than 70% of the patients that have been attributed to hyperleukocytosis, pressure on abdominal veins by splenomegaly, or infiltration of sacral nerves by leukemia cells. In our setting, really, our numbers were too small and correlative analysis could not be done. Now, blindness and deafness, again, rare but devastating. Our numbers were again too small. We could not stand firm and say this is the correlation. Now, younger patients, why did they have this? They had significantly higher BCR level percentages at diagnosis. They had significantly higher initial total white blood cell counts than the older patients. They are more likely to be in heart failure at presentation. I'm not talking about heart failure due to anemia. I'm excluding that. Could it be that they were probably more rheumatic heart disease patients? There was no evidence. We did not pursue this. We cannot strongly argue on that. Now, could this reflect just brisk hematopoiesis in the youth rather than anything else? We don't know. We did not expect heart failure in the younger patients because it is in the older patients that cardiac comorbidities are higher. But as I've said, in a population like ours in low income, rheumatic heart disease may be a possibility. Though that particular disease, the days I was a student, there was a lot of rheumatic heart disease. These days, if you see one, you are looking for students to come and listen with a stethoscope because it's becoming very rare. Now, lymphadenopathy was more likely to occur among patients with lower absolute neutrophil counts in circulation. Now, reasons for this. We don't know. In CML, it has been attributed to advanced disease with extramedullary hematopoiesis. The presence of secondary myelofibrosis with cytopenias may be associated with extramedullary lymph hematopoiesis and extension. You get extramedullary hematopoiesis in the lymph nodes in the advanced disease. Here we are not very clear. Savage and colleagues had found lymphadenopathy only in patients with advanced disease only, and some other thought of synchronous other malignancy explaining lymphadenopathy. We did actually take aspirates and biopsy some of them. They were myeloid. So these were myeloid. These were not other diseases. It has also been attributed to blast transformation, but even in our chronic phases, some of them had lymphadenopathy, which was myeloid and not acute leukemia. So we are not clear on this. Now the BCR, the breakpoint cluster region, as we have said, in almost all CMS patients, there's that breakpoint on the major breakpoint cluster region, and these are the, those are the sites. And the transcripts of the 210 kilodalton, you get different size with different 25 amino acids, respectively. It is important in relation to platelets. Platelets, here platelets with patients with high platelets in circulation were more likely to present with leg swellings including nodular swellings, expected platelet clumping and the rest, though not all of it is easily explained. Such patients had lower BCR-ABL levels. Now, the correlation for this, again, is not clear. We talked about a multivariable analysis, but still at the same time, there are loose ends that needed to be tied to make sense. Now, hematomas occasioned by platelet clumping are a likely cause, and this has not been described. In a study on BCR messenger RNA and PANC patients in early chronic phase, platelet counts were high in the B3A2 positive patients. We don't know whether this correlation would hold. Now, I talked about heart failure. We did not expect it in the young group more predominantly. If it occurs, one would expect it to be correlated with the older age group. So could hyperviscosity have been a possible cause of this, but why more in the young patients than in the older patients? Data published about heart failure in chronic myeloid leukemia has associated it more with the tyrosine kinase inhibitors, particularly dasatinib, nilotinib. Most of our patients were really not even on nitrotinib, particularly first-line treatment. It was more of a imatinib. Elder patients, we know, have many comorbidities that include cardiovascular disease, so we expected the relationship. The relation between BCR-ABL levels at diagnosis, high neutrophil counts and young age, and heart failure in CML has not been documented, and we do not have a clear explanation for it. Now, BCR-ABL question is that BCR-ABL quantitative assays, the tests are not standardized between laboratories. And the reliability of some of these reports could be very difficult. I mean, if you come to a country like ours, when a test starts, everybody wants to do it independently. And whether everybody is doing it well, you don't know. But the good news that the people who do for us this is two major laboratories who do for us in our country BCR-ABL tests that we rely on. Sometimes, of course, we find it difficult to rely, and we talk to them, and if there are difficulties, we change. So our situation is unique that because of weak economy, as I've explained, we start with quantitative BCR-ABL upfront. We do not split it all the way before we do quantitative. So in conclusion, clinical presentation of CML is not directly based on volume of some circulating hematopoietic cells. And we still think that complex biological other factors may be in play. We do not look at if there's any contribution of some of the myeloid elements, like myelocytes, metamyelocytes, and bands. You never know. At the different stages of maturation, different addition molecules, the expressions, you cannot tell. And so we are still trying to interrogate this data further. Thank you very much.
So I'll start on my topic, next topic. This is my second talk. So basically, I was asked to speak on hereditary gynecological cancer. I'll just give you an overview. It's basically first chapter, very difficult to finish in half an hour. But then I'll just give you an overview what is happening. So if you see the gynecological cancer, almost 15% of all ovarian cancer and 5% of all endometrial cancer are considered to be hereditary. Okay, so here I am considering only the breast and ovary and endometrium, because breast is by the general surgeon they see. So here in the gynecological aspect, these two cancers will consider for today. So now, next, it's not moving. Okay, so you see, presentation of gynecological malignancy at a relative young age with a family history of cancer, usually of a specific cancer syndrome in 2 or more relatives. These are basically the salient features, what we see. Ovarian cancer in a single first degree relative increases the chance by 2 to 3 to 4-fold, and endometrial cancer in any first degree relative risk increases by around 1.2 to 2.8. So basically, if you can see, all the hereditary gynecological cancer, as the name suggests, they will run in the family. So these are the things we should look at. That's the importance of family history, which I have already elaborated in my last talk. Finding out the family history is very important. The elaborate family history, at least the 3 generations, above means her parent, grandparent, and great-grandparent, and downwards the son, the grandson, and the great-grandson, and laterally the siblings, the first cousin, second cousin. So you should take a very detailed history, then only you can suspect that this is the woman, maybe she is carrying that gene. So this is what we should look forward. So now if we see the gynecological cancer syndrome, these are the 5 important syndromes which may constitute 1 or 2 of the gynecological cancer. So if you see, one is the hereditary breast ovarian cancer syndrome. As the name suggests, it will have the ovary and the breast. So the genes, what are the genes that are responsible? If you can see, BRCA1, BRCA2, RAD51C, RAD51D, and PALB2. These are the genes that are responsible to hereditary breast ovarian cancer syndrome. And hereditary ovarian cancer, if you see, here you have the BRCA1, BRCA2, RAD51C, RAD51D, PALB2, and BRIP1. And in Lynch syndrome, already I have discussed in my last presentation, basically we look for this MLH1, MSH2, MSH6, PMS2, and Cowden syndrome, P10, and in the Peutz-Jeghers syndrome, we have STK11 and LKB1. So these are the genes which you look for when you are trying to find out the various hereditary syndromes associated with gynecological cancer. And what are the systems that are affected? This one I already have told. Here, Lynch syndrome, ovary along with the endometrium in the gynae. Otherwise, you have colonic cancer also. So endometrium and ovary are the 2 things. And in Cowden syndrome, we have ovary and endometrium. And the Peutz-Jeghers syndrome, we have the breast and cervix. So now, again, okay, sorry. Next. So if you see the risk of cancer as according to the various mutation carriers. If you see BRCA1 mutation carrier by the age of 80 years, almost 72% of the BRCA1 mutation carrier will have breast cancer, and 44% of the women with BRCA1 carrier will have ovarian cancer. And in BRCA2 mutation carrier, we have around 69% will have breast cancer by the age of 80, and 17% of the women will have ovarian cancer by the age of 80. And there are other mutation carriers like the RAD51C, RAD51D, BRIP1, BARD1, and PALB2. You know, these will constitute around 5 to 10% of the risk that is involved. So now, what are the different genetic tests in gynecological cancer? How to go ahead about this test? What are the pre-test counseling? What are the post-test counseling? So whenever you are asking a lady to get a genetic testing, you should know beforehand, there should be a counseling session with that lady, her family member, and then you find out what are the appropriate tests that needs to be done for that woman. And then once you have decided on that, we should ask the test to be done. And then once the test is done, you should know how to do the post-test counseling. So these are very important steps here. So now that's, as I've already told, you should know why you want to do the test, when you want to do the test, where the test should be conducted, who will be the beneficiary, and how it has to be done. So one by one, let's see. So whom to test? If you go by the NCCN and the SGO guidelines, they will recommend genetic counseling and testing for all women with epithelial ovarian cancer. But it is not feasible for each and every country, especially in India, we cannot do. In African countries also, I'm sure it will be very difficult to do. And for endometrial cancer, they say, as I've already told last time, NCCN recommends all endometrial cancer patients to be tested for MSI, MMR status, preferably using ISC for detecting MSH6 and MPMS2. So this is the recommendation, but then again we go back to think, ultimately it is the family history. Suppose this is the number one thing which you should always remember whenever you are suspecting. Do a very good elaborate family pedigree chart. You can make a chart like this. This is the index patient, and you should draw it like this. So this is how you make. It's there in the internet how to generate a pedigree chart, family pedigree chart. So you get every file, all young patient coming less than 50 years, coming with ovarian cancer, endometrial cancer. You should always try to, in the history, you should always try to make a family pedigree chart. That is very important, how to make it. So this is important. So now, as I've already told, the testing is 3 important steps. One is the pre-test counseling prior to ordering the testing, consideration of the most appropriate test to order for that woman, and post-test counseling. And it is recommended that a genetic counselor, clinical geneticist, oncologist, surgeon, oncology nurse, or other healthcare professionals with expertise and experience in cancer genetics be involved in any stage whenever possible. So it is basically a teamwork. One person cannot do. They say in our country, low resource setting, generally the oncologist, the treating physician becomes the main. He only will decide what the test to be done. But then in Western countries, developed countries, they have a team. So we are also trying to develop a team. We should try to develop a team, train someone from your department to learn how to do the genetic counseling, to become a genetic counselor, because they are the person who will take a very detailed history and then find out which test has to be ordered. As I've already told, not only the family history, in that while we are asking for the family history, you should ask whether any patient had any genetic test done earlier, whether there is a known gene that is available with the family. Means someone will tell my aunt has been ordered is BRCA1, BRCA2 positive, then you know. So this is the next member of the family, I will get this test done. So that is very important, the family pedigree chart. And that suppose there is consanguinity, as Dr. Fozia was talking about, this a lot of people getting this cancer, genetic cancer in Mauritius because of a small country. Ultimately it is the consanguinity marriage basically. That is important. So there is also, if there is any history of consanguinity marriage between relatives, then there is a chance of genetic disorders. So these are the things we should elaborate in the history. That is very important. So now, as I've already told, risk assessment by the family history and all those things, and any member in the family, or whether there is any risk-reducing surgery was done for any member of the family. So this is way how you find out the risk, do the risk assessment, then pre-test counseling. So, okay, now how to do the pre-test counseling? So now once you have you thought, okay, this is the woman she needs counseling. So first and foremost, you should take a consent from the woman that, okay, we are going for this pre-test counseling, we need to find out, we need to do some test, so that is out. So first is very important, the consent from the woman, from the lady, and then the detailed family history, as I've already told, then detailed medical and surgical history of the other family members. Whether any family, as I was told, any family member had undergone any risk-reducing surgeries, like the risk-reducing salpingo oophorectomy, or risk-reducing hysterectomy, or risk-reducing mastectomy, they may tell that one of my aunt has undergone this test. So you get a clue that, okay, most probably they have something in the family. So in this way, it will give you a clue. Again, you will have to discuss about what are the testing, possible testing modalities that is available, what are the risks involved in the testing, what are the benefits of testing. Benefits of testing means, suppose a woman is tested for BRCA1, BRCA2, now we know that these BRCA1, BRCA2 carriers will have a very good response to cisplatin-based chemotherapy, or they will be PARP inhibitors works in these tumors. So these are the benefits. Then some limitations. All the tests, you do 100 tests, there will be some test where result will come inconclusive. That's very difficult. Then again, you have to counsel this patient before and only. There is a situation when you may not get any result in spite of spending all the money. So that is also important. You should tell them these things, the sensitivity and specificity. All these things has to be discussed with the patient before, ultimately, once everything is convinced, she is convinced, then only you should order the test. Okay, so now another thing is that you should also tell them about the possible management options. Suppose a woman you are counseling and you have discussed and you told her, okay, you need to get this test done. So now if that test comes out positive, what is the implication on her treatment and also on her family member? Now you see, suppose this test is positive, then what are the medicines that can work on her, and what is the impact on the family members? Whether what type of strategy has to be advised for the family member, risk-reducing strategy for the family member. That is important. Again, there will be women who do not want to disclose that to her family members. That also you have to take consent beforehand, whether you want to disclose these things to your family members. Then there are some issues with the insurance. Insurance people, if you know that she is they will not get insured covered. So in the Western countries, there are many here who has coverage for all these things. But in developing country, the insurance people, they will not insure. They will know that she is a high risk here for this cancer, so will not insure. So these are things you should take care. You should discuss with this woman before you really go ahead. And then discuss the cost of testing. That is also important, another factor. And the privacy of genetic information that I've already discussed. So now, what are the selection of genetic tests? So, you know, this actually, I'm not a guy who can tell you in detail. Dr. Jasmine can throw some light maybe. Yeah. So basically, it is said that we do this multi-gene panel testing. This is basically implemented for sequencing only a few genes. You know BRCA1, BRCA2, you know now you do this BRCA1, you write BRCA1, BRCA2. So they do multi-gene panel testing directed. Then you have the whole exome sequencing, all the coding. You know this DNA, they have the coding and the extron and the introns, if I'm correct. So these extrons are basically, these are the coding, they have the DNA material here, and the introns, they do not have anything. So you can do whole exome sequencing, okay? And other one is the whole genome sequencing. So in whole exon sequencing, you may miss out sometimes because there may be some genetic material in this intervening. Yeah. So these things are some intricacies are there. So basically, you should know that either it can be a multi-gene panel testing, or it can be a whole exome sequencing, or whole genome sequencing. These are tests. And what are the ways? You can see that the 3 methods to detect known mutations and 2 methods to detect unknown mutations. The known mutations you can detect by PCR, FISH, microarray, and the unknown can be done by NGS and Sanger sequencing. So it is said that once, suppose you are doing a test by NGS and NGS came out to be positive, it is said that those genes where NGS has said positive has to be reconfirmed with Sanger sequencing. So that is the way. So all the lab where you are doing NGS, they should have this Sanger sequencing facility also. So that is one of the important criteria, the test where it is being done. So now when to order which test, again it depends on the type of cancer, as I have already told, breast cancer, ovarian cancer, BRCA1, BRCA2, and for those endometrial cancer, you know, family history, very important. You know from the family, they have this genetic material here in the family, so you advise accordingly if someone is already told, and also affordable cost. So now, where you need to do the test? If you see the NCCN guideline, they say that test has to be performed in those labs who are CAP accredited and CLIS certified. So that is, they say that is a criteria for doing these tests. So, but in our country also, not many lab has this criteria, but then you should try to see that if you are getting it done from somewhere, it should be CAP accredited and CLIA certified laboratory. That is Clinical Laboratory Improvement Amendments certified. So now, there are some criteria for the lab and also for the test. If it is said that, as I've already told, the lab should have this criteria, the turnaround time. You've sent a sample and the report should come within 4 weeks. So that is the turnaround time, then it is good enough. Then should be quality certified. Technology should be available, what? NGS, Sanger sequencing, and also MLPA. I'll get back to you, what is MLPA. Then all these labs should have a pre and post-test genetic counselor. That is also important. The test criteria, they should have a very less false negative, specificity should be more than 98%, failure rate should be less than 1%, and VUS means variant of undetermined significance. It is a very important thing. I'll come back to that in a while. So it should be less than 6%, and the cost should be around 400 euros. Try to keep it below. So interpretation of the results. As I was told, there are 5 things that may come. Either it may be pathogenic, or it may be likely pathogenic. This is variant of undetermined significance, benign, likely benign. So generally the lab will report these 2. Some lab will report up to this, but no lab will report you as benign or likely benign. Okay? So the thing is that you can get these 3. Out of these 3, you may get a report. So now, what is this? So if it is positive, confirmed by Sanger sequencing. If negative, they do not find anything, then they will do MLPA test, that is multiple ligation probe amplification, to find out any deletion, for large mutation deletion for that. But then even after doing that, they will not tell it is benign. They will not. They will write you pathogenic, like that. Now let's little bit about the uncertain significance. What is this? You know, one is benign, likely benign, other one is pathogenic, likely pathogenic. Variant of undetermined significance means they got a genetic, they have identified some genes which are not yet ascertained whether they are really pathogenic or benign. There is some confusion. So this is a dynamic process. There is a website called CleanVar. they will, suppose you are doing this study and you are putting a patient for testing in these labs, they will keep on tracking those patients, and at one point of time today, which is not a variant of undetermined significance, may at a say 3 years, 5 years down the line, it may become a pathogenic. Because they will see that this is the gene which is found in many women, and they are ultimately becoming malignancy, getting the disease. So they will reassign it as pathogenic. So anybody with a VUS report, they should be always alert. They should be always alert. They should keep on tracking in the CleanVar website that whether my gene has been as a designated. Sometimes they are redesignated as benign also, and sometimes they will redesignate them as malignant, means pathogenic. So accordingly, steps have to be immediately taken. Because for the pathogenic and cyclopathogenic, there is implication of the patient and also the family member, the cascade testing in the family member. But in the variant of undetermined significance, we treat the patient as per a pathogenic, but the cascade testing part is not done for the variant of undetermined significance. So now, if no deletions, germline mutations, it is critical to note that when no deleterious germline mutation is detected in a probe, results should not be directly labeled as negative, and the potential limitations of test should be considered, as I have already told. They will never tell us negative or anything. So what are the possibilities? So some possibilities include the patient has a pathogenic variant in another gene, not included in the multi-gene panel, that the tested gene has a sequence variant that cannot be easily detected by sequence analysis, such as large deletion, and that the patient has a sequence variant in a region such as intron or regulatory region between the intron and exon of a gene that may not be covered by the test. So these are the situations. So now you have done the test, you have got a report, pathogenic, lactopathogenic or VUS. Now again you have to call back that patient and you have to sit with her attendance. So now you have to discuss the result. So that is also important. Who will discuss about the post-test counseling? That also has to be trained, that person. He or she should be well aware of all the reports. What are the possible reports that may come, and with what report, what I'll discuss with the patient. That is also important. So the doctor or counselor should be well versed, as I have already told, about the result and its implications. Sufficient time should be given to address the patient's concern, address the psychological consequences. These patients, there may be psychological trauma to those patients. His whole life now, they have to be under follow-up, strict guidelines, all those things. So you should, before and only, you should make them aware of all those things. And in the post-test counseling, very important, these are things. Interpretation of the result in the context of personal and family history of cancer. Okay, means suppose it is positive, now whether it should be disclosed to the family members, they have to be also tested, and these family members has to undergo these rigorous screening strategies and reducing surgeries if needed. So now recommendations about the medical management option, including screening, lifestyle modification, as I will do these things. Importance of notifying and testing at-risk family members. Told. Available resources such as high-risk clinic, disease-specific support group, and research. Everything has to be there. Suppose you do a test and now you don't know what to do with her. There is no way you can do the risk-reducing strategy. There is no way you can follow those patients. Then it is difficult. If you are doing this test, then you should know that what is coming next. So now the clinical implications and the management of genetic mutations. So now we have done the test. You have done the post-test counseling. Now let us come back to the patient. The patient, what to do with this patient? So now the two things, one is the affected member, means the patient, and unaffected means the family member. So the clinical implications of testing in the affected member is what is different in the primary treatment. Okay? So as far as the BRCA1, BRCA2 mutation is concerned for the ovarian cancer, we know that these are the patients, they will respond good to cisplatin, platinum-based chemotherapy, which is one of the gold standard for treating ovarian cancer. Then in the maintenance, PARP inhibitors will work in these patients better than the other group of patients. And in the recurrent setting, there is a role of, again, there is again role of PARP inhibitors. And in the surgery, they say HIPEC works better in those patients where BRCA1, BRCA2 is positive. In the unaffected member, the importance of screening in those unaffected members, the risk of risk-reducing surgeries, I'll come to these things, and chemo prevention. So now testing, as I told, the two ways. One is germline testing. This is basically for the family member we do, or even the patient, it is done from the blood sample. Somatic testing means the tumor sample. Okay, so from the tumor we will get BRCA1, BRCA2, and here we can also get all these things, RAD51C, RAD51D, PLB2, MMR, and BRIP1. So what is the ideal way? They say parallelly, both should be done. If you cannot do both at a time, then germline first, then somatic. So what is the timing of the test? Ideally at primary surgery. You got a ovarian cancer, you have opened it, you got the ovarian tissue, send it for histopathology. At the same time, you send for this BRCA testing. Now, in NSCT setting, what you do, you can do at diagnosis. One means you have done a two-cut biopsy, then at the same time, you can ask for this BRCA testing. Suppose you have missed, someone has not done that, you have got the patient during interval debulking surgery, then during the NSCT, that time also you can take a tissue and do it, or during the interval debulking surgery, that time also you can get ovarian tissue and do it. So these are regarding the timing of the surgery, anytime, whenever you get, you can do it. So now, what is the implications in hereditary breast ovarian cancer syndrome? As I've already told, a few things I've already discussed, pathogenic, lymphopathogenic. So here, on the patient, prognosis, high response to platinum, increased overall survival and progression-free survival with high PEG. That is also there, and role of PARP inhibitors. Then these patients need to go for cascade testing for the other close family members. And preventive strategy is the risk of ovarian cancer in the family member. If you see BRCA1, 35 to 46%, in the BRCA2, 13 to 23%. In the variant of undetermined significance, as I was told, only the patient is taken as a proband, no role of cascade testing for the family members in the VUS. If later variant classified as I already told, if it is later classified as pathogenic or benign, convey to the patient and relatives and manage accordingly. Benign or likely median, no lab will report as far as this. Okay, so just give you a diagram. This is the patient. This is how you tell. This is the proband. See, you see, her mother also had this. So this is how it goes. Now you know. This tested for germline BRCA2 by NGS, confirmed by Sanger. This will benefit from PARP. So basically interpretation is that this is a part of hereditary breast ovarian cancer syndrome, autosomal dominant inheritance, high penetrance gene. Result is pathogenic. Implication, patient will benefit from PARP, prognostically better. Cascade testing is advised for the other family member. There is a role of risk reducing surgery in the family member. So these are the implications. Now again, index patient, unaffected relative. There is a role of PARP inhibitors. In the cascade testing have done, unaffected relatives. Tested positive for BRCA mutation carrier. What will be done for them? So they can undergo the risk-reducing mastectomy, risk-reducing salpingo oophorectomy. There is a role of chemo prevention. I'll come to these things. There is the role of intensive screening. There is the role of the pre-genetic diagnosis, and there is a role of reproductive and lifestyle modification. I'll discuss these things. Okay, now germline variant detected in, as I was told, blood sample or buccal mucosa. Blood sample is ideally taken because sometimes they say because of the contamination in the buccal mucosa, sometimes there is some fallacy. And tumor variant detected in the tumors and could be somatic or germline, and somatic variant detected in the tumors but not germline. Okay, now, so FDA has approved PARP inhibitors. What are the things that are approved? Niraparib, Olaparib, Rucaparib, these things are approved by FDA if in the case of BRCA1, BRCA2 mutated ovarian cancer patients. This is already there in the NCCN. So if you can just always go back to the NCCN guideline, and you can see that if you are getting a patient with this BRCA mutated patient, then definitely you can work. It works. Okay. So now, regarding the maintenance PARP inhibitors, dose and all those things are already there. You can add it with bevacizumab, and the dose is olaparib 300 mg orally for twice daily. This is generally given for 2 years. Niraparib can be given for 3 years. Olaparib monotherapy can be given for again 2 years, and rucaparib until disease progression. Okay, so these are already there. So now, how do you manage this woman? What are the risk-reducing strategy? That is important, I think. So once the patient is BRCA pathogenic or likely pathogenic, So counsel regarding reproductive desires, extent of cancer risk, degree of protection for breast and ovarian cancer, management of menopausal symptoms, hormone replacement therapy and related medical issues. All these things has to be taken care of. Now let's say about the breast cancer. So these family members, you have to counsel them from the age of 18 years, all this, I should say girl should be should be made aware of the breast lump. The importance of doing a clinical breast examination will start from the age of 25 years, every 6 to 12 months. From 25 years to 29 years, annual breast MRI with contrast or mammogram or individualized based on the family history. If you have a breast cancer diagnosis before the age of 30 years. It is said that suppose they have a family history of a relative where the breast cancer was diagnosed at 28 years, then you should start this before, at least 5 to 10 years before. So now this MRI may not be possible everywhere. So after clinical breast examination, ultrasound can be advised also. At least something you should do. Again, from 30 to 75 years, annual mammogram with consideration of tomosynthesis and breast MRI screening with contrast. So all these things, based on your local availability, you should do. Clinical breast examination is always possible everywhere. Ultrasound may be added. After 75 years, it should be decided by the individual basis. They say the mastectomy by 25 years reduces the breast cancer risk by 90% without bilateral salpingo-oophorectomy, and mastectomy along with bilateral salpingo-oophorectomy reduces the breast cancer risk by 99% if it is done by 25 years. These are some of the things that has come. Now, contralateral prophylactic mastectomy is not recommended in advanced C ovary. Because advanced C ovary, generally the lifespan is very difficult. They do not survive for more than 5 years in almost, more than 50% of the patient will die by 5 years of time. So it is not recommended in advanced C ovary. The chemo prevention, tamoxifen up to 62% reduction in BRCA2 mutated cancer, contralateral breast cancer prevention in advanced breast cancer can be done. So now, what are the management and risk-reducing surgery in BRCA pathogenic glycoprotein variant positive ovarian cancer and endometrial cancer? In ovarian cancer, risk-reducing salpingo-oophorectomy is advised, and it is for BRCA1 mutated by 35 to 40 years. In BRCA2, 40 to 45 years, 5 years later, and in RAD51C, 51D, BRIP1, 45 to 50 years. Other HRD means if the risk is more than 5%, then this risk-reducing salpingo-oophorectomy is advised. But then it is sometimes very difficult. Young patient, if you do salpingo-oophorectomy, you need to take care of the hormones. Whether you need to really you can give hormones or not, all these things, question comes. So some women may not be ready to do a risk-reducing salpingo-oophorectomy at this young age of 35 to 40. So all these things has to be counseled, and then proper decision has to be taken. But it is said that ideally, a risk-reducing salpingo-oophorectomy should be done by 35 to 40 years in case of BRCA1 mutated carrier. And if you do that, not only if it has an impact on the ovarian cancer, but also it reduces the breast cancer risk if you do this risk-reducing salpingo-oophorectomy. But another thing you should tell is that even if you do risk-reducing salpingo-oophorectomy, her risk of ovarian cancer does not is negated by 100%. Up to 96% you can do. There is always a chance of primary peritoneal carcinoma of around 1.8 to 4% in this woman. So that is also that you are undergoing risk-reducing salpingo-oophorectomy, and you told them 100% there will be no. Up to 96% protection is there, but there 4% is always there. So now, patients with risk-reducing salpingo-oophorectomy without. So the patient, I told you, some patients won't, that they won't be liking to go ahead with this risk-reducing salpingo-oophorectomy. What do you do with those patients? There you should do a transvaginal sonography, and CA125 may be considered at the clinician's discretion starting at 30 to 35 years. Generally it is advised yearly. Okay? In some situations 2 yearly also, but then yearly is okay. So, and chemo prevention in a meta-analysis, use of oral contraceptive pill significantly reduces the risk of ovarian cancer by almost 50% for both the carriers of pathogenic and lyclopathogenic BRCA1, BRCA2 variant. When do you do this chemo prevention? This OCP they should be advised to take this OCP prior to the first pregnancy, interval between the pregnancy, and after childbearing, till the risk-reducing salpingo-oophorectomy is done. So now again another thing, that is endometrial cancer, BRCA1, BRCA2, they say that not much, but then still there is some risk of this serous variety, serous uterine carcinomas. But you have to discuss the risk and benefits of concurrent hysterectomy at the time of risk-reducing self-oophorectomy prior to surgery. Suppose the patient has completed a family, you are doing a risk-reducing self-oophorectomy. Sometimes you may you can give them the option, they can do the hysterectomy also. The advantage is that if the hysterectomy is done, then in the hormone replacement therapy, you can use estrogen alone. Otherwise, combine estrogen and progesterone when uterus is left in situ. Now, little bit about the risk-reducing salpingo-oophorectomy in an ovarian cancer susceptible gene. It is said that how do you do this salpingo-oophorectomy? So, decision to carry this is not light given the impact of premature menopause. I have already told, still there is a risk that around 4% of the patient will have this primary peritoneal carcinoma, may have this primary peritoneal carcinoma risk, and then the lifetime risk is more than 10%. Discuss, when do you recommend discussion regarding risk-reducing salpingo whenever any gene that has a risk of more than equal to 10%. So that may be considered. And how do you do the technical considerations? Once you open the abdomen, peritoneal washing has to be taken, anterior ovarian fallopian tube has to be removed. The IP ligament is ligated at 2 centimeters from its insertion into the ovary. The infradopelvic ligament, it should be at least, the ovary is here, it should be at least 2 centimeters away. And once you send you to the histopathology, the pathologist, they will do it at the CFM technique. That is what. So basically, the section is micro section. Okay, so then, and they will do it and they will see whether there is any occult neoplasia in that tube. Then that's why they told that it is now told that the ovarian cancer as such, it develops from the tube, they say. So there is another concept that whether in young patient, whether you will do the tubectomy, salpingectomy first, followed by oophorectomy at a later date, so that she gets some hormone supply. There is also that concept is coming up. Studies are ongoing to see that they are doing the salpingectomy first, and then at a later date they will go for oophorectomy. So this is one. So now this already I have discussed in my last talk. So testing, that is for the BRCA, all those things. For the Lynch, already I have discussed this part. So once Lynch is diagnosed, the cascade testing for the family members. Here comes the role of all those I told you, colonoscopy, then the TVS, endometrial sampling for the endometrial cancer, those things will come. So MSI high, intermediate grade, role of pembrolizumab. What is the implication ultimately? The role of pembrolizumab has come, and here, and if it is a MMR proficient tumors, then there is a role of pembrolizumab plus lenvatinib. So now, Lynch syndrome associated cancer and the risk-reducing surgery, BRCA I have already told. Now Lynch syndrome, what are the things that may come? Colorectal cancer, okay. Risk estimate is around 52 to 82%. The risk is there. So these patients, they should undergo colonoscopy 20 to 25 years, from the age of 20 to 25 years, every year or biannually. And it should be started 2 to 5 years prior to the youngest affected member. Or else 20 to 25 years you should start. Endometrial cancer, there is a risk of around 25 to 60%. Cumulative risk at 80 years is around 54%, as high as 54%, and average age is around 49 years. So initially you should make them aware about the abdominal uterine bleeding. TVS plus minus endometrial biopsy every year biannually from 35 years. Hysterectomy is individualized based on MMR genes. Ovarian cancer, there is a little risk, 4 to 20%. Average is around 46 years. Bilateral salpingo-oophorectomy is individualized. Estrogen replacement therapy is safe. So these are the risks, some of the risk-reducing strategy for Lynch syndrome associated genes. And chemo prevention in Lynch syndrome, I have already told, aspirin 600 milligram once daily for 2 years as per this CAP2 trial. So 3 other rare syndromes to finish my talk. Just one slide each. So germline mutation in the Peutz-Jeghers syndrome in the LKB1 gene or STK11, there will be the pigmented. So that is the importance of whenever you get these patients, you should see them as a whole. They may be a part of any syndrome. Whenever these patients come in a young age, you should always look. So if you see that there is a pigmented lesion on the lips and buccal mucosa, so she may be a part of this Peutz-Jeghers syndrome. So that is also, you should see the patient completely. The breast and gastrointestinal system and gynecological tumors may be there. Risk of sex-cord stromal tumor with annular tubules of the ovary and adenoma malignum of the cervix. This is what comes is constituted by the Peutz-Jeghers syndrome. So what do you do for them? Annual pelvic examination and pap smear starting at age 18, and 1 to 3 yearly transvaginal ultrasonography and CA-125 testing starting at the age of 25 years is recommended. For the Cowden syndrome, germline mutation in the PTEN gene, the hematomas, distinct dermatological changes, and various other malignancies, endometrial cancer risk is around 21 to 28% by 30 to 40 years, one of the major diagnostic criteria. 1 to 2 yearly endometrial biopsy should be offered starting at age 30 to 35 or 5 years earlier than the earliest endometrial cancer in the family. Risk-reducing hysterectomy may be considered. And Lee-Fraumeni syndrome, germline P53 mutations, multiple primary tumor with absence of other physical abnormalities. Gynecological malignancies are not common here, and most frequent gynecological cancer is ovarian cancer. And no ovarian cancer surveillance is recommended for this. So just to finish, options for reproductive age group female. So there are two things: prenatal diagnosis and pre-implantation genetic testing. So prenatal diagnosis, suppose that woman, you know, she has come from that strong family history and she has this mutation carrier and she has come in an early pregnancy, 12 to 16 weeks of gestation. So what do? You take out the amniotic fluid and you culture it, and then you do the chromosomal analysis, and if you see that baby is carrying the genetic here, then you can counsel them for MTP. Other way is that pre-implantation genetic testing. That is, before pre-implantation, you can plan accordingly. You can tell them all this. In this setting, IVF is must. So in the IVF setting, at the embryo stage, 2 cells are taken out from the embryo and they are biopsied, they are tested. If they are affected, only the unaffected embryo is implanted. So this is the way how you go. But then again, there are some ethical issues, the cultural and religious beliefs, socioeconomic factors, all this, availability of technology, all this comes into play ultimately. So these are my references, and thank you so much.
Good afternoon, everyone. I'd like to start by thanking Dr. Paul Rajkumar for inviting me today, and extend the thanks to Merck Foundation for organizing this. I'm going to be talking about how we improve surgical outcome and from a surgeon's perspective. So as we heard from some of the previous speakers, there are several challenges in treating a cancer patient. When it comes to new cases, the projected figures for 2035 are nearly 24 million cancer cases, of which 61% will be in developing nation. When you look at cancer-related death, almost 70% of this will be in developing nation. So considering the problems that we are facing from diagnosis, prevention, pathology, radiology, this is quite a depressing figure. But however, there are things that we can do to improve the outcome. You may be familiar with this Lancet Oncology Commission report, which was published in 2015, which states surgery is essential for global cancer care in all resource settings. Of the millions of cancer cases that are diagnosed, nearly 80% will need some form of surgical intervention once or even more than once. And by 2030, if we look at the surgical burden, we need 45 million surgical procedures worldwide. We don't have the workforce to deliver this. It's only less than 25% of the patients with cancer worldwide actually get safe, affordable, and timely surgery. Historically, surgery was the only treatment for cancer. And despite the advances we've seen in medical and radiation oncology, surgery still is the only modality with the potential to cure most solid organ cancer. In this presentation, I'm going to just focus on solid organ cancer, and I specialize in gastroesophageal cancer, an upper GI surgeon. So most of this is in relation to digestive disease cancer. Surgery is a complex intervention main constituents of a surgical intervention is not just a surgical procedure, which in case of cancer, it has to be tailored to the stage and fitness of the patient. Surgeon with his or her surgical and decision-making skill is important, but beyond that, a lot of the outcome depends on the surgical team, pre and post-operative care, and the pathology. If you ask me to choose one thing, I would say pre and post-operative care and having a good surgical team is crucial to successful outcome. As a surgical oncologist, the role can span from the time of initial diagnosis requiring either open or a surgical biopsy to staging of cancer and treatment and reconstruction, etc. But becoming a surgical oncologist is different. Surgeons must be more than just a technician. With an understanding of biology and the natural history of the disease, knowledge of contribution made by other disciplines in cancer patient treatment, which includes psychology, chemotherapy, radiotherapy, pathology, radiology, etc. A surgeon can no longer work in isolation, but must be leading a multidisciplinary team. And it is at this point that a surgeon becomes a surgical oncologist. A surgeon performing gastrectomy is different from a surgical oncologist performing gastrectomy, simply because a surgical oncologist will have a better understanding of biology and natural history and contribution made by the multidisciplinary team. Here are some examples of how I collaborate with other specialists, working with geneticists in hereditary cancer to optimize treatment, prevention, and screening strategies with breast cancer, colon cancer, as we heard in the last presentation, and genetic gastric cancer with CDH1 gene mutation, which have particular interest. Working with the radiation and medical oncologists on the use of neoadjuvant chemotherapy or radiotherapy to enhance the outcome or to permit surgery. Before operating, I sit down with the radiologist for planning the operation to optimize resection margin, to understand the depth of invasion, and to preserve function and prevent damage to adjacent structure. Working with pathologists pre-operatively and post-operatively for tissue diagnosis, for tumor immunophenotyping and mutation analysis to optimize treatment and to quality assure surgery in terms of surgical resection margin. Otherwise, we would see a high risk of recurrence and failure. If there are any young surgeons or trainees in the audience, I would strongly recommend you to refer to this literature, which is published by the Society of Surgical Oncology and the European Society of Surgical Oncology, publishing a curriculum in surgical oncology. Now, in Africa, in another low-resource setting, you have unique problems and challenges, which I just can't imagine how you are sort of dealing and coping with. Yeah. Here's a snapshot of data which was recently published, an outcome of palliative surgical treatment in context of rising incidence of gastrointestinal cancers in Burkina Faso, Africa. The background of this paper was that digestive cancers are frequently diagnosed late in Africa. And in this paper, they looked at 639 palliative digestive cancer surgery that were performed. And not surprisingly, the majority of the patients, 76%, reported improvement in the quality of life. Now over here, remember, it's palliative surgery. We are not curing the patient. We are not extending the life. We're simply trying to improve the quality of life. The palliative surgery is widely practiced in digestive cancer, and it improves the quality, and African surgeons should be aware and well educated to safely perform surgical palliative procedures. However, apart from surgery and surgical care, there are a lot of things that we can do to improve outcome, and I want to focus a little bit on that. If you look at the core principles of surgical treatment of any cancer, for that matter, what we want is a clear resection margin. Intraoperatively, minimal handling of the tumor and prevent tumor spillage, and anatomical reconstruction of the organ that we are removing the cancer from, so that we can optimize physiological and psychological function of the patient. When it comes to radical surgery, it is only done when the tumor appears to be confined to one area only, and then the entire tumor can be removed with usually with the surrounding lymph node. Because we know carcinogenesis is not a single pathological event. It takes multiple division of cells for a tumor to reach 1 centimeter. So even after radical curative surgery, you can never be sure that you have preoperatively staged and picked up any metastatic disease. Surgically speaking, a curative resection is also referred to as a R0 or a R0 resection, which means the involved tumor and the tumor draining area is removed with no microscopic tumor cells at the resection margin, which a pathologist can tell us once they have analyzed the specimen. A lot of the time, curative resections would fail simply because the staging process, we have missed out micrometastasis. CT scan, for example, can only pick up disease which is 1 centimeter or bigger in size by and large. And it's very easy to miss out micrometastasis in bone, liver, or brain. You can pick up micrometastasis in abdominal peritoneal cavity by simply performing a diagnostic laparoscopy and thereby preventing a major surgical procedure if you find positive cytology in the peritoneal fluid washout or micrometastasis in peritoneum, which are not visible on a scan. So when it comes to planning for surgery, accurate staging staging information is important. But not only that, once you've done that, understanding of the cancer biology and route of spread of that particular cancer in the anatomic location is also important to see what's the preferential mode of spread for that particular cancer. Is it direct invasion, bloodstream, or lymphatic? In advanced cases, you will have all three. But when we are talking about surgery and surgical cure and prolonging the life, it's important to understand the cancer biology. This is, again, just a very broad example of principles of surgical treatment, which is stage dependent, depending on the T stage and the end stage of the disease. Patients with metastatic cancer usually are not offered radical surgery. But for a T1 or a T2 cancer, radical surgery is usually indicated for solid organ cancer with good prognosis, and our aim is to cure the disease. With T3 disease, radical surgery is possible. However, this is almost always combined with combination treatment, chemo or radiotherapy, etc. For T4 disease, radical cure may be possible, but usually palliative. And combination treatment, though used, the aim is to achieve longer disease-free survival. It's unlikely that you will be able to get a full cure. Minimize adverse effect from local recurrence. This is just an example of a T stage of a gastric cancer. As you can see, as the depth of invasion increases, risk of chances of achieving cure are less, and the risk of local recurrence increases when it is T3 or a T4 cancer. Now, what is the role of lymph nodes? There were two theories being proposed. One is the Halstead and Fisher theory. The lymph nodes by Halstead theory state that it functions as stopping the spread of the cancer, as you see in colon cancer, versus the Fisher theory, which states that the lymph node indicate failure of the host defense mechanism, as manifested by systemic spread and metastasis, as you see in breast cancer. Breast cancer, from the time of diagnosis, is almost considered by some as a systemic disease, versus colon cancer, where but these are just simply theories. And again, a good understanding of tumor spread, tumor biology is important to understand the role of lymph nodes and treating lymph nodes surgically. Again, broadly speaking, surgical treatment for node-negative disease, usually no additional treatment is required for node-negative disease or N0. For node-positive disease, depending on which level of nodes are involved, N1, N2, usually combination treatment is targeted for achieving a cure. For more advanced nodal disease, N3 and over, the aim and intention is usually palliative. And similarly for metastatic disease, it's very, very rare that you will be able to downstage the disease. However, with modern chemotherapy and radiotherapy, I have seen, at least in UK, a lot of the M1 disease can be downstaged to T3, N1 or N2 disease and making it resectable. Here's an example taking example of gastric cancer for a radical D2 gastrectomy. Now, gastrectomy, there are different types of gastrectomy, and that's why I started by saying that just being a surgeon and the technician is not important. The D1 gastrectomy is when you remove the gastric tumor with the lymph nodes which are near the stomach. D2 gastrectomy is when you go beyond the stomach, remove the fibrofatty tissue and lymphatic tissue along the major blood vessels. So for a T2 tumor, there's 31% chance that the N2, which are the second level of lymph nodes, are likely to be involved and have micrometastasis. They may not show up on your scan, not on CT scan, not on PET scan. But there's 31%, we know from clinical trials and research data, 31% chance of micrometastasis in level 2 nodes in T2 cancer. When you do radical extended D2 gastrectomy and remove the N2 lymph nodes, you can improve the survival by 15%. And similarly, as the stage advances in T3 tumor, there's 40% chance that you will have micrometastasis in N2 nodes. Therefore, D2 gastrectomy with removing level 2 nodes, you can achieve 10% survival benefit. Therefore, it's important to stage and carry out the appropriate surgical procedure. Otherwise, you will be in a situation where you will have high risk of recurrence of that. When we look at the modern standards of cancer care, surgery alone is no longer the only treatment for most solid malignancy, but a combination of surgery and multimodality therapies, chemotherapy, molecular therapy, and and radiotherapy is involved. Even for R0 resection, where you have removed everything, the biological nature of the cancer and the disease is such that for a T3 cancer and above, you will need multimodality treatment even after a curative resection. Now, surgery, surgical resources, surgical expertise, etc., are not easily available. So what I want to do is focus on some of the non-technical aspects of surgical care that can have major impact in improving surgical outcome of a patient. And what I want to talk about is effect of centralization of specialist cancer surgical care and evidence-based practice and following guidelines. When you centralize specialist cancer care, where you have specialists from every discipline available, tailoring treatment for cancer patients, the treatment is managed by a multidisciplinary team offering multimodality treatment depending on the stage of the disease. And this is evidence-based by following international guidelines on cancer diagnosis and treatment. Here's another example that I want to share. What did we learn from centralizing a different service, which is acute stroke service? I'm using this as an example to show and highlight the benefit of centralizing complex healthcare. In 2010 in England, we centralized acute stroke service. This was a major system change in England. And following centralization of acute stroke service in urban areas, we reduced mortality and length of stay and increased the delivery of evidence-based care. And when I say a major system change, what we did was adopted a hub and a spoke model. Hub is the center, is a specialist center where you provide tertiary care. Whereas a spoke are your multiple satellite units where you can provide primary and secondary care. And overall, you create a hub and a spoke system for managing complex cases to deliver better outcome. Following implementation of acute stroke service in 2012, I was involved in centralization of specialist cancer service in London. This was a network of 12 provider organizations which were commissioned. It took us nearly 3 years to actually implement this. Bladder, prostate, renal, and esophagogastric cancer were the cancer services which were chosen for centralization process. There were different teams set up, consisted of clinicians, managers, different stakeholders for designing and delivery of specialist service using hub and spoke model in cancer care for these cancers. The next thing which I referred to was the guidelines. By developing a multidisciplinary team working in isolation or within a hub and a spoke model, the team usually follows clinical guidelines which are evidence-based practice and published and freely available. Now, there are different guidelines and there's slight variation in treating the same cancer. It doesn't matter which guidelines you pick up and follow. It's important to follow evidence-based practice to improve the outcome. Here's another example, a simple algorithm of what the guidelines say about managing gastric cancer in Europe. It's not just one person taking a decision within the team, the surgeon, the radiologist, the pathologist, oncologist, everybody sits in the team, and patients' preoperative investigations are presented and discussed, and based on the stage of the disease, treatment is tailored for that patient. There are several advances in surgical techniques. Surgery has really transformed in the last few decades. We've seen a rise of minimally invasive or keyhole surgery, robotic surgery, natural orifice surgery, and endoscopic microsurgery. Now, all of this may or may not be necessarily available, but again, Merck Foundation has taken the initiative, and I'd like to thank them for sponsoring some students from Africa to join the minimally invasive surgical training course in Queen Mary University. Hopefully, they will be the champions in future and come and present at this conference about their success story. Moving away from the technical side of the surgery and the surgical outcome, there has been advances in surgical management of a patient as well, with improved understanding of surgical resection margins, biopsying the sentinel node, intraoperative chemo and radiotherapy, and better reconstructive surgery. But again, these are a lot to do with the surgical techniques. What I want to focus on is the enhanced recovery and the program and prehabilitation of the patient. Preoperative risk assessment and preparation is key to having successful outcome in a surgical patient when surgery is indicated. And focusing on physical, nutritional, and mental well-being is, again, crucial. Yes, a lot of the cancer patients will have additional comorbidities that will need optimization, such as hypertension, diabetes, etc. But often the nutritional, mental well-being, and physical functions are sort of neglected, and hence rehabilitation and enhanced recovery as a wholesome package of surgery helps improve outcome. There are several scoring systems available, and you can choose any to assess metabolic function, or there are other predictors of prognostic and recurrence and outcome rate. With rehabilitation enhanced recovery, what do we mean by that? In a surgical patient, particularly those with gastrointestinal tumor, cancer or the cancer-related treatment itself will trigger weight loss and malnutrition. And this can happen even in an overweight or an obese patient. The impact of malnutrition and sarcopenia will significantly increase the postoperative complication and the risk. And this is where the enhanced recovery after surgery protocol comes in handy. Screening for malnutrition should be carried out early, and nutritional therapy and prehabilitation should be started as soon as possible in a patient who's potentially going to undergo surgery following neoadjuvant treatment. Here's a snapshot example of a common preoperative course of a patient who has presented with mild anemia, the hemoglobin of 115, urgently referred for investigation and diagnosis, is found to have a malignant lesion in the stomach. It takes few weeks going through the diagnostic process, staging process, discussion in multidisciplinary team meeting, offering new adjuvant chemotherapy, which is the standard of care for gastric cancer. And by this time, 6 weeks have gone by or so, and you can see the hemoglobin steadily dropping simply because we've not looked at patients' nutritional status. When it comes to the day of operation, the hemoglobin is 9. Technically speaking, the patient is still fit for surgery. We would not operate on a patient with lower hemoglobin, lower than 9. But as you can see, in this case, the surgical outcome could be compromised because of poor nutritional status. Blood transfusion was considered as a negative predicting factor. However, a recent large data set on stage 2, stage 3 gastric cancer, this is sort of more than 2,900 patients, has shown that there is no long-term recurrence-free survival benefit with or without blood transfusion. So anemia should be corrected. Nutritional status of the patient should be improved pre-operatively. When we say prehabilitation, it's an interdisciplinary patient-centric conceptual framework. It has several elements, and it's easy to sort of divide this into like a traffic light: red, yellow, and green. Interventions. So universal intervention is green, targeted intervention is yellow, and specialist intervention is red. Now, prehabilitation and enhanced recovery program are itself a big talk in itself, and there's no way I can cover in this presentation. But just to give you an idea, universal measures include healthy eating, exercise habit, and engaging in surgical school, almost so to say, arranged by local health authority for stopping smoking, alcohol cessation, etc. And compassionate communication, information giving, and general psychological support should be offered to each and every patient. So these are the universal measures of prehabilitation, but they are structured and delivered by a team of specialists. Yellow are the sort of targeted intervention for physical function, nutrition, and well-being, depending on the case. Appropriate preconditioning for rehabilitation should be started in the form of exercise to improve the physical function, nutrition by dietitian and nutrition support team, etc., etc. Similarly, red symptoms, depending on your preoperative patient assessment, you would have specialist intervention to improve physical function, nutrition, and well-being before major surgical intervention. So that was, in brief, prehabilitation, which takes place before any surgical intervention. Enhanced recovery after surgery, even though it says enhanced recovery after surgery, even this journey is part of the prehabilitation and starts before surgery. ERAS refers to patient-centered, evidence-based, multidisciplinary team-developed pathway to reduce patients' surgical stress response, optimize their physiological function, and facilitate recovery. So it starts from home to hospital, back to home again. This again is something that is centered and delivered and developed by a team that includes the patient, the staff, as well as your facility and infrastructure. Here's a snapshot diagram of what is ERAS, pre-hospital phase, with patient and family education, pain management plan, patient optimization, and prehabilitation, and preoperative phase, avoiding prolonged fasting, letting patients have carbohydrate beverage up to 2 hours before the operation, multimodality, medication, regional block placement, and planning discharge and education right from the beginning. So you could go and take these simple measures and implement them in your practice to improve outcome in cancer care. There's a society of ERAS, and the guidelines are again available free on the ERAS the society website if you want to integrate this. This is sort of low cost and improve outcome. Similarly, there are guidelines in nutrition, in surgery, which you can follow and integrate in your practice. Improving outcome, refining in surgical practice will be driven by underlying molecular basis of tumor biology. As we have seen in genetically risk patient at cancer, preemptive surgery in population will reduce the risk of getting cancer. Tissue and function preserving improvements, which is minimally invasive surgery, robotic surgery, as this becomes more and more accessible and cheaper, will improve outcome in surgical patient. However, this again is difficult in low resource setting, and our focus could be on primary prevention and early diagnosis of cancer to improve the outcome. There are, of course, several factors that influence the outcome, which are related to the patient, the healthcare delivery, socioeconomic factors, which I won't go into. But prevention and early diagnosis will have a big impact. This is, again, an example of prevention paper which was published in May 2022, data on future incidence and mortality of gastric cancer from 185 countries, what is projected to happen between 2020 and 2040. This is a population-based modeling study. It's projected that currently we have 1 million cases of gastric cancer. However, by 2040, this will rise by 62%, which is 1.7 million. Preventive measures through eradication of H. pylori infection with a simple prescription of 3 antibiotic combination, behavioral changes such as reducing salt intake, smoking, obesity, and alcohol consumption remain key in controlling gastric cancer incidence. Finally, coming to the last few slides, what I would like to draw your attention to is to this Global Surgery 3. You may have seen this or may have enrolled in this international study. This is a quality and outcome in global cancer surgery protocol for a multi-center international prospective cohort study. Despite the likely increase in risk of mortality and major morbidity for patients undergoing surgery for cancer in low and middle income countries, high quality empirical data are currently unavailable. So this study aims at collecting observational data on breast, gastric, and colorectal cancer mortality and major complication rate at 30 days after a surgery. I'd just like to finish by showing this short video. It's just over a minute. So I would encourage you to register in that study and just look it up. And with that, I would conclude my presentation. Once again, thank you for inviting me and giving me this opportunity to share my experience.
Thank you.
Thank you very much. First of all, I'd like to thank the organizers for inviting me to speak today. I'm extremely honored to be part of your cause. And the other thing which I kind of enjoy, right, looking at different presentations, different methods to treat cancer is scientific and clinical diversity of what we do, right? And yet, right, in this diversity, we have a common aim to treat cancer and potentially to get rid of cancer as a disease, maybe even within our lifetimes, maybe in the next generation or so. So my cause, my presentation will be very different from the previous one, because what I do at Barts is experimental cancer research, right? And many of the facts, many of the graphs that you will see is a kind of open question, right? So it's work in progress, right? And again, doing experimental cancer research and doing this work in progress, right? We need to keep in mind the ultimate goal, why we are doing experiments associated with preclinical cancer research, and why we should keep in mind that the ultimate aim for us is to treat patients, to treat cancer, right? And this is something that we, as experimental biologists and experimental cancer researchers, should keep in mind. So first of all, if you are clinical or medical oncologist working in a lymphoma clinic, most probably you can divide experimental clinical and therapeutic repertoire of leukemia and lymphoma into pre-1997 and post-1997. So again, this is very arbitrary, but 1997 was a year when rituximab was licensed by both Food and Drug Administration and European Medicines Agency, which quite literally, I would say, revolutionized treatment approach to leukemia and lymphoma. And starting from that point, as you can see here, the amount of therapeutic antibodies in development in phase 1, phase 2, phase 3 clinical trials in clinic expanded eightfold, like that, right? And talking about lymphoma and leukemia clinics, so since then we have around 24 approved monoclonal antibodies to treat cancer. Again, this list is very dynamic, and within 2-3 weeks, this can be very different. But what is important to see here is that 16 of these 24 approved monoclonal antibodies are directed to target tumors, so it's something on tumor surface, and indeed, and this is a very large percentage here, 5 target the same antigen, which is CD20. From natural development of B cells, we know that CD20 is something which is there on B cells, including malignant B cells, but is not there in, is not present in pre-B cells, right, and including stem cells, which makes it a very attractive target to play with and to develop more and more highly successful clinically antibodies. So rituximab, as I mentioned, was first licensed in 1997, and early clinical trials and early clinical data were very exciting. And here you can see 2 examples. When rituximab was added to a CHOP chemotherapy regime, which was a standard chemotherapy regime in diffuse large B-cell lymphoma and follicular lymphoma in germinal central lymphomas in overall. And addition of rituximab to CHOP, cyclophosphamide, one of the Vinca alkaloids, doxorubicin, and steroids. So adding rituximab to CHOP chemotherapy regime dramatically increased rate of event-free survival in diffuse large B-cell lymphoma, which historically is a relatively nasty disease, and still we are not quite there to treat it. Again, talking about chronic lymphocytic leukemia, addition of rituximab shooted up response rates for CLL from around 50% to 100%, which these days means that CLL is pretty much controllable disease, and in many cases patients die with this disease rather than from this disease. So rituximab and anti-CD20 antibodies is a quite interesting biological phenomenon, right? Why I'm saying that is that we know that rituximab was licensed in 1997, right? But up until maybe 2010s, 2020s, it was unclear how these antibodies work, right? So which was a very interesting phenomenon. Usually we have preclinical studies, and we study mechanisms that can be targetable, right? And then we develop targets. So, but talking about anti-CD20 antibodies, it was other way around. We knew it worked. It was licensed. Antibodies were licensed, and then experimental biologists started looking at the mechanisms. In general, you can distill anti-CD20 antibodies into three different mechanisms. One is direct cell death via FAP2, via engaging FAP2 fragment of the antibody. Ligation of Fc receptors on macrophages or natural killer cells, which allow to engage immunocompetent cells and destroy tumors indirectly. And the next one is, evolutionarily more ancient mechanism, engaging complement, which is able to lyse target tumor cells directly. So talking about one of the effector mechanisms, which is via Fc receptor, we know that effector cells and immune competent cells are indeed activated or inhibited via Fc gamma receptors. In general, we can divide Fc receptors into two main parts. One is activated Fc receptors, which are good for elimination of tumors, and inhibitory Fc receptors, which prevent activation of immune competent cells, and again can be one of the targets to improve anti-CD20 therapy. So again, if you want to engage immune-competent, secondary immune-competent cells via Fc fragment of antibody engaging one or the other Fc gamma receptors. So there are options available, and one is NK cells, natural killer cells that only express activatory Fc gamma receptors and contribute substantially into antibody-dependent cytotoxicity. Mediated by secondary immune competent cells. In turn, if you look at B cells, including malignant cells, malignant B cells, any germinal central lymphoma, these cells contain only inhibitory Fc gamma receptors, so commonly known as CD32, which indeed is able to inhibit antibody response. So from experimental point of view, it took quite some time. So if you remember, 1997, rituximab was licensed. So this paper by Steve Beers and Mark Cragg was published in 2010 for the first time, establishing that indeed macrophages and macrophages are activated by engaging activatory Fc gamma receptors, and this is one of the main mechanisms of action of anti-CD20 antibodies such as rituximab. So again, so thinking kind of strategically, right? We have a balance, right, between activatory Fc gamma receptors and inhibitory Fc gamma receptors, and strategically, talking about things strategically, what we want to do is to shift this balance towards activatory Fc gamma receptors, and what we want to do is to inhibit inhibitory Fc gamma receptor in order to activate secondary immune competent cells like macrophages, natural killer cells, and which in turn will result in cell clearance. So from clinical perspective, again, looking at shifting this balance, there is still an unmet clinical need, right? And if you look at comparison between fludarabine cyclophosphamide, which is yellow here, and fludarabine cyclophosphamide plus rituximab, which I just received a message that there were issues with internet connection, but it is fine now. So if you want me to repeat or re-record something, you will, I can do that later after this talk. So, but there is still room for improvement, and still, if you look at this time frame, right, still you see that in at least 50% of cases, disease relapses, and the question is, again, remembering what we can do. The question is how we can improve antibody therapy, and ultimately how we can use antibodies in a chemotherapy-free environment, right? So one of the strategic goals that we remind ourselves all the time is how can we remove chemotherapy from the equation at all? It's maybe far, maybe near, but it is a goal. So what can we do to improve antibody responses? So if we go back into history of antibody development, the first thing that you see is that historical timeline of production of different antibodies is pretty much dominated by antibody engineering, right? So from 80s, when first shy attempt to introduce monoclonal antibodies into clinics. One of the first problem that clinicians and experimental biologists, experimental cancer researchers encountered is HAMA, human anti-mouse antibodies developed by humans, right? So which led to production of chimeric antibodies and humanized antibodies with slightly more complex Fc variable fragments. Human antibodies, and again, I will not get into too much of details here for the sake of time, making antibodies better, more specific, and more engaging secondary immune response against tumors. So if you look at CD20 antibodies, and paraphrasing Alice in the Wonderland, so all, no, not Alice in the Wonderland, Orwell, Animal Farm. So all anti-CD20 antibodies are equal, but some of them are more equal than the others, right? And so they can broadly, biologically be divided into two main categories, two main types. One is type 1, or rituximab-like antibodies, and another one is type 2, or tocilizumab-like antibodies. And starting from 2003, again, basing on Mark Craig's papers in early 2000s, who probably did more for antibody biology than anyone else in the world. So he established that type 1 anti-CD20 antibodies are indeed distributed into so-called cholesterol-rich rafts on cell surface, which have major signaling function and due active signaling in cells. And in turn, we have type 2 anti-CD20 antibodies, including B1, which was one of the first anti-CD20 antibody developed experimentally, but didn't really take off in clinic. So type 2 antibodies are located in non-raft fraction, which means that biologically, topologically, these are different, functionally different antibodies, still targeting the same molecule. So two biological mechanisms. Obviously, the question is, one of the questions is which is best and which is better at targeting tumors and eliminating tumors. So we know that type 1 anti-CD20 antibodies do engage complement very nicely and do good complement-dependent cytotoxicity. Indeed, these antibodies, like rituximab is one of the classical type 1 antibodies, have limited impact on direct cell death. But secondarily, they are very good at inducing antibody-dependent cytotoxicity, including NK cells and macrophages. So in turn, type 2 and CD20 antibodies do not engage complement. Indeed, they do induce good programmed cell death and good secondary immune cell recruitment via antibody-dependent cytotoxicity. So by simple logic, if you look at these two lines, what you want to have is as many of these three modalities as possible, right? And looking at type 2 and CD20 antibodies, they are indeed good at inducing cell death and good at secondary immune response. And indeed, if you look at tumor elimination in vivo, in animal models, you see that the amount of B cells is indeed B cell elimination is indeed higher for type 2 anti-CD20 antibodies. In this particular case, it was tocilizumab, also known as B1, and obinutuzumab, which is one of the recent developments. Interestingly enough, so both type 1 and type 2 antibodies do have the same effector mechanism, and the same effector mechanism means macrophages and Fc gamma receptor interactions. So the question is, right, so pretty similar antibodies, both of them have 2 out of 3 modalities which are good. So why are they better? So if you look at the dynamics of binding of rituximab in human cells, B cells, for example, one of the first or B-cell non-Hodgkin lymphoma cells, follicular lymphoma, or diffuse large B-cell lymphoma cells. One of the first things that you see is rapid reduction in surface accessible CD20. Right? So what happens there is internalization of CD20 as a response to ligation, to adding CD20 to the system. Talking about rituximab, you can broadly correlate sensitivity to rituximab with surface accessible CD20 on cell surface, right? So which means that the more cells internalize CD20 from their surface, the less sensitive these cells will be to rituximab. If you try and correlate surface accessible rituximab with Fc gamma receptor 2B, which is one of the inhibitory Fc gamma receptors on surface of B cells. The correlation is non-linear, but reasonably straightforward. And indeed, internalization correlates with, negatively correlates with sensitivity of cells to rituximab, as we see here, but also internalization positively correlates with Fc gamma 2B expression on malignant B cells. And again, you can from experimental biology, experimental cancer research, you can show it by more than one mechanism, including flow cytometry and including confocal microscopy. So from functional perspective, indeed, what we see is that internalization of CD20 inhibits all three branches of antibody effector mechanism, including antibody-dependent cytotoxicity and cell killing by natural killer cells, complement-dependent cytotoxicity, and secondary phagocytosis, again associated with macrophagal function. So the theory here is that this phenomenon indeed can cause resistance of non-Hodgkin lymphoma to rituximab chemotherapy, right? But again, we can do a lot of things preclinically, right? But the ultimate answer to your question that you develop preclinically is how it works in clinic. So, again, back in 2011, Blood, Sean Lim, very talented PhD student at the time, showed that progression-free survival in patients with follicular lymphoma and mantle cell lymphoma indeed correlates with expression of Fc gamma receptors. So for mantle cell lymphoma, as you can see here, Fc gamma receptor to be positive, patients did not do well at all. In turn, Fc gamma receptor to be negative, patients did reasonably well. Right? So highlighting the importance of inhibitory Fc gamma receptors on surface of B cells and malignant B cells. A similar picture was characteristic for follicular lymphoma, where medium and highly expressed Fc gamma receptor patients did really poorly, and negative and low Fc gamma receptor 2B patients still poorly, but much better than the other cohorts. So talking a kind of strategically where we are at the moment, is we have inhibitory Fc gamma receptor to be on surface of B cells, including malignant B cells, and we have activatory Fc gamma receptors on immunocompetent cell surface, right? So if you bind any type 1 anti-CD20 therapy, for example, rituximab, to Fc gamma receptor to be CD20 gets internalized, and it inhibits and limits therapeutic potential of anti-CD20 antibody regardless what dosage you apply. Interestingly enough, type 2 anti-CD20 therapies are not internalized in lymphoma. And if you directly compare some of them, almost all of them, actually, right? This is one of the most obvious things that you see. Right? So again, this is surface accessible CD20. And for CLL, MCL, FL, and diffuse large B-cell lymphoma, we see quite a lot of surface CD20s there if you apply one of the type 2 anti-CD20 antibody, and in turn, the same internalization via Fc gamma receptor 2B happens for type 1. Again, not getting into too much of details, this has been confirmed extensively on the EMU TCL1 mouse model, which is one of the most widely spread model for chronic lymphocytic leukemia. Again, if you compare therapeutic duration of different anti-CD20 antibodies, you see that type 2 anti-CD20 antibodies with international name obinutuzumab is pretty much linear, and therapeutic duration is indeed associated with antibody half-life only, but not with other mechanisms like rituximab, which and Goede and colleagues capitalized on this preclinical finding and indeed show that probability of progression-free survival is indeed higher if you add type 2 anti-CD20 antibody as opposed to type 1 anti-CD20 antibodies. So we know that type 2 anti-CD20 antibodies do outperform type 1 anti-CD20, which is what we need as experimental biology. But again, we can do better, right? And still, the question remains how we can further optimize biologically treatment with anti-CD20 antibodies. We know that tumors can induce changes in microenvironments. We know that tumors per se can alter Fc gamma receptor expression. Right? Tumors adapt all the times, right? And this is why we have first line, second line, third line therapy. Even for antibodies. We know that tumors can reduce activation to inhibitory ratio on macrophages, again, by releasing various cytokines. So at the end of my talk, right, and again, this is work in progress. What I want to share is what kind of strategies can we deploy to overcome deleterious and inhibiting tumor clearance inhibiting effects of Fc gamma receptor 2b. So obviously, logically, the first thing that you might try to do is to block receptor itself on the surface of B cells, indeed, you can apply various phage libraries to design a highly specific anti-human Fc gamma receptor monoclonal antibodies. So, and what you can do then, you can inhibit Fc gamma receptor 2b and then apply type 1 anti-CD20 antibodies or type 2 anti-CD20 antibodies, binding will be direct to CD20, but not to Fc gamma receptor 2b. And indeed, early attempts to do so enabled us to reduce rituximab-induced internalization on chronic lymphocytic leukemia cells in vitro, right? But again, these are all preclinical studies which might or might not translate into clinic, but it doesn't mean that we shouldn't do that. So anti-human Fc gamma receptor 2b antibodies indeed are able to enhance antibody-dependent cytotoxicity via engaging macrophages and phagocytosis through inhibition of CD20 internalization, which is a nice functional readout, by the way, meaning that we are in the right directions there. We might be in the right direction. So similar things happen if you combine rituximab and anti-Fc gamma receptor 2b in normal B cells in vivo. So basically what you can manage to do, again, in highly experimental system, is reduction of circulating B cells, which is a very broad proxy to reduction of B cell tumor burden. At least initially, if you combine anti-human CD32B, which is Fc gamma receptor 2B plus rituximab. So this strategy works at least preclinically. Similar results can be obtained in CLL cells in vivo xenograft models. Again, I will not expand too much here, but what you can do, right, is you can inject CLL cells into immune deficient mice, for example, SCID mice, severe combined immune deficiency syndrome mice. Cells grow there, and then you can, in a clean system, clean experimental system, you can define a biological mechanism of cell clearance. So, indeed, in these cells, we see reduction of CLL cells in spleen if we combine rituximab and Fc gamma receptor 2B antibodies. So, to summarize what I just said, we have two main mechanisms of action, right? So one of them leads to resistance, and another one leads to sensitization, right? And activatory or inhibitory Fc gamma receptors seem to be at the crossroads there. In conclusion, we know that anti-CD20 antibodies deplete tumors through Fc gamma receptor mediated mechanisms, and we know that macrophages are key effectors in preclinical models, and we know that type 2 anti-CD20 antibodies in that sense are better than rituximab because they don't internalize. Still, they internalize to some extent, and what we are trying to do is to figure out mechanism and look for potential ways to influence internalization, right? So which in principle will allow us to even further increase survivability and tumor clearance. So I think that I will stop here. I'm very conscious of time, and I know that some of you might have any questions, and we will use this time to answer any questions you might have.
All right. At this point, we'll go into a Q&A session. I think we'll take maybe 2 or 3 questions because of time. So the questions should be directed to Professor Patel and Dr. Brown.
Professor, good afternoon. Thank you very much for that very high-level topic. In your last statement, you talked about obinutuzumab being better than rituximab. I don't know in which context. Is it in the CLL or DLBCL context? Number one. Number two, CD20 seems to be exhausted in the approaches really targeted. And probably instead of milking it with a lot of different mechanisms to try to prop it up, can't we look for another epitope that we can now look at better? And looking at CD19 and CD22, which are not being exhausted in the BCL, in the B cell lymphoid neoplasm situation.
Yeah, so it's a very good question. I like it a lot. So maybe starting from 1997, right? It's a massive attempts were directed by many universities, many groups about finding the best the best epitope which would be the most stable one, right? And again, talking specifically and only specifically about germinal center lymphomas, which is lymphomas and leukemias. Let's expand it, right? So be it diffuse large B-cell lymphoma or follicular lymphoma, or talking about leukemia, CLL, right? So CD20 seemed to be the most stable. CD19 was tried even before CD20 because it was an obvious target, right? It's everywhere on B cells, and as you know, it is used very widely for CAR T cell therapy, right? But CD19 is notorious for early and very strong internalization. Therefore, even after first treatment with antibodies, we're not talking about CAR T cells here, its effect is lost. So this is one aspect. The other aspect is that CD20, as we know, appears starting from pre-B cells, right? Which means that it is there on germinal lymphoma cells, on normal B cells, but anything which is before that stage of B cell natural development does not contain CD20, which is very convenient because you can eliminate lymphoma, you can eliminate B cells, but normal B cells will regrow, right? And this way you wouldn't have to deal with bone marrow transplantation as well. So talking about exhaustion, right? One of the questions within that context is why there is an exhaustion, right? And talking about internalization, right, is one of the, this might be one of the key mechanisms why we are dealing with the exhaustion of CD20. So yes, I agree with your points a lot. But there is more than one, more than two, more than 5 different factors that we need to take into account for developing future treatment modalities.
Thank you.
I hope this answers your question. If not, then just feel free to write me an email and we can continue this discussion.
We can all see from the screen who is who. I had questions for you, but I think you have answered some of them. So I'm going to just somehow quote a few of the paraphrase the questions so that maybe you can just give us very short statements on each. Firstly, I just want you to elaborate just a little bit more on how instrumental starting the Merck Foundation fellowship programs at Krishna has been. And then maybe also enlighten us on the different types of fellowship programs that you have. And then how those fellowship programs that you're running at KIMS2, how they are benefiting the fellows.
Yeah. Let me tell you, I have told you that when we joined hands, as per the demand of Merck Foundation and the requirements of Merck Foundation Africa requirements, you can say that. We designed around 8 fellowship courses, and we got the permission also from the NMC for all the doctors to train them at KIMS. This is one. And it is not a small number, basically, to start with at KIMS. That's one. And as I directly told you that 5 countries have been benefited out of that. And in near future, we will definitely add many more. So it's going to be an adventure for us because our doctors and our faculty or oncologists, they are also excited. And as I told you that every doctor was so excited to interact with us. So that itself shows that we are going to have definite, positive impact by this scholarship program joining hands with Merck.
All right, thank you so much. I think to everybody who is listening, whether in here or online, you're now able to understand what actually is happening at Krishna. And if you're interested, if you're not already part of Merck, please do join us, apply and join Krishna. They have a lot of offers there. Yeah. They're talking about 8 courses. I think that's good. It's a good start as it is a new it is new into this whole process. Thank you so much.
Yeah,
Dr.
just more to add that other than oncology, we are also training or giving advanced training in cardiology and neurosurgery. Basically, our neurosurgery department is actually most modernized, you can say that. It is of its kind in India, basically. So you can think, I request all of you that in case we can extend our hands in giving advanced training in cardiology and neurosurgery, because my chancellor has specifically told me that yes, we are ready. So just keep in mind the Merck Foundation. Thank you.
Thank you so much. Dr. Paul Kamfwa, a oncologist from Zambia. Please take the mic and introduce yourself.
Thank you so much, and good afternoon, everyone, those who are in person here, and those who have joined us virtually. I'm Paul Kamfwa, a gynecological oncologist from Zambia. At the same time, the coordinator for cervical cancer program in Zambia.
All right, okay, fine. Thank you so much. I think for a start, let's hear from you. What are the challenges in treating gynecological cancers in your country, Zambia?
For the challenges, I think it's better we look at it from the aspect of the building blocks of a health system. Probably that's how I'm going to outline it, and it will be easier almost for everyone to follow through. So, top on the agenda, of course, it's the paucity of health workers in cancer care. And when I talk about cancer care, it's not just limited to gynecological oncologists or surgical oncologists. You'll find that through all the pillars of oncology, be it gynecological, surgical, clinical, or radiation oncology, we do have the paucity, or we do have that deficiency. No wonder even Merck Foundation had to come on board. When we talk about gynecological oncologists, the time that Merck Foundation approached our country in 2017, the only gynecological oncologist we had in the country was from United States, but he has been a resident for 16 years in Zambia, and is the one who was mostly doing the pelvic surgeries, of course with us. He's a professor from University of North Carolina. So prior to going to Tata Memorial Center, we were doing pelvic surgeries with him, but there was no that formal training per se. Until Merck Foundation in 2017 had to approach our country, and apparently I was among the first cohort to go to Tata Memorial Center. Of course, everyone knows that it's a world-class center in India in as far as oncology is concerned. So far, 2 have completed. So I was the first. Later on, there was another colleague of mine who went to Guwahati and under the professor. Apart from that, what has happened is that if we go into, again, surgical oncology, there was nobody who was doing surgical oncology. But during that time, again, an extension was made, of course, for one to be trained in surgical oncology and another in pediatric oncology. So these, in total now, there are about 7 who have been trained. And it's a very good start, especially in those disciplines, pediatric, gyne, and surgical oncology. So that is the paucity of health workers. But when we come to another challenge, it's health financing. If you look at cancer care, it's not an expensive, it's not a cheap thing in as far as the health is concerned. If you look at the drugs, the equipment, everything pertaining to cancer is quite expensive. So when it comes to treating the patients holistically, it becomes a very, very big challenge, especially that most of our patients, they come from the rural areas and the pay is not all that good. So it's quite a big challenge on them. Then the other challenge, I think it has to do with infrastructure. Where we were in India and these other Western countries, you find that there are a lot of cancer centers. But where I'm coming from in our country, we only have one cancer center. And that cancer center is the one that has to do comprehensive surgery, at the same time do radiotherapy and chemotherapy. Yes. Then the other challenge is that of equipment. Like what I mentioned, I wouldn't just want to restrict to gynecologic oncology. If you look at equipment, the one that we have to use for cancer care, particularly pertaining to radiotherapy, whether we are talking about external beam or brachytherapy, the machines are quite expensive. Talk about Linux or Cobalt, those are quite expensive. So you find that more often than not, we do have these breakdowns, and when you have got breakdowns, for you to repair the machines, it takes quite a lot. And of course, the challenge again on the side of medical oncology, it's the drugs. Drugs for cancer, if you talk about chemotherapy, immunotherapy, or targeted or hormonal therapy, it's not that cheap. It's quite expensive. So these are some of the challenges that we have been having in our country. But it doesn't mean that those challenges have just remained like that. Remember, we have found the solution as a country. Like what I talked about on health workforce, we said that the country had to support us so that we could do that. But you know, in life, there comes a time when you grow, because it's not almost everyone will be going to India. So what happened is that we started growing. And how have we grown? So in the country, under the International Gynecologic Cancer Society, IGCS, what happened was that with the collaboration from University of North Carolina plus West Virginia University, we have had mentors now who come 3 times in a year to be with us as local supervisors. They visit our country, and we have started a fellowship under IGCS. It's a 2-year fellowship which is supported by 3 universities, and it has been doing quite well. Apart from that, we have also a bridging which has occurred, a 5-year program now which has been started in Zambia under the University of Zambia, meaning that we know we are not just going to be begging every time outside. It's high time we have matured, we have got the abilities now, and this has been started. Of course, we are having a collaboration from all these partners. When it came to health finance, even if we talked about how expensive cancer treatment is, we are using National Health Insurance Scheme, so that a lot of these patients, even if we are talking about MRI, CT scan, they are catered for. If we talk of surgeries, everything is being paid for that. So that's the beauty that is associated with where I'm coming from. I'm not going to labor on those others, but all those challenges, to tell you, there have been solutions.
Thank you so much. That sounds wonderful. I think you have tackled almost everything that I wanted to get from you just from that response. And I would like to say congratulations to Zambia, because that's a major step. From the time you finished up to now, it seems like you have a lot of things in motion, and we're all celebrating with you. Thank you so much.
You're welcome.
Dr. Muhammad Saleh Baudas. Please introduce yourself.
Thank you very much. Thank you for everyone. Good evening. I am Dr. Muhammad Saleh Baldas from Republic of Chad. Chad is French speaking and Arabic speaking, but I try to speak English as it is going on. I am beneficial of the Merck Foundation Oncology Fellowship Program in 2020. As you know, or most of you know, that Chad is one of the sub-Saharan country in Africa, about 17 million population. Within this population, only about 5,000 medical doctors. And within these doctors, only 100% or 100 specialists. And only 2 medical oncology in my country. One of them is my personnel. And we are have a lot of challenge in Chad to treat patients with cancer. So that after I have been returned to my country, we are established center. There is no center in my country to treat cancer patient. Till now, we are sending a patient to do some investigation in neighbor country like Cameroon, like Egypt or Sudan, because we have not yet established any cancer centers, and we are doing our best to awareness of the patient, and we hope that we can beneficial of a lot of our any others person can be beneficial of this formation, because we are 3 persons on chat. One of them is medical oncologist and 2 nurses, and 1 is a histopathologist only. So that we hope we can beneficial of a lot of what can I say, for the scholarship next time to build healthcare capacity for treat cancer patient, and this is our big challenges in my country.
Thank you so much. Despite not having a cancer center in any particular location within your country, is there any particular service, for example, that you have initiated after completing the fellowship?
Yeah, we have initiated a center or a department in Al-Hariri Hospital, International Hospital, where I work there. It's the private hospital. And we, with other colleagues, we do some investigation. We can awareness the patient. We are doing some treatment, but a lot of things there is no available in my country, like chemotherapies also. It is very expensive. Some patient, as you know, my country is most of the patient is of low socioeconomic status, so that they cannot afford to buy chemotherapies. So that if the patient have been diagnosed, they have no chance. If they are still or they are waiting, they die, or they can, if he has an effort, can be going outside the country, can be treated. So still now, we are doing our effort to do the best for our patient.
Thank you so much, doctor. We wish you all the best.
Thank you very much, and excuse me for my language.
No, you were clear. You were very clear. We now move on to Ghana. May I ask Dr. Salifu to give us your testimony as a Merck scholar and tell us how the fellowship has impacted you.
Good evening, everybody present online and in person. And thank you very much, Merck Foundation, for your continuous invitation to participate in the Luminary activities. So I believe I've said a lot online in the popular Merck Foundation videos, but just to give an update on what my journey has been. Somewhere in 2012, when I was training as a general pediatrician, I expressed interest in pediatric oncology. And the reason that interest came about was because I did a rotation on the pediatric oncology ward, and a lot of the effort we put in for these patients just resulted in deaths. And the reason was that they came in with a lot of advanced disease. And you know what it is, cancer and being advanced, and the fact that they even come in with all sorts of complications, comorbidities and whatnot. And we happen to have a very young and brilliant pediatric oncologist. She trained in Sick Kids, Canada. She had just returned. So I was just wondering why she would put her life in this business when the outcomes are so poor. Then she told me that that is not the story in the world. The story is what we see here. Over there in high-income countries, it's very different. At least 80% of children with cancer could be cured. And then she went on to tell me what the gaps were in our setting. At that moment, I just felt the injustice to these children. At the time, she was the second pediatric oncologist for a population of 25 million, almost 50% of which were children below the age of 18. And you can't change anything with two people in this business. The following day, I told her I wanted to do pediatric oncology, and I didn't know how, because there was no training program in my country. And I actually wondered whether there was any in, that part of Africa, West Africa, if I wanted to do that training. So I mentioned this to her, and the search to find a program for me began. And I was supposed to have completed my training in 2013, that is with general pediatrics. So somehow they managed to get me a slot in South Africa. And it took 2 years, and the paperwork was not completed. Then one time, I was asleep around 10 p.m. when I had a call to wake up and respond to a call from Merck Foundation for applicants. And then I woke up, and that was the deadline. In fact, they woke me up because it was the deadline to submit applications. So I did. I think I even missed the deadline because I finally sent everything in by 1 a.m., the following day. And within 3 days, I had a call that I had been selected. That was in 2016, and I was one of 2 from Africa who were selected to go to India. So I think my arrival in India and whatever happened there could be summed up as a pilgrimage rather than just a training program, because it opened the doors that I could not possibly have had elsewhere. The training was, first of all, India. We could liken some of our economic challenges to India. Patient profiles, demographics, and everything. So you don't go to India and come back to your country feeling like, oh, it's because it's a high-income country, that's why they're able to do these heroic things. No, the story wasn't like that. These are economies that are similar to ours, and as Prof. Banavali showed us this morning, that you can have, flashy cars and then, a cat being pulled by, an animal on the same street. So that's the issues we had to deal with. And so going back home, I just didn't leave with knowledge in pediatric oncology. They taught us how to advocate effectively with data. They taught us how to raise funds, and they use themselves as examples that they came back from the West. In fact, they did some of their training in India, went to the West, added on, came back to use everything they had, but patients could not afford care. And then today he mentioned the Impact Foundation as well. So before I left, they made me sit in the office of the Impact Foundation for 2 weeks to see what they do, so that when I get back home, I don't feel as frustrated as they were. So all these opportunities were there. So I went back home more hungry than I went to India, because I saw it all, and I saw it in a setting where we could actually also make a difference in our country. So when I went back home, I did 1 year in India. Of course, back in Ghana, you can work as a pediatric oncologist, but you are not recognized on paper with 1 year training. So fortunately, Ghana had actually started a program in 2018. So I was the first to enroll in. But of course, when you are leaving, you are just the only one. And so there was the need for more. And whilst I was in India, I heard that a colleague was interested. I think he's sitting here. Yeah. So there was another opportunity. I don't know how to call it, but I was also taught in India how to grab opportunity. And so I sort of mentioned him. And he is actually the first medical oncologist in Ghana after his training, the first, and the only one at present. Also, there was another opportunity for a second pediatric oncologist. He also trained and came back home. So the Ghana College of Physicians and Surgeons started their training. I enrolled in it, and then I completed, and then I set up a pediatric oncology unit in a setting where, well, so we don't have a cancer center in Ghana. So it's usually in general hospitals or general teaching hospitals where you all compete for resources. So when I went to set up, I knew they would feel me and my patients are a burden. And so I decided that I would just look into the corporate society and philanthropists to set up the system. And from what I learned from Madame Shalini and her team at Tata Memorial Hospital, I used that to raise funds. So chemotherapy safety cabinet, all sorts of equipment that we need, all came from private settings, not from government. And none of my patients have ever been referred to the social welfare system because they couldn't afford treatment. And every single patient I have taken in who cannot afford has received treatment all the way to the end. So I'm just trying to say that Tata Memorial Hospital, through Merck Foundation, has given us some kind of training that is so different. It's the training that you don't just sit down and look on and say that, oh, you are waiting for structures to be put in place. You are actually trying to make sure that you are part of the solutions. So we trained nurses. Now there's even a formal training program for pediatric oncology nursing. We've started training pharmacists as well. So all cadres of health workers who are required to be in the setting of pediatric oncology, they are all being trained in country now. And our college even sent some of our fellows to Tata Memorial Hospital just to get some more insights into how to even set up systems, because we have people from other West African countries who don't have any pediatric oncology units. And so they are going to set up from scratch, and they need to know how to do that. So they actually send them to India for 3 to 6 months to see how they can also finish their training and go and set up. So yes, we've made some giant strides thanks to the opportunities that Merck Foundation has given us. And we will forever remain grateful that we have moved giant steps because of the experience we've had. Thank you very much.
Thank you so much. That was wonderful. Wow, I think Ghana has really benefited from this.
Absolutely.
Yes, yes, yes. They have really benefited, and I'm sure Professor Banavali and his team are very excited with this wonderful testimony. We can see that a lot has happened in Ghana following this fellowship, and there are more and more that are benefiting from this. So thanks to Merck Foundation, congratulations to Ghana for the progress.
Thank
Keep
you.
it up. Thank you so much. May we now have a testimony from Senegal?
Thank you. Good evening, everybody. First of all, I think I'll apologize as our fellow from Chad for my English. Coming from a French-speaking country, it will not be as good as yours, but I'll try my best to be understood. I'm Dr. Ndeye Fatou Sow. I'm 30 years old, and I'm from Senegal, which is a small country in West Africa with 16 million inhabitants and only 3 pediatric oncologists, 1 single unit in a general pediatric department in a teaching hospital, and we receive almost 400 children every year treated for cancer for only 3 pediatric oncologists. So I was a general pediatrician before getting the opportunity to be trained by Merck Foundation through the Cancer Access Program at the National Cancer Institute of Cairo University, where I got the master's degree of pediatric oncology. And that had a real impact in our daily lives in Senegal. First of all, it increased the number of pediatric oncologists. We were 3 and now we're 4. I just came back home. It's since maybe the beginning of this year, not even 1 year, and ever since, all the activities had followed one another. Participating in the activities of the Pediatric Oncology Department, which exists for almost 10 years. It's a department that exists for 10 years, but ever since, there is no significant improvement in the treatment of children. We don't have good results. We don't even can assess the results because there is no research, there is no teaching. The 2 specialists that were working there did their training maybe 7 or 8 years ago. And since that time, there is no new people, no fresh improvement, anything. So when I got this opportunity, we all thought to ourselves, why wouldn't we try it? I think this is the occasion because ever since nothing has changed. So maybe now is the moment to try something else because maybe the solution is something else. And indeed, that's what happened. First of all, I think what's more important is the fact that we updated the knowledge. We're using very old protocols, very old working methods, no risk stratification, no standard of care, nothing. And with that new experience that I got from Cairo, I helped a lot in changing a lot of outdated working methods, especially regarding the supportive care and regarding the chemotherapy that we're giving to the children. And another impact we're having right now is regarding the teaching and the research, because the Dakar University, when I came back, welcomed me to participate in the training of students that are specializing in general pediatrics and that are having rotations in pediatric oncology. And that helped us, gave them the basics they need to early diagnose and treat patients across the country, because we only have 1 unit, and those young pediatricians will go everywhere in the country, especially in the rural areas. And before, they didn't get the chance to be taught what they need to know to be able to diagnose early the children. And now that I'm helping them to do that, we can see the results now that it's really helping in early diagnosis and early treatment, and it's of course improving the results we're having regarding childhood cancer in Senegal. And we're also conducting research studies. We just completed the first study about the epidemiology of childhood cancer in Senegal, and that helped us assess the extent of the problem, because without research we cannot know what is exactly the problem. We might have some ideas of it, but nothing concrete. So that study helped us assess the extent of the problem to know exactly from where we should tackle it and what are the strategic points we should address. So that was really, really, really important, and I think it's a chance we got through this program. So thanks to Merck Foundation, because if it wasn't that new experience I got, I think we wouldn't have thought about it. So thank you, Merck Foundation. I think we face all the same challenges, and the impact of the scholarship is really important, both in our social, personal, and professional lives. And I think we could spend the whole night talking about it. But I'll just thank again Merck Foundation for giving me this opportunity and for inviting me here to share my experience with all of you. So thank you.
Wow, thank you so much. And from Senegal, all I hear is quality cancer care. In every statement that you were saying, I was hearing quality. It seems like you're on a path to improve the quality of cancer care within your country.
Yes, definitely.
Yes.
But the problem is still for pediatric patients. We have a lot of stuff for cancer care. I think I have a colleague here, he's a medical oncologist or a surgeon, so I think they have better chances. We have a lot of infrastructure, we have a lot of equipments, but they are not within reach for children. For example, a new cancer center is being built, but it's almost for medical oncology and surgical oncology. Pediatric oncology have a small share in it. Radiotherapy is available for a long time, but children do not benefit from it because we don't have enough trained pediatric radiation specialists, and the few we have are afraid of it. They're not used to treating children. So it's really difficult because we feel like we have things within reach, but we cannot reach it. So that makes it challenging for us. So the quality is not that bad. It's improving, but there's still a lot to do with the pediatric patients. And hopefully we're working on it. I'm a part of a team that is working on a new project. The government is building a new hospital that should be finished in 2024. And there should be a new pediatric oncology unit. I'm supposed to be responsible for it. So we're brainstorming to see how to improve things, to make things better for the future.
Right. We wish you all the best. Thank you so much. And now we move to another country. So like I said before, I'm from Malawi. I would like to introduce the new Malawian doctor from the Gambia. Please introduce yourself and give us your testimony.
Okay, thank you. I am Fatuma Jaito from the Gambia, but now in Malawi, doing residency in orthopedics. I'm sure everyone is looking at me why and how. It's quite a long story. I did a one-year surgical oncology at Tata Memorial Hospital. That was from 2018 to 2019. So I was one of the first beneficiaries to the scholarship. So when it came, nobody knew about it. Nobody wanted to do it. But I decided to take the leap of faith and then went to India to do the surgical oncology. So when I got there, it was good. It was nice. I saw a lot of things. I did more of ortho-oncology. So, and that was what, after doing this fellowship, it's a one-year fellowship, pushed me to do orthopedics because it has never been. So the aim is to finish this and then proceed on, because I've seen a lot of cases that without having the orthopedic background, you can do some of the cases. So where we are as a country, it's the same as every African country, but we're a population of 2 million, but I think we're still behind. But with the Merck Foundation scholarship, we're about now two, one surgical, one medical, who recently finished. But because of this, the first lady, who's actually very interested in oncology, had to tap from some other places so that we could have a cancer institute, which we don't have. We don't have a lot, actually, ranging from the personnels. Now we have only 2. The unit is not there, and then so it's a whole struggle. But because of this, so we have now started building the center, because her point is valid as everyone's point, as in you can't build the capacity just by personnel, so you really need to have infrastructure as well. And then that's going on well. And then we just got our first mammogram in the country to start screening for breast cancers, and then that's actually a big step. So it's all because of the Merck Foundation that has brought all that opportunity to the country, because if it wasn't for that, she wouldn't know, many people wouldn't know, and then we wouldn't be where we are today. So it's, we just want to say thank you to Merck for this opportunity. Because of that, I am where I am today, to make sure we take the country somewhere when it comes to bone cancers. So I want to say thank you to the country as well, because it's through the Office of the First Lady that we got to get the scholarship as well. And then thank you to the team for being here, inviting me, and then to be able to speak. Thank you.
Thank you so much. I'm sure we all came through Ethiopia and will still be going back through Ethiopia. So now, okay, majority of us, I also didn't come through Ethiopia, but the majority of people in here came through Ethiopia and will be returning via the same route. So I would like to take us to Ethiopia. Let's hear from the president of the Pediatric Oncology Society in Ethiopia. Let's hear from him a few words on his experience with Merck Foundation. Thank you so much.
Thank you. Just at the end, it is very difficult to speak. Most of the things have been said, but I'll focus. One thing, I am Dr. Abdulkader Mohammed Said. I am a pediatrician and pediatric oncologist working in Addis Ababa University. And I am the unit head and also the president of Ethiopian, it's not pediatrics, Ethiopian Hemato-Oncology Society. So I was practicing oncology for 7 years before I joined the Merck Foundation Fellowship Program in the University Pediatrics Department as a general pediatrician. In 2017, I joined the Merck Foundation Fellowship Program and completed in December 2018. After going back, during the training, I gained a lot of knowledge and upgraded and my skill, and also I updated my knowledge on the oncology part of pediatrics. Currently, the pediatric hemato-oncology unit has 42 beds, and it is 12 daycare beds and one sedation room for intervention to do bone marrow biopsy and bone marrow aspiration and also milk-guided biopsy. And additionally, we have started MDT for solid tumors as well as for neuro-oncology. And daily, we have a daily clinic on the hemato-oncology clinic. It is a separate area for daily activities. And almost including the new patients, we see around 900 patients per month. And this is a huge number. The number is increasing now. This is on respect to the service, and this training also helped us to increase the training of the fellowship training program in our setup. We have a 2 years fellowship program, pediatrics hemato-oncology. We have 2 graduates. Currently, we have 3 fellows on the training, and we are going to accept the 3 in coming December. So the 3 fellows will be second year fellows, and we'll accept 3 more. So that means we'll have a capacity of 6 fellows to train. At the same time, coming to other activities, we also prepared a guideline for nursing, because the nursing activity is important for the management of the patient. Unless the nurses have skill in managing the patients and following the patients, the outcome will be poor. So we prepared a guideline with the Ministry of Health, with the help of Ministry, and there is Aslam project, and we have now finalized our guideline for training for the nurses. This is in short.
All right, thank you so much. I think coming this far, let me appreciate the panelists all the way from Senegal, Chad, Ghana, the Gambia, Malawi, India, Ethiopia. Thank you so much for taking part in sharing your experiences, how Merck Foundation has impacted you individually, as well as your countries and the various workplaces that you're at.